Thank you, sir. Due to unavoidable personal reasons, Dr. Ranjit Unnikrishnan sir is not able to join us personally, but he will be joining us on Zoom to deliver his lecture. Next, I would like to invite Dr. Jolit Sheth sir to felicitate Dr. Chandan Mohanty sir. Ji, sir. Thank you, sir. Would request Rakesh Luhana sir to welcome Dr. Vikrant Pujari. ठीक है. Then Dr. Janil Gurnani is also. Then Rakesh Luhana sir will welcome Dr. Hitesh Modi. Thank you, sir. I would request Dr. Ankit from our team to welcome Dr. Anil Patil, sir. And finally, last but not least, I would request Yogendra Pundir sir to felicitate and hand over good buddies to Dr. Rakesh Luhana sir. Please. Yes. Yes. Thank you, everyone. So we are starting our program. First of all, the session 1. I would like to request the chairpersons for the session 1, Dr. Jolit Sheth sir, Dr. Hari Menon sir, and Dr. Yogendra Pundir sir. Kindly do the honors. Sir. Excuse me, sorry. Yes. I would request Rakesh Luhana sir to. Sir, one. What is remaining, sir? Sorry, sir. So, वो Janil Gurnani. Yeah. Thank you, everyone. Thank you, sir.
Welcome, all of you. Good
Thank you,
morning. Let's, without wasting any time, and let's kick off the session. Deepak, can we have you on the stage? Yeah, you are going to talk about tubular lumbar discectomy.
Respected chairpersons, Dr. Rakesh Luhana, and the MISSAB team, Dr. Amit Jhala, and all other our associations, I am thankful for inviting me to talk on this topic of tubular retractor discectomy. This surgery allows treatment of most lumbar disc herniations in the central, posterior lateral, and lateral recess locations in minimally invasive manner. And paraspinal approach is being used using successive dilators for docking of tubular retractor through the muscle splitting rather than muscle cutting methods. The preservation of the midline stabilizing structures and musculatures leads to less blood loss, less postoperative pain, and faster recovery in most cases. The incidence of lumbar disc herniation is 5 to 20 cases per 1,000 adults annually, and most common age is 3rd to 5th decade. Male to female ratio is 2:1, and 95% of the disc herniations occurs at L4-5 and L5-S1 levels. This is the slide which is showing the various approaches where the discectomy case one has to use an incision about 1.5 centimeter from the midline. The position of the patients for discectomy is very, very important. We use prone position with the bolsters on the chest and pelvis so that the abdomen remains free to decrease the venous oozing. Face and eyes must be protected well. I usually check vision pre-operative and post-operative cases, as I have heard that in 1 or 2 cases the vision is lost in the after surgery if one checks. So it's better to put it on record that the vision is good pre-operative, and immediately as soon as patient wake up, I examine him for the vision. Neck should be in the neutral position. All pressure points should be well padded. Skin is prepped and draped in standard fashion. We do not use neuromuscular blockade or neuromonitoring. We use ceftriaxone and micacin as pre and perioperative antibiotics. This is the slide which is showing various muscles which are very, very important for the stabilization of the spine. And this is the multifidus, longissimus, and intercostalis. These are very important muscles for stabilizing the spine. The level of the disc is being localized using the needle, which is about 1.5 centimeter from the midline, and the needle should be parallel to the longitudinal axis of the disc space. And once the level has been decided, one can use either a K-wire or a smallest tubular dilator to begin with. One should be very careful in using the K-wire because it has to dock on the bone of the lamina, and one should be very careful not to go too deep, otherwise it can penetrate the ligamentum flavum and can injure the dura also. This is how the dilator are being docked, and at the end we use 20 millimeter size tube for the lumbar discectomy, and here is the self-holding arm which is being used on the opposite side where the surgeon stands. When we work in a very narrow field, one should be very, very careful to locate the anatomical points here, and this is the right side of the tube which is being docked. This is a spinolaminar junction, and this is the facet and ligamentum flavum. This is how the overall positioning of the self-holding arm and tube is seen here. We use microscope for all surgeries, but one can use magnifying loops with headlight or exoscope or endoscope for discectomy. This is a set of the instrument which are very, very essential for this surgery. Majority of the instrument are bayoneted shape or angled, like Carrison punches, various tubes are there. These are the bayoneted shape curettes, and this is serial dilators, and these are the disc forceps. Here I am presenting one case, male 53 years, who slipped on the wet surface before 1 month, and then he started having low backache and pain radiating to the left foot. Patient had a relief of backache with medical management, but his sciatic pain continued. Sphincters were not affected. The neurological examination showed SLR 80 degree on left side, and patient had left EHL weakness and left knee flexion weakness 4 grade by 5. Patient had a diminished sensation to pinprick on the outer aspect of the left foot, and the reflexes were normal. These are the axial T2 images showing a disc herniation here, and at L4-5 on the left side, and we can see that the disc has migrated down behind the body of L5. This is a sagittal image of the patient MRI, and here we can see the disc has coming back on the back of body of L5. The X-rays are being done in flexion extension just to rule out the instability. This is how there is a final docking of the tubular retractor. This very important slide where here we can see that the tube has been docked laterally, which is not the ideal position for discectomy. So the tube has been deviated medially, and this is the correct position of the tubular retractor for the discectomy. This is a video showing the procedure. This is a medial, cranial, and caudal direction. And the muscles are being retracted using the bayoneted monopolar. One need to expose the inferior half of the upper lamina and the base of the spine, that is a spinolamellar junction, and also some part of the ligamentum fleum is being exposed. Proper exposure of the lamina and the base of the spinous process Sorry for the interruption. Here it is not possible to do fast forward, so we'll have to again go through our entire procedure again. So again, this is how the muscles are being retracted from the lamina. Proper exposure is very, very essential, otherwise we need to struggle for the excision of the lamina, and the muscles are coming in the way at times. Now the ligamentum flavum is exposed, and the inferior lamina is being removed using the Carrison punches. The bone removal should be started from medial to lateral aspect, from the spinolamellar junction and laterally. And inferior inferior facet is being excised, medial part, for the proper exposure of the nerve root. The lamina should be removed till the superior insertion of the ligamentum flavum. And now the ligamentum flavum is being dissected from the lateral part of the lamina and the facet, and further bone removal is performed of the lamina and the medial part of the inferior facet. And now the ligamentum flavum is being removed piecemeal. Initially superficial layers are excised, and then one can gain the space between the ligamentum flavum and dura using the dissector. And dura needs to be separated properly from the ligamentum flavum. At times the dura is adherent to the ligamentum flavum and one can injure. So it's very, very important to dissect the dura from the ligamentum flavum, and then the ligamentum flavum excision continues. Here the more muscles are being dissected from the inferior lamina, because we need to expose the disc which is going behind the body of L5. So some portion of the inferior lamina is also removed for the exposure of the disc which is migrated inferiorly. The ligamentum flavum is being continued to be removed piecemeal. And now the dura is exposed, and the nerve root is also being retracted along with the dural tube for the exposure of the posterior longitudinal ligament and disc level. Here we encounter a lot of epidural veins. And one need to cauterize using bipolar so that the bleeding do not interfere at the time of disc removal. The bayoneted nerve root retractor is being inserted between the dura and posterior longitudinal ligament. Few more epidural veins are cauterized using bipolar forceps. And then cut using micro scissors. Now the posterior longitudinal ligament is being incised with 11 number knife in a cruciate manner, and the disc is being dissected using the blunt hook. Sometimes one can use ball tip also for the dissection between the disc and the PLL. And the large disc fragment is removed using disc forceps of various sizes. Some fragments of the disc are being removed from the disc space. As we note that the disc has migrated inferiorly, more posterior longitudinal ligament is cut to expose the inferiorly migrated disc, and we can see the body of L5 there, and the disc is being gradually removed using blunt hook. And as the epidural space is being decompressed, there is an acute bleeding from the epidural veins which were compressed earlier by the disc herniation. Hemostasis is being achieved. Hemostasis is very crucial in discectomy because otherwise it can cause epidural hematoma and pain to the patient. Now hemostasis is being done properly. We usually do not use any flow seal or any substance for controlling the bleeding. And this is the size of the incision. There is a disc which is being removed. This is another case, female 47 years, presented with lower backache and right lower limb radiating pain. And on clinical examination, sensations and power was normal, but SLR was restricted on the right side and right ankle reflex was absent. Sphincters were normal. We can see here the disc at L4-5. Large disc is there, and the traversing nerve root is being pinched, and patient has a pain. It's a sacralized L5. This is an axial image showing the disc herniation here and causing the pressure over the lateral recess also. Here the inferior lamina is being excised using drill, high-speed drill and cutting burr, but one can use diamond burr also. The drilling is performed till inner cortex is reached. And copious irrigation is required for the cooling purpose. Once the inner cortex of the lamina is reached, the ligamentum flavum is dissected from the bone and bone removal is started from the spinolamellar junction till the upper insertion of the ligamentum flavum is reached. And the fat is being popped out epidural area, and now the ligamentum flavum is being dissected from the dura and pushed down. And removed using Carrison punches, and all the time we dissect the ligamentum flavum from the dura to prevent injury to the dura. Sometimes one can use a cottonoid between the ligamentum flavum and dura to protect the dura from injury. Now the dura is seen well, and whatever visible ligamentum flavum is excised as a part of decompression. The medial portion of the inferior facet is excised. We use gel form to control the epidural oozing. The dura and nerve root is retracted and incision is kept on the PLL, and the dissection is performed using the ball tip between the PLL and herniated disc. The disc is being removed piecemeal. It's very important to look around every corner of the area being exposed to remove all fragments of the herniated disc. Otherwise, patient can have a persistence of pain due to residual disc fragment. Every time it's very essential to repeat and dissect the disc from underneath the PLL using blunt hook or ball tip. PLL is further incised to expose the disc space, and more disc fragments are being removed from the disc space. After removal of the most of the disc, we usually irrigate the disc space with saline to remove any loose disc fragments from the disc space. So this is a final picture, and hemostasis is being achieved using small piece of gel foam. And the fascia is sutured after tube removal using 3-0 Vicryl. There is a disc fragment that has been removed. This is another case. Female, 33 years, patient presented with low backache since 2 months and pain radiating to left lower limb, relieved partially with medication. Patient had paresthesia in the left leg and foot since 1 month.
Deepak,
Yes.
we need 5 minutes for question answer.
Yeah.
You've already exceeded your time. You just have another 36 seconds.
Yeah. Okay.
Go ahead.
So I will. So
If it's more of the same,
Yeah.
we can pass on.
Yeah. Now one more video I would like to show. Yeah. In this video, we see a herniated disc fragment inferiorly, and we see there is a difficulty in retracting the root because the large disc fragment is lying in the axilla of the nerve root. So initially, this disc has been removed from the shoulder area of the nerve root. See, there are a lot of difficulty in retracting the root. And now the PLL is and the now large disc fragment is being removed from the axilla of the nerve root. This is a confirmation after removal of the disc. All patients had a complete resolution of the radicular pain post-surgery. This is one video out of interest. We have done it post-operatively, and one can see the amount of bone removal after discectomy, and this is a 3D picture showing small window in the lamina. So advantages of the MISS approach is decreased blood loss, infection rate is low, less soft tissue damage, shortened hospital stay, the pain is reduced, faster recovery time, and less iatrogenic instability. Complications that can occur are the nerve root injury, dural tear with CSF leak, discitis, wound infection, wrong level of surgery may be possible at times, epidural hematoma, and residual disc fragment. Thank you. Thank you for patient hearing.
Thank you, Deepak. Excellent presentation. I leave the thing to the open to the house for whatever questions you want to ask. Yes.
I saw that probably you have used the bipolar and the number 11 knife, the same as we are using in open surgery. I find that it is very difficult to maneuver there. So are there any special designs which you have used, or it is the same one?
It's a bayonet handle.
Yeah, bayonet handle knife is good, but the 11 number blade is too big to maneuver there.
Yeah, one has to be
So
very careful.
are you using anything else,
No,
like a
nothing
micro knife in which we use in brain micro surgery or something?
I use initial 5 mm tip only. Don't insert too much inside.
But then also the whole body of the knife goes there, 11 number. Suppose you maneuver like it may injure the dura.
Yeah, there is
And
a fear.
same thing for bipolar. It doesn't, you cannot get enough space because the bipolar, when you insert in such a small tubular, it gets compressed. It is not the open blade which goes in. You have to close the blade to keep it.
Longitudinal axis, so that it is possible.
So
to
it becomes very
accommodate.
difficult to manage.
Yes,
Is
it
there
is-
any special designs available which we can use?
0.9 mm tip should be all right for most of the
But
cases.
is it available? Because this
Yeah.
I am also using the same and I find it very difficult
It is
to.
available. Even 0.6 millimeter tip bipolar forceps are also available, and that can go inside.
No, something like a Carrison punch design and bipolar at the tip. Something like that, is it
No.
available?
No, not at this time, as far as my knowledge.
Okay, thank you.
Anybody else? Just one comment, Deepak. I've been doing this for now almost 40 years, not tubular, but microdiscectomies. And I don't see much difference except that you are using a tubular retractor with a single blade retractor at the appropriate level. The procedure thereon remains the same. The only comment I would like to make is that I am not as brave as you are regarding the epidural veins. I prefer to, use gel foam and pack them with patties and continue with my surgery. Anyway, if there are any more questions or comments.
Here, I agree with you, Dr. Jhala said, that I have also used hemilaminectomy retread for so many years and did excellent outcome. So even literature says that long-term outcome doesn't make any difference whether you do open discectomy or tubular retractor discectomy. So it doesn't make, and I have seen post-operative cases where there is not much atrophy of the paraspinal muscle with the hemilaminectomy surgery. Long-term results, if we have handled the muscles carefully, had a judicious subperiosteal removal, not use excessive cautery, then the muscle do not get atrophy that often.
The only comment, yes, one more comment I had was that there is a lot of muscle burning, I notice, of course, for your view. And when I said microdiscectomy, actually I learned the really classical microdiscectomy, which I don't do. But originally, Professor Yasargil used to actually turn a flap of the ligamentum flavum towards the midline with a stitch, hold it up, and then remove the disc and then put the flap back. I had learned that, but my impatience or this thing, so I just used to remove the ligamentum flavum like you did. But never did a hemilaminectomy.
Dr. Asargil might want to prevent epidural fibrosis.
Maybe.
That may be one of the reasons.
Maybe.
But at times when it is very thick and compromising the canal, and we are working through a small corridor, it is better to excise ligamentum flavum and provide a good decompression.
I agree with you, in which case if there is a narrow canal, then microdiscectomy would not be the chosen procedure, or the tubular discectomy would not be the chosen procedure. Anyway, thank you very much. Excellent presentation.
Thank you.
Now I invite the next speaker, Dr. Neeraj Vasavda, for Miss Lumbar far lateral discectomy.
Okay, so it's okay if it will. This is hopefully a voice-over video, and it is about L3-4 extraforaminal tubular discectomy again. I'll try to go as fast as I can to cover up the time. Okay. स्क्रीन मिररिंग करो ऊपर से स्क्रीन मिररिंग करो ऊपर से ना स्लाइड નથી वीडियो છે this is direct video, this is not on the slide. PPT में मुझे दो एक मिनट डिस्प्ले प्रेफरेंस મારે જોવું પડશે ને ડબલ મિરરિંગ કરવું પડે ઉભા રહો એક મિનિટ છોડી દો
In the meanwhile, we can take further questions if anyone have for Dr. Deepak. Yeah, Dr. Rakesh. Excellent presentation. What is your tip for a hard disk herniation? Whenever the disc is hard, what is your approach? How do you deal with the hard disk with osteophyte?
I usually use bayoneted osteotome and use a lightweight hammer to break it and then remove piecemeal. I would also like to comment regarding the complications. In the initial few cases, we had two cases of CSF leak. Obvious dural tear and root herniation was there. In both the cases, I converted, removed the dural tube, put hemilaminectomy retractor, and removed the bone, find out the dural edges, and repair it. So, in two cases, then we have not encountered CSF leak much. But in case CSF leak occurs in tubular retractor, nowadays, as I have heard, the instruments are available for repair of the CSF leak through the tubular retractor. And also, if it is a small, one can use a small muscle and put T-cell to control CSF leak.
Yeah, I think Dr. Neeraj is ready with his presentation. Please go ahead.
Sorry for the interruption. Actually, I wanted to play a voiceover video, but I think somewhere there is a problem and it is not running. So we'll directly go to the case detail of this patient. This patient is female of 74 years with acute onset of left front of thigh pain, unable to walk or stand. Even sitting gives intense pain. Failed conservative treatment for more than 15 days. And patients now wanted something to be done about this pain. And if you see this image, there is an extraforaminal disc herniation at L3-4 level here on left side with some up migration which is being seen into the foramen. So we decided to go for a tubular approach for this patient. There are various ways to belt the same cat. It's a classic extraforaminal discectomy. You can use a Wils's approach. You can do tubular discectomy, and the best would be to do a PELD. We were doing this under tubular retractor system. So there are specialized instruments which are required to do this are mainly the tubular retractor set you should be having. You should be having microscope. You should be having a good high frequency CM, and you need a power tool, specifically the Midas Rex bayoneted handpiece, which we use as AA15 handpiece for all our cases. You can do with the loop, but loop is sometimes very difficult in my hand, so I prefer surgical microscope. Docking is classical. You don't go so medial. You are right. I first dock my tubular retractor on the facet, and from facet we walk upwards to reach to the isthmus where the red line is. This is where I would want to dock my tube, so that I can directly, half of my tube will remain on the isthmus and half my tube would be in an extraforaminal area. So that is the tubular docking system for this is under lateral view, and it is right on the disc space. So this is now the video. You can see this is the midline, this is L3 pedicle, this is L4 pedicle, and this is roughly around 1 inch cut. This is slightly larger cut because we wanted to record the video. We use now 16mm tube, and which is 3/4 of an inch incision what we use. So incision is from inferior border of the superior pedicle to the inferior border, superior border of the lower pedicle. Rest of the steps are more or less standard, that you open excise skin, subcutaneous tissue, then go into the dissect dorsolateral fascia. I use this self-retaining mastoid retractor to lift the skin from soft tissue and dissect bluntly till I reach the lumbodorsal fascia and cut with the bowie or a knife the lumbodorsal fascia right in the line of the incision. For orientation, this is right side of the patient, this is left side, this is caudal, and this is the cranial end of the patient. I am standing on the left side of the patient and operating. So once we have used the incision, Rather than K-wire, I think most of the tubular surgeon has done away with K-wire, because as Dr. Deepak sir rightly said, K-wire can migrate into the epidural space and can injure dura. So we use our finger to dissect between the muscle. The another advantage of finger is finger becomes your eye, and you can palpate all the landmarks, and you exactly know where you want to dock your tube before even your first dilator is docked. Sometimes I keep a finger, and at the fingertip I dock my first tubular dilator, and then gradually you put tubular dilators, sequentially goes up, and finally the tube is docked. Various tubes are available, every company has different tubes. Some surgeons would prefer to use expandable tubes, but I think expandable has more muscle damage, and most of the surgeons have now migrated to using a fixed diameter tube. This is around 18 millimeter tube which I am using, and you can see this, this is the final docking on the facet. Soon you will see the facet capsule. There will be some muscle fiber over the capsule. So to identify the capsule, I use a dry gauze piece and try to rub all the remaining fibers away from the capsule. This is absolutely important for me because I want to be sure that I am not damaging capsule. And if you damage capsule, that patient's facet may go into arthritis, and that arthritis may lead to further back pain in future. So this is where I start from my extraforaminal disc herniation. This is my gauze piece, and I'll rub it with a very thin blade, slightly sharp Cobb's elevator, and you will be able to see very clearly the capsule. From here, I'll try to walk over that how I would go. So this is, I have identified the capsule, and then we'll try to dissect the lamina. This is just to reduce the muscle damage as much as I can, and I can get a very clear view. This is L3 lamina. You can see this bone which is getting exposed here. So from there, I'll try to walk upwards to identify the isthmus. Then finally, I'll tilt the tube, walk over the facet to go upward to dock the tube at the right position between the tube pedicles. Half of my tube would be on the isthmus and half of my tube would be into extraforaminal area. And this is how we put a final dilator and try to tilt the tube so that no muscle should come inside. So this is how it would look. You can see this was the facet capsule which we had docked, and then this is the lamina. There will be some muscle fibers which I will have to burn so that I can get a very clear idea, but these are very small muscle fibers, just a layer of small muscle, not too much. And once you have identified all that, sometimes you can even see the mammillary process. And this is the inferior border of the upper pedicle, and here would be the ASAP, and this is your lamina. I'm trying to create a space into extraforaminal area. You can see this is an oval structure or teardrop kind of a structure where superior border is lined by the inferior border of superior pedicle. This is superior border of inferior pedicle, and this is the isthmus. So this much of area I would want to drill off and enter into the extraforaminal area. You can use a diamond headed 3 millimeter burr. So this is final after we have just tried to burn muscle from here only. The rest of the muscles and all soft tissues remain intact. This is where we will start our drilling, and this is the inferior border of the upper pedicle, which you will be able to see with this dissector. You can see this is a bone. So if you just want to visualize the anatomy, the traversing route will be going from here, the exiting route will be coming from here. It will be coming from 10 o'clock to 4 o'clock position, just inferior to this area. This is the pedicle. So it will be somewhere here would be a ganglion of the exiting route, and we want to work in this space because we don't want to disturb ganglion as much as possible. You can use this diamond tip burr to create a kind of an opening here. Now here some surgeons would want to directly go between the intertransverse area even without drilling the isthmus. You can slightly drill the inferior border of the transverse process is L3 and enter into the extraforaminal zone. Somehow my training and I have been comfortable with using some amount of isthmus so that first I can identify ganglion and from there on I can go into the extraforaminal area. The moment you drill off, you will see a foraminal portion of ligament of flavum which you can start removing. I'll try to go slightly faster so that we can cover up the time, because this is nothing but drilling. So this is, you can see the foraminal portion of the ligamentum flavum, and the root will be somewhere right here. So you have to be very careful while drilling around here, and you have to be sure that you keep on irrigating the wound to avoid heat injury from the high speed burst, because high speed burst generates a lot of heat. You can use your Kerrison punch to open the area further. So this is this very sliver amount of bone you need to remove. You don't need to remove too much of bone. This is, we are reflecting the ligamentum flavum. This is flavum which has been reflected. The moment you remove this, you will be able to see the root which is coming from here. You can see this is a ganglion. Ganglion will be exposed. Be very careful that you don't want to manipulate ganglion too much, otherwise some patient may have a post-operative causalgia kind of a thing, because ganglion is a very sensitive structure. Now the upmigrated disc will have pushed the ganglion posterior and superior. So this is the safe area where you have to work around. This is ganglion. This is the safe area, and this will be the area from where you will be able to get the disc. So you have to just imagine that disc has migrated upward, push the ganglia posteriorly and slightly superiorly. So this is the zone where you have to open slightly to expose and to reach to the disc space. So this is the only nervous structure you actually see while going inside. You can use this kind of a foraminal punch to open your foramen and disc area. So this is the area where you will be able to identify your disc. I use a petty or something like a cottonoid just to dissect through the adhesions due to inflammation which has come because of the ruptured fragment. And this is the herniated disc right here. You have to be very careful in retracting ganglion. Make sure that you are not retracting ganglion for too long. Otherwise, again your patient will have a post-operative some amount of ganglion irritation symptoms, and you don't want that. This is the blunt dissection I am doing with cottonoid just to break adhesions around the ganglion and try to identify the disc and ruptured fragment. Once that is done, you can use the standard procedure. You can use a knife to incise the disc space, and again this is just a standard 15 mm or 11 mm blade which we are using under the tube, and then you have to tease out the fragment. And since this is a degenerated spine in an elderly and a migrated disc, most of the time they have multiple fragments, so make sure that you have fished out all the fragments from the disc, otherwise the residual disc may create some kind of post-operative pains to our patient. Make sure that you have removed all the fragment. Try to search for and hunt for the fragment which are hidden somewhere, and most of the time they are anterior to the root or anterior to the ganglion or quite far lateral. So these two places, anterior to the ganglion and very far lateral area, where you will have to search for this fragment, because sometimes you feel that major fragment has come out but small fragment still will be tenting and compressing on the root. So you have to be very careful in fishing out all the fragments. You see that multiple small fragment keeps coming if you hunt for the fragments. So this is the anterior portion. This is far lateral side. My root probe is going in, and you will see that some fragment keeps on coming into the wound. So this is a fragmented kind of a disc. Most of the time it is the case in elderly population, and you have to be very sure that you have removed your root properly. Now at the end of the procedure, you have to be very sure that your ganglion is 360 degree, from all direction it is completely free and it is mobile. You achieve your hemostasis by using a gel form or a cottonoid or a bipolar, whatever way you are comfortable, and make sure that you have made your ganglion completely free. And then when you finally remove your retractor, more or less all muscles just falls back. So this is how the procedure goes. Thank you.
Thank you, Dr. Vasavda.
Thank you, sir.
Excellent presentation.
Thank you, sir.
And I'm sure all of us have learned a lot, got some tips. Any questions? Any queries?
Sir, how to avoid excessive drilling of the isthmus?
So you have to be very sure what tools you are using. So this is 3 mm burr, right? So thickness of the burr is 3 millimeter. So just drill 3 millimeter. If you want to go more, sometimes if it is a very thin isthmus, I have a mental note about how thick the isthmus would be. Sometimes if it is thin, just looking at your CT scan, X-rays, you come to know that this is 5 millimeter, 7 millimeter, 10 millimeter isthmus. So use your burr tip as a guide. Burr tip is 3 millimeter diamond burr which I was using. So one burr width is 3 millimeter. Then if you want to use another, you have to be very sure that your isthmus allows that. So actually for extraforaminal disc herniation, you don't need to drill too much medially. I was just talking to Ravish, if we are doing sometimes paracentral discectomy also from the extraforaminal area in a higher lumbar level. In those cases, I sometimes drill isthmus up to 6 millimeter also, because I want to reach to lateral border of the disc. L1-2, as we know that, we don't go from interlaminar approach. Sometimes we don't want to retract the dura too much. So in those cases, sometimes we go extraforaminal approach, same approach for the disc, but we drill isthmus more. For an classical extraforaminal, sometimes actually you don't need to drill at all the isthmus. You can just drill the transverse process. That's what I said, that some surgeons would want to just drill the transverse process, enter into the extraforaminal zone, identify ganglion and remove the disc. But this is how I am comfortable. I first identify the axialla and then come down.
Thanks. So, excellent talk. Nidhi, this can be approached different way. What I do is, my entry point is 4 centimeter lateral to midline, and you dock quite lateral. You identify
Oblique.
inferior TP,
Yeah.
and then go superiorly, and just take couple of bite. You get into the disc, then take out extra for a sequestrated disc, and then you would see the root. In that case, you don't need to drill much, and then your root would come at the end. You won't retract the root too much. So post-operative discectomy would be less common, I would.
So that is why there are two approaches. One is classical transverse approach, and this is half approach. So I'm somehow since day one I have been doing this way.
Amit,
Thank you.
Amit, please.
I think this is an excellent presentation, whatever you have said, and it's very good for a novice to know the anatomical landmarks and then find out the root, and everything is okay. But I absolutely follow what Rakesh has done. I have a slightly lateral approach compared to what he has shown is the isthmus, so that I directly go into the disc like in PELD. But instead of endoscope, you can just use a smaller tube of 16. The advantage is, as he said, that you don't need to drill much. And if there is associated foraminal component, then also you can access with the help of the forward punches. So that's just a tip that I would like to tell, because in this you have to drill more if there is a foraminal component.
So I guess yes, you might have to drill little bit more, but as I said, I feel somehow more safe using this approach, identifying all the vital structures first and then going into the disc.
And Neeraj, I had one question.
Yes, sir.
Most of our patients do not have such pure disc. Most patients which we encounter, they have central, lateral and far lateral components. So what do you suggest for that when you have to address all three areas?
So this particular approach, that is why somehow I have learned this approach over a period of time. If you have a paracentral disc herniation, then also you can use same approach while doing an extraforaminal discectomy and also paracentral discectomy. But that is the same with what Amit Bhai and Dr. Rakesh said, that you can go in far lateral and then come inside. So I think you can take a paracentral as well as extraforaminal area from the same approach. In my approach, you might have to drill slightly more. In the intertransverse approach, you will have to drill slightly lesser. But you can approach both the case, unless it is pure central disc which cannot be accessed from this extraforaminal area. In those cases, I think better to go from intertransverse approach and then go paracentral classical tubular approach, which Dr. Deepak sir just now demonstrated.
What I want to say is, if you want to do the extraforaminal disc by far lateral approach, by tubular method, then in tubular method it is universal that you have to dock on the bone.
Correct.
So either you have to dock on the transverse process,
yes,
or the lateral part of the isthmus.
Correct.
So everybody wants to say that if you dock on the transverse process, then handling of the nerve root is lesser, which leads to the lesser dysesthesia.
Well, in my
same thing?
I think, I mean, handling of the nerve more or less remains same, that's what I feel. I have used both the approaches, and somewhere, I have been more comfortable with this
Because-
approach. Even if in intertransfers, ultimately you will have to identify the nerve, because without checking your nerve, the 360-degree freedom of your nerve, your procedure is not ended. So ultimately you will have to identify the nerve. Here I am identifying beforehand, and I hardly retract any nerve. In that also, maybe you will see disc herniation first, but somehow, my mind, I was very uncomfortable to put a knife without identifying a neural structure. So that is why I am more comfortable with this approach. But handling of root more or less is same in both the approaches.
Because drilling the half of the isthmus.
No, it is not
will
half.
Directly
It is not half. It is just 3 millimeter. It is not half. My tube is docking on the half of the isthmus. Drilling is not half. Drilling is hardly 3 millimeter. So one burr tip width, which is 3 millimeter.
Because the lesser you drill, the more you land on the nerve.
Not really.
More you drill, then you will.
Not
be more
really. So
stiffer and going towards the
sometimes at lower lumbar level, actually, when you are doing L4-5, L5S1, and you have a very hyperlordotic spine where the foraminal and extraforaminal area is very narrow. In those cases, sometimes you will have to even drill the SAP, the inferior facet also you will have to drill to get adequate exposure just beneath the root. Because as everybody rightly said, you cannot keep on retracting the ganglion there.
Just one comment. I think in all these surgeries, one cannot be dogmatic that this is the way to do it.
Agree.
Also, not all anatomy is same, not all patients are same. So usually you have to tailor your surgery to the requirement. And that's all I have to say. And how much you drill, drill more, drill less, it will depend on the requirement.
Correct.
On the table.
So it's all about, what is your isthmus,
Yeah,
that
yeah,
decides
yeah.
what you do. Thank you so much. Thank you.
And thank you very much, Dr. Vasavada. Wonderful presentation. Where is Dr. Hitesh Modi?
Sir, I am here.
Okay, come on. Acha. He's a traveling neurosurgeon. Ah. Hitesh.
Good morning.
Hitesh, before you start.
Yes, sir.
I was just wondering when I read your thing. Tell us more about your, spine and surgery and all, though we are all aware, but tell us more, what led you to do a MBA or a PhD? What was the...
It was my passion. I am always passionate about reading and studying. So even like I have published around 130 international peer-reviewed journals, papers, and simultaneously I was interested in research work. So I went to South Korea and completed 3-year PhD program for spine and did animal trial on pigs for spinal column shortening and its impact on neuromonitoring as well as on spinal cord blood flow. That paper was actually awarded by SRS as a Russell Hibbs Best Basic Science Award in 2010 Japan. And then during COVID time, I was seeing how the hospitals and other things are being managed in the tough time. That creates interest in me that how to manage all these things and how to understand economics as well as the management structure in a corporate hospital. That stimulated me to go for MBA, and I completed that MBA last year from BITS Pilani.
Oh, excellent. Congratulations.
Thank you, sir.
Congratulations. Gentlemen, we have a genius amongst us. Please start.
Thank you, sir. I am basically belong to Baroda and now practicing in Ahmedabad. And when I started and when I joined Baroda Medical College in 1994, we always see you as one of the iconic person in the field of neurosurgery. And since then, our journey has been started, and ultimately I become spine surgeon and practicing in Ahmedabad, sir. Thank you very much to have wonderful words for us. So I think talk was given to show videos. So I will just, I thank my fellows, Dr. Anson and Navish, who has prepared this video presentation for me. So it is their main work. And so first of all, I would like to share this video about the docking of tubular retractors. I think it's not being played here. Okay. So this is a midline, and I go usually 1.5 or 2 centimeters lateral from the midline where I want to enter. I dock with K-wire and then check under CM if I want to go at L5 S1 level. I just confirm. Then over the K-wire, if I am using 20 millimeter tube, then I just insert the tube over the K-wire in the center, and then I put incision, and then my further process will start. So this is how I measured with a tubular dilator, and go ahead. So I think this video has been shown by Dr. Neeraj Vasavada also in his previous talk. Again, I use blunt wire. Nowadays I am more comfortable with the first dilator. So now I don't use K-wire. Then start this. So because the talk is on lumbar stenosis, so my main intention is to dock on the lamina, and with the help of first dilator, with mediolateral and superior inferior movement, I try to retract some sort of the muscles over the lamina and feel. If I am going too much lateral, then I will be definitely able to palpate the facet joint as well. And this is how I go ahead with the tube. And then I insert the final retractor. This is a 20 millimeter tube. This is specifically helpful if the patient is very, very obese. Like in this, I am using 7 centimeter tube, which is really deep. And if you are doing decompression of lumbar stenosis with only 20 millimeter incision, that is one of the best. So after this, we apply microscope on that and then carry on further surgery. So this is one of the hypothetical case of lumbar canal stenosis. Patient may have symptoms on one leg, and in that case, my approach will be completely different. And if the patient is having bilateral leg pain, then again my approach will take a different course. So let us go one by one. So this is the video showing for unilateral decompression, as this shows that the lamina is over there. So, and on the lateral aspect, this is the lateral, and this is the medial, this is the lateral aspect, this is cranial, and this is caudal, and I am operating on the right side of the patient. So once I dock the tube and I feel the bone is there, then I am very comfortable using diamond tip burr, because I had one complication using cutting burr, and my burr went inside the dura, and I damaged the dura as well as rootlets came out, and I had to open that case. So after that I changed my approach. Even if your hand slips slightly with a cutting burr, you can definitely take out ligamentum flavum or dura. So most of the area I am doing, I thinned out the lamina with the help of diamond tip burr, and once it is done, then I use Carrison Ronger to start from the inferior border of the lamina and start further burring process and decompression process from medial to the lateral side. So as you can see that frequent irrigation always helps. And if you are doing lumbar canal stenosis surgery, you have to do wide decompression, which is very, very essential for such cases. If you can fast forward this video, I think that will be better, because the talk is for 30 minutes. So I have prepared the video according to that time. But, you know, is it possible? It's not possible. नहीं था. Okay. तो क्या खोलूँ? आने बंद करूँ मैं? मिनिमाइज करो. चालू रहे से? Let me. Okay. Then now you can see that with the use of Carrison Ronger, I am going cranially to see the upper edge of ligamentum flavum. I think I need to change the video from the source so that we can move little bit fast. I'll just minimize. So let it go. Just a moment. Done. Okay. So I think we will be able to understand it much better now. So this is how I go proximally. And as we can see, first I go from medial and cranially to see the upper edge of this ligamentum flavum. And once I see upper edge of ligamentum flavum, then my Carrison will start moving on the lateral aspect. So now you can see that I am taking bites on the lateral aspect. If you encounter some sort of bleeding, you can use bone wax to stop that bleeding if it comes from the bony edge. Once this is done, I always try to feel that the ligamentum flavum is free with the use of ball tip probe. Here I can see that complete removal of ligamentum flavum is not done. Then I use bayoneted shape curette to make it free from the upper part and then carry forward the further surgery. So once I retract ligamentum flavum with ball tip probe, I start taking bites of ligamentum flavum with 3 millimeter Carrison Ronger or 4 millimeter Carrison Ronger. Here I think we need to take specific care. When you take bite with Carrison Ronger, you have to cut the ligamentum flavum, not try to pull ligamentum flavum, because sometimes dentate ligaments are adhered to the ligamentum flavum and that can cause dural tear. So you have to always watch dura and then try to cut ligamentum flavum. So once this is done, then I am going on the lateral side and caudal side. So I try to remove the ligamentum flavum. This is the inferior part or the superior margin of the caudal vertebra, caudal lamina. I try to take some bites over that lamina also so that I can decompress the cord or decompress the dura adequately. And now I am moving on the lateral aspect as well as in the foraminal area. So if you are comfortable with the same tube in the same position, you can carry further, or if you want to tilt on the lateral and inferior side, you can definitely tilt that tube. And I always try to preserve the facet joint. If you have to take some of the facet joint, you can take 2 to 3 millimeter of the facet joint on the medial aspect. This is how you can watch the nerve root being decompressed. And at the end, I always try to mobilize the nerve root and try to observe the disc space below. And this is my end point and confirmation that nerve root has been decompressed adequately. If I feel some more pressure coming in the foraminal area, I again try to decompress with 2 millimeter or 3 millimeter Carrison Ronger, and finally I confirm the adequacy of decompression. If the patient is having bilateral leg pain or patient is having severe canal stenosis, tight canal stenosis, then over the top decompression will be a better choice. So this video will show how to do over the top decompression. So I start from the same side, unilateral side. In this case it was on the right side. I start burying the lamina. So this is the inferior, this is the superior side, this is medial, and this is lateral side. So start burying, and then I try to feel where is the inferior laminar edge, and then take some bites. I think this process is the same as we saw on the previous video. So this is done on the ipsilateral side. I can see that there is clear superior edge of this ligamentum flavum. I do some dissection or some decompression on the lateral side, on the same side. Once this is done, I try to feel the adequate decompression on the medial side, on the ipsilateral side with the help of ball tip probe. I see where to go from on the opposite side. Then I change the direction on the opposite side. And now you can see here that this is spinous process as well as it will continue into the lamina on the opposite side. And then I start drilling that part with use of 3 millimeter diamond tip or 5 millimeter diamond tip burr, and I start going on the opposite side. So as I go on burying that spinous process and lamina, it will continue into the inferior articular process. So you have to carry on further, try to palpate, and I am using this dural retractor to see where the dura is, and then I try to use osteotome. So here I am using osteotome on the opposite side. So you can see so I remove the excess bone which is hypertrophied there, and then I will be able to reach to the SAP. So once you remove enough part of opposite side lamina as well as inferior articular process, then you will be able to see the superior articular process, and then you carry on further decompression using 2 millimeter Carrison Ronger on the opposite side. And sometimes you can definitely use osteotome, like in this case, to do adequate decompression. In this case, it was a matter that the canal was 0. So I tried to remove some sort of ligamentum flavum on the medial side to see the dural margins. So I think now you will be able to see that I am removing a part of SAP on the opposite side with help of osteotome and curette. Okay, so this is the inferior side, and some sort of SAP is also being removed from the cranial side. And once this is done, then I can see the dura on the medial side. Here you can see a large hypertrophied ligamentum flavum which being attached on the lateral side or at the SAP. So I am removing some sort of ligamentum flavum on ipsilateral side or on the right side, and finally then I will proceed on the opposite side. So now I am going on the opposite side to remove the hypertrophied ligamentum flavum, as we can see here. As flavum was removed, I can directly approach SAP now and try to see the foraminal area and nerve root on the opposite side. So now I am inserting a Woodson probe. I am going in the foraminal area on the opposite side. And then finally insert the Woodson probe to check the adequacy of foraminal decompression on the opposite side. And I make sure that the opposite side dura is also retracted adequately so that that side decompression is done well. Then again I tilt back my retractor tube on my side and complete the final decompression on my side. So this is how I complete it. And finally I am checking the ipsilateral neural decompression with the use of, this is some part of the facet joint which I have removed, and check the adequacy of foraminal decompression on same side. When I am using Carrison Ronger on my side, I can use 3 mm or 4 mm, but when I am doing decompression on the opposite side, I think I don't use more than 3 mm. 2 mm is enough. If space is adequate, then I use 3 mm. And again check with mobility of the nerve root and complete the procedure that the nerve root is mobilized adequately on same side, and then the procedure is completed. Thank you very much.
Thank you very much, Hitesh. Excellent presentation. It is open to question. Anybody has questions? Or was the presentation so good that there are no questions? Yeah, okay. Amit, go ahead.
Yeah, this is just for the juniors who want. So, do you follow any pattern of doing a decompression? and there are certain patterns that everyone follows. Do
I
you have any
follow
pattern?
I follow my fixed pattern,
Agreed,
which
but
is
every
which is fixed
every
in my
time
brain.
whatever pattern you follow in every case, or
Yeah.
a pattern is different in all the cases.
So, see, case to case is different. So if I have to decompress only one side, unilateral side.
No, for a bilateral decompression.
Bilateral. Yes, so first of all, I see complete ligamentum flavum on my side. Okay, and then tilt the tube on the opposite side. Also tilt the table maybe 10-15 degree so that I can see, I think my tube should see, half of the tube should see the spinous process on the opposite side so that I can do the burring easily. And with the burr, I carry forward to the lamina and inferior
So you are
articular
going
process.
ipsilateral superior,
Yes.
then going contralateral
Contralateral superior, yes. And then follow it
then
downwards.
going contralateral inferior.
Inferior, yes.
Right. But what about the pure inferior? Because that's where sometimes the issue is.
That depends
Because
upon
that
case
was
to
not
case.
shown.
That depends upon case to case. Then you have to dock it on the lateral side. You have to see preoperatively, you have to analyze your MRI, other pictures, and then you have to plan accordingly.
But for me, I feel always I try to remove the superior part of the inferior lamina.
Agree.
Because that's very important. Otherwise, the dura gets bulged up.
So,
and
so
there is
that specifically happens whenever you are removing disc bilaterally. So that will definitely help. Be
It is
helpful.
only for stenosis.
Stenosis. Okay. Rakesh.
That's a very well point raised. There are some patients with operated stenosis decompression come back with residual symptom, and most of the time the residue is at the inferior aspect, like superior aspect of inferior lamina.
Yeah.
So the pattern I follow is, as you said, ipsilateral laminotomy, contralateral upper half,
And
contralateral
then
lower half,
distal half.
then ipsilateral upper, ipsilateral lower, and at the end spinal
Agree.
lower part of your ligamentum flavum, basically.
So
the
basic-
pattern changes
yeah.
whenever there is ipsilateral disc. Whenever there
yeah.
is huge disc, you have to decompress ipsilateral discectomy and then go
And then
opposite side.
contralateral.
Otherwise, the dural tear chances would be higher when you go on opposite.
So basic idea is like you have to confirm that all routes are free. Yeah, so on both the sides and specifically on the opposite side. Yes, please, sir.
One more question. How about how much spinous process of inferior level you have to tackle to reach the contralateral inferior angle?
So inferiorly what happens that spinous process will continue with the interspinous ligament. Okay.
Do you need
So
to drill or you can?
you will be definitely able to see that inferior half is reached. How much proximally you need to go, that depends. But my usual technique is that I used a wide MIS osteotome, and it should definitely cover at least 1.5 width of the osteotome. So that roughly like 10 or 12 or 15 millimeter size. So that should be enough, I think, for the decompression.
You said that you are using the osteotome from the opposite side. Is there any advantage of this, that you need to drill less, or you are saving some time and
yeah,
energy?
I
and
can-
what size osteotome you are trying to use it?
My osteotome is around 10 millimeter size, but I also keep 5 millimeter osteotome and 3 millimeter osteotome. But they are not the MIS osteotome, they are the similar small straightforward osteotome. For 10 millimeter, I am using by Medtronic, which is actually designed for MIS surgeries. So, and the purpose of using osteotome and burr is to save time and my energy, because in tight canal stenosis, if you want to take Carrison ronger and do decompression, it is very, very tedious job. And using
Is
this
it that
osteotome,
sole reason that you want to same, or when you want to take a big bite of that side, the 3 or 4 mm of bite which is going in that corridor on the recess is causing injury to the nerve root.
on the
To
opposite,
prevent that, you are doing that
Yeah.
using osteotome.
so while you are doing decompression on the opposite side, using 3 millimeter Carrison ronger is also a big ronger. So it is better to use osteotome that can definitely prevent neural injury. You have pointed, your point is very well taken.
Hello. Do you drill the upper border of the lower lamina? Because I feel that if we don't drill the upper border of the lower lamina for the single level canal stenosis, the exiting route is not fully decompressed.
So I usually take bite with Carries and Ronger rather than drilling the upper border of
Just
lower
bite
lamina.
only, but
yeah,
in your tubular
usually.
retractor, is it visible?
Yeah, it's visible, definitely visible. You have to take that bite because the ligamentum flavum attachment should be removed and you have to take at least 2 millimeter bites. That's better to decompress
I would
the nerve.
like to differ from all other present.
Okay.
Initially, I used to do with tubular retractor. Now I use a conventional retractor because I found of two reasons. One is muscles coming in between. Second, slightly inadequate decompression. And third, logically speaking, if you cauterize the muscles, then you are, the whole aim of using tubular retractor is to decrease back pain. Otherwise, if we preserve the spinous process, everything else remains the same. Initially, I observed that causing less muscle trauma is more important to prevent back pain than type of instruments used. Of course, I don't have any study or like that, but...
yes, can you hear me, Takesh bhai?
Hello? So, my question is really, does tubular retractor, so I'm basically challenging the whole concept of tubular retractor, but does it really makes a difference that, or does it that we want to use a tubular retractor and then we are doing
Hello.
this?
There are few studies published that tubular retractors will have like the studies regarding some, I think, blood markers, and they says that the muscle damage is less. But it depends how you use your tubular retractors. If you are using very haphazardly and taking out so much muscles,
Recording
then
stopped.
it is same. Yeah, thank you. Yes, Ranjit.
Hello. Hitesh, can you hear me?
Yes, yes.
Good morning, all. Sorry to be not being there in person. Thanks, Rakesh bhai and the entire team, MISSAB. I just want to add a point to what was discussed with Amit bhai and Hitesh. So my strategy in these cases is, before my surgery, I know what, am I going to do a discectomy or am I just going to do a canal decompression? So the cases where I have to do a discectomy, I do ipsilateral first. Ipsilateral first, take out the disc and then go to the opposite side. So in cases where I'm not planning a discectomy, I do contralateral first. Contralateral first, then do the ipsilateral. The reason is, as mentioned by Rakesh, so whenever in a central broad-based disc with a tight canal, where the entire stenosis is contributed by the flavum and the facet, when you try to do a discectomy first or do the IPSI first, there is more chance of dural injuries. So in those cases, I go to the contralateral first, do the quadrant 3, quadrant 4, then come to quadrant 2, as Amit bhai mentioned, and then go to quadrant 1. If I'm doing a discectomy, it is quadrant 2, quadrant 1, then quadrant 3, quadrant 4. I hope it is added to the point, Hitesh.
Yeah. Neeraj has to say something.
I'm sorry, the tubular concept somebody challenged. So I agree. See, in a long run, I totally would agree. The way what you do, maybe you may do a tubular discectomy, you may do endoscopic decompression, you may do conventional microdiscectomy, retractor, and do over the top. Everything result-wise, it is more or less same. What I don't agree to the comment made by them is, muscle damage. We only remove very sliver of muscle, which we as such do in our classical microdiscectomy approach. And inadequate decompression doesn't happen because a tubular retractor is not fixed. It keeps on rotating to various quadrants, as Ranjit mentioned. When you are operating on quadrant 1, you tilt your tube. Then, when you go opposite side, again you tilt your tube. When you remove inferior lamina, you again tilt your tube. So it's a 360-degree rotation of the tube, which helps you to decompress it thoroughly. So result-wise, it may not be much difference in any of this technique, but when you think about, probably I take tubular retractor as a first step to go for further advanced tubular minimal invasive procedures where it does make differences.
So I just add to it that for a micro discectomy or a tubular discectomy, it does not make much of a difference whether you are doing an open micro discectomy or a tubular discectomy. But as you go to the higher decompressions, like in multi-levels, if you do a stenosis or if you do a TLIFs, then there is a definite advantage of a tubular. So it all depends on how higher grade of decompressions, multi-levels you are doing or not. And there it makes a lot of a difference.
I would like to thank all the speakers and the chairpersons of this session 1 for teaching us all the techniques and crux of MIS decompression. Now I would like to request the chairpersons to hand over a memento to our speakers. Firstly, Dr. Joli Sheth sir, to Dr. Deepak Patel sir. Hari Menon sir will present a memento to Neeraj Vasavda sir. That's why, sir. And requesting Pundir sir to present memento to Hitesh Modi sir. थोड़ा बच्चे चलो center. Just a small note for all the delegates, we are not breaking this session. We are starting the second session, but whoever wants a tea or coffee can have it from the food counter and enjoy on their tables. We would start the session 2. I would like to invite the chairpersons for second session, Dr. Amay Patankar sir, Chandan Mohanty sir, and Anil Patil sir. Please sir, join us sir. You may start, sir. Yeah. Sir. Yeah.
So, without wasting any time, I would request Dr. Ranjit Unnikrishnan to start with his presentation on MIS TLIF.
Good morning, Chandan sir, and the entire team. Can you see my screen? Chandan, can you see my screen?
Yes, yes.
Okay, at the outset, thank you very much, Rakesh and the entire MISSAB team at Ahmedabad, at Baroda, for inviting me. And apologies, I could not be present in person due to a personal emergency at home. So we will discuss this minimally invasive transforaminal lumbar interbody fusion step by step, and you can stop me at any particular step you need further clarification, because we have got nearly 50 minutes, as Rakesh has told me. So we'll try to get it threadbare right from setup and the indication. So we'll start with the case. He was a 49-year-old male manual laborer, back pain and left leg pain for quite a long time, with a near normal neuro exam, with a right SLR at 50, and had the typical round of physical therapy, pain medications, had no sustained relief. And these were his X-rays. He had multi-level degeneration with probably a developmental stenosis with a short pedicle at L4, L5. The typical case scenario where you get more of back pain and equivalent leg pain with a facetal tropism. And this was the MRI showing a large contained disc, the typical ones which give a lot of back and leg pain over the time. And this was his MRI showing severe bilateral stenosis and causing his back and leg pain. So he had a round of transforaminal root block. He had temporary pain relief for a couple of weeks, had persistent back pain, at which point we offered him surgery, foraminotomy and a fusion. So what should we see in the preoperative X-rays when we plan this surgery? Number one, apart from the levels, we should look at the level of the iliac crest. We should know at what level is the upper border or the line, the transcrystal line when you draw where it crosses across, so you can plan your levels and position accordingly. One point to note in these cases is that if you're planning an L5S1, L5S1, as we know, typically is at an angle. So if I can go back, if you look at this X-ray, if you have to do an L5S1, you have to make, your line goes across like this. So in those patients, what I do typically is to take the patient on a Mayfield frame and I give significant head high. I tilt the head so high that I try to get the disc nearly vertical so that I can, my working angle becomes more vertical than at an oblique. It also helps me to orient my microscope properly. So this is what should see in this X-ray. And when we plan the surgery, remember, even today, I consent all my patients that if I cannot do it MIS, I will open. It's always consented. I seldom have to convert it to open, but I always see that I get it. I get the consent for an open procedure. And even though I'm planning a fusion, I always see for dynamic views, not to assess my index level, to look at my adjacent levels for any subtle instability which I'm missing. And in case of degen scoliosis, I see for the correctably at the convex bending to know that will I be able to correct it by doing a single or a two-level fusions. Today, if I have to go more than 2 levels, I go for an OLIF. I don't go for an MIS TLIF for purely convenience sake. Now, when we position the patient, you can use your choice, use bolsters or frame. I use a Wilson's frame. And make sure you get good AP and lateral CM images. There is no TLIF or no MIS procedure without getting good AP and lateral. That is why I consent the patient that if I am not getting good images for whatever reason, I will open you up. The next step is localization and guide wire placement, and then incision and serial dilatation. We'll see it step by step. So it is typical for me to get these patients. So it is not that truncal obesity which matters. It is the muscularity which matters. So it's very typical for me to get these patients who are very obese, huge, and who I plan in MIS TLIF. So when I get them in, and if I get this kind of picture, I think twice. Can I first see, can I try to improve my image by getting a better exposure or something by positioning? If I don't get a good image, I don't proceed further with MIS because that is a disaster if you don't get good images. A typical OT setup. So if I always approach from the site of the pathology. So if the patient's got right-sided leg pain, I stand on the right side. If patient's got a left-sided pathology, I stand on the left side. And always opposite to me is the image intensifier so that it becomes easy for me to see. So we will go through the key steps of a MIS TLIF procedure. The first step is contralateral pedicle cannulation and guide wire placement. Next is docking the tube or the retract system, whichever you are comfortable with. 3 is decompression, wherein total fasciectomy and ipsilateral root decompression. 4th is discectomy, end blade preparation and cage insertion. Next is contralateral on over the top decompression. This need not be done in every case. So any patient with a bilateral leg pain who complains preoperative symptoms, I do over the top. A patient does not complain bilateral symptoms, but patient has got bilateral up-down stenosis on the MRI. I rely on indirect decompression by expanding the discal height. Next is ipsilateral screw insertion and compression. These are the 6 steps of MIS TLIF surgery. Now, first step is contralateral guide wire placement. So this I am doing the right side, so I put the left side guide wires inside. So a point to note is that when you keep these guide wires, unlike in a normal MIS pedicle fixation case, you have to keep them away. You really bend them away on the edge to the ends of the patient, because remember, you have to have a retractor coming up like this. So you don't want it to compromise your access. So I make sure I bend them really away, and I use nitinol wires. I don't use the stainless steel wires, because nitinol wires are the ones which are very malleable. They've got shape memory, and they don't tend to break so much. So I use them, and this is how you mark them. And next, what I do is, before I go, I draw this line. I draw the lateral pedicular or the mid pedicular line, depending upon which is my site of interest. So a place where I already planned the over-the-top decompression, I go to the medial pedicular line or mid pedicular line. If I'm doing only ipsilateral, I draw this line. This is drawn on the APCR. I draw the lateral pedicular line. Once that is done, then our next step is docking. So I follow a slightly unconventional technique of docking. So when I dock, I first take the largest dilator which I'm planning. So if I'm using a tube, it's a 23 millimeter tube, or the quadrant, it is 23 millimeters. So I just mark it across my site of interest, make a skin impression. After I make a skin impression, I cut the skin and the fascia to the same cut. Then I put my finger inside, and I use my finger as the dilator. I don't use the serial dilators to start, because I find it much more easy. With my finger, I go and feel the spinous process. I feel the interlaminar space, and I dilate using my finger. I'll show a short clip of that. So first, I am marking my skin incision. You can see my guide was placed across. It is bent across. I make my skin incision, and I use a knife and take a cut. This cut cuts the skin and the fascia. At the length of it is the same size of the tube. Then I use my finger, and with my finger I dilate. And if I feel the fascia is tight, I put the knife again inside. I cut the fascia longer than the skin, because that is where all those pain which was discussed earlier comes if you try to go and stretch it up. Then I use, after with my finger, I do all the dissection with my finger. Then I put the first dilator, and this dilator sits on the spinous process or the spinolaminar line. And then gradually I put the serial dilators. Remember, these dilators are inserted so that I can put my retractor blades. They are not used to dilate the muscle. The muscle is dilated with my finger. After this, then I attach the retractor. In this case, I'm using the Medtronic quadrant system. So we should remember that the retractor is placed opposite to you, not on your side. It is opposite to you. And since I'm a right-hand dominant surgeon, I have a retractor coming from my right side up. Right side up, so that it does not come in the way of my C-arm. The retractor arm should be placed in such a way that when you take a lateral shoot, the arm should not come across your field of vision. So this is how it comes, and keeping it across in this case, I think I come on the left side based on convenience. Today I try to keep on the right side. Next are the decompression steps. Remember, since just because you're doing a MIS surgery, no way are you compromising your decompression. No way. You have to do the same decompression or better what you do with an open surgery. So typically, as Harms has mentioned, the way we do is first we take out the inferior articular process. Next, we take out the superior articular process. This is the one which I mentioned. When you draw your docking site, it's around the 3 centimeters or 4 centimeters from the midline, based on the lateral pedicular line or mid pedicular line, as the case may be. Once you dock your tube, this is the first vision you get. You see I'll just show this illustration, then show a quick video. So then you see the inferior articular process. Next, this is my site of osteotomy of the inferior articular process, and I typically use the burr to cut. Remember, I use the burr like an osteotome, not the burr like a burr, because I knock this off and I take that piece as my bone graft. I don't burr out and make the whole bone into powder because I need this bone. So I make a transverse cut here, make a vertical cut here, and that bore I use a 2 millimeter cutting at that stage, 2 millimeter cutting, and that is my part of my bone graft. Once I do that, I see the superior articular process cartilage. There I identify the pedicle. I put my love here and feel the upper border of my pedicle. Once I know that, then I take a transverse cut across that, and again I harvest that as my bone graft. At which point I'll see the lateral border of the flavum, which I remove piecemeal, and then I expose the Cambin strangle, where we see the lateral border of the sac with the root, we see the exiting root, and we see the disc. I'll show this on the video step by step. So expecting that there'll be people who are just getting exposed for the first time, just showing some illustration. And then we do the annulotomy, do the discectomy, piecemeal discectomy. And once that is cleared, then I go to my next stage of graft preparation and cage insertion. I have no separate MIS cages or MIS instruments. I use the same open cages, open instruments for doing an MIS surgery. The only MIS thing I use is the screws. Earlier I was using conventional screws. Now I've gone back to the MIS. Rest all is open surgery. Other than the retractor, there is no investment involved for doing an MIS surgery. So again, like the way we do conventionally, I put all the graft first inside the disc space, which is prepared. And if the graft is remaining, then I put graft inside the cage. Many times I end up putting all the graft in the disc space and nothing inside the cage. The cage is just used as a spacer. So this is how the cage goes in. I use a conventional cage. And then once we have the cage inside, then I go to the opposite side, over the top decompression. Now the question is, how do you reach the opposite side? Chandan, am I going fast or should I go slow?
No, that's fine. Go ahead. You carry on.
Okay, sure.
I'll let you know.
Yeah. So then next, so once we have finished the ipsilateral quadrant 1, quadrant 2, now we decide how to go to the opposite side. So the way to go up to the opposite side is by a series of use of your table tilting and microscope tilting. So this is how you would see conventionally the ipsilateral quadrant 1, quadrant 2 when you're doing an ipsilateral decompression. So when I have to go to the opposite side, that is quadrant 3, quadrant 4, I tilt the table significantly. That is why I take all my patients when I do a TLIF, I take them on the frame because I'm more comfortable tilting them on the Wilson frame than on the bolster. And very extremely obese patients, I keep a lateral support so the patient does not tilt off the table. This is seldom required if you're using a quadrant frame. And I also use a Mayfield for all my patients because I'm more comfortable with that when I'm especially doing an L5S1. And so look at this series of steps. How do you go to the opposite side? So you tilt the microscope. Next, number 2, you tilt the patient. Number 3, this is how you get your vision. This is how you can go to the opposite side, quadrant 3, quadrant 4, when you have to do a over-the-top decompression. Now, once you reach there, you will remove again the midline edge of the flavum. You will burr off the base of the spinous process here. So first, once you tilt the tube, you'll be seeing the midline flavum here, like we saw in the previous illustration. We remove it piecemeal. Then you go and drill the base of the spinous process, and then you will do the opposite side. So this we will see a video. I'll pause where I feel I have to stop. So there the video starts. So this is the medial side. This is the cranial side. I'm standing on the right of the patient. So you have to use a long bipolar. Now this is my transverse cut of the inferior articular process. The way I mentioned, I use it across like an osteotome. I cut it off, right, and then I remove these. I use a keratine and remove this bone. Now I am cutting across the inferior articular process transversely, and I use again. I cut it across, come up to the lateral bottom, and you can see I made a notch. At this point, I use a 5 mm osteotome, like what Hitesh Bhai mentioned, and knock off that, and use that big chunk of bone to prepare my bone graft. So I have two large chunks of facet joints, and at this point, you see the bleeding. Don't cauterize. I'll pause here. Don't cauterize. So it's a reflex sensation for us to go and try to cauterize this. Don't cauterize because you have not seen the roots well. In this image, if you see, this is my exiting root at the upper right corner, and this is my lateral border of the dura along with my my traversing root. So, but still, don't cauterize. Next, the question is, what do? Just put a patty there. Just put a patty there, pack it up. Don't cauterize anything there unless you see the roots very well, because it's a network of epidural venous plexus there. Plus, we are dealing with a stenotic or a pathology which has changed the anatomy there. Don't go and cauterize there. Just pack it up. It always stops. And once I go and remove the quadrant 2 or remove the lateral recess better, and then I slowly remove part of the flavum. Once I see it, then I'm using my bipolar and I'm cauterizing the epidural venous plexus. Now I'm exposing the base, I'm exposing the disc very well. Remember, at no point I'm using a retractor here. I don't use a retractor. The thing on my left hand is a suction retractor. My rationale is that the root is angry and inflamed. You pull on it, patient gets more post-op dysthesias. We are going much lateral. So I tried to avoid it. Now I'm doing a annulotomy. I'm using a box annulotomy. Remember, I can just go back for a while and again emphasize the point. When you start doing annulotomy, use the knife facing outside, and you dip the knife inside the annulus, then cut, so that even accidentally, if you slip, you don't hit the dura or anything. You don't hit the dura. So you go inside, cut off a box, you do a classical box annulotomy, then you do a piecemeal discectomy. Remember, I'm not retracting the root at any point of time. I can see the lateral border of the exiting and the traversing, the middle border of the exiting and the lateral border traversing root. I am doing a piecemeal discectomy, and I spend a lot of time here. And now I'm using the end plate shavers. You can see the white anterior annulus very well in this image. And then sorry. So, yeah. So you remove again discectomy there. You can, I take all the time and prepare the end plate, use keratins, disc rongers. I'm using a straight keratin. You can see that. I'm not using any angle keratin. It's very easy to do it with a straight instrument. You don't really have to have all those really angulated ones. So here I'm using the shaver and removing my end plate. And you can see the anterior annulus white shiny piece. Next, after I do that, then I take in my shavers. You can see I'm using my sizers. Here at this point, I try not to use a root retractor. So I serially dilate. I'm using the regular straight one. And then when I have to put in the cage, I use a root retractor and ask my associate or assistant to retract it. I'm using a conventional cage. You can see this. I'm using a thick, I always use a kidney cage or a so-called TLIF banana cage. I don't use a straight bullet-shaped cage. And after that, you have, I finished. Now I'm going to the opposite side over the top. You can see I've tilted. Now you can see the medial lateral edge of the flavum. I'm removing it piecemeal, remove the flavum. Then I'm drilling the base of the superior articular process, and wherein I expose more of the flavum. Then you can see I'm going to the lateral side. I've seen that quadrant 4 now. I've seen the opposite exiting and traversing root, and that has completed my decompression of the opposite side. And after this, I remove the retractor, and then we have, I put my ipsilateral screws. So remember, a technical tip to remember in this step is that you don't have to always use the muscular window which you used to do your decompression to put your screw. I repeat, you don't have to always use the muscular window which you created here to put the screw, because if you do that, you might cause a lot of skin tenting. So what I do is that I forget that I put my jamshidi or my bark needle through another muscular window into the lateral border of the of my pedicle axis, and then I through this I place both my guide wires, and this is where I have got my cage placed well anteriorly, because in this case so whenever I have to recreate a bit of lordosis, I try to place my cage more anterior, so the cage is more anterior, and then I have my screws going inside. I have done my screws, ipsilateral screws. Then I put the contractor screws, and then the last step, that is compression. I compress the screw heads and try to recreate the lordosis. Remember, any single level fusion you do is the most important surgery for that patient to prevent adjacent segment degeneration. I repeat, every single level fusion you do for any patient with any pathology is the most important step to prevent that patient's adjacent segment degeneration. If you don't respect the PI minus LL balance or imbalance, or in a patient with a fallen sacrum or a very high pelvic incident, you try and decrease the lordosis by doing a straight fusion at single level, you can be ensured that after 10 or 12 years, he'll come back to you with adjacent segment disease, depending on how lucky you and he is. I can tell with my own long-term bad results. So make sure that you really recreate the lordosis. The tip to remember in this step is that once you put in your screws, when you start compressing, don't look at the screw heads to measure your gap, because remember, you're using polyaxial screws. Your screws might angulate, and it might not create intradiscal compression or lordosis. So look at the screw heads. Look at the part just below your montage. You see look at the space. Look at the right image. Once I compress, I want that to be closer. I want that to be closer, and hence, thus recreate my lordosis, not my screw heads. And this is the final wound. So these are my guide wire wounds for 4 and 5, and this is my hole for my decompression, as well as to put my screws through this. And this is the final image of this patient of L45 MIS TLIF. All my goals of surgery has been achieved. I've got ipsilateral decompression. I've put my cage center. I've got contralateral decompression. I've compressed it and recreate the lordosis as much as I could. Now, to conclude, patient selection is the key. Plan to complete and complete the plan. Please remember, key to the surgery is not the size of the incision. It is achieving what you have visioned and doing it. Do not compromise on root decompression and end plate preparation because you have decided to do an MIS. If in trouble, if you're having some torrential bleed, or you've got a dural tear which you are not comfortable managing, convert to open. You don't lose anything. And remember, this is here to stay. We cannot go out today. Any surgery which I have to plan a degen surgery, first my thought process is, can I do it MIS? Is it single, multi, whatever level? Thank you very much, Rakesh Bhai and team, and I'm open to questions. I think we have enough time for questions.
Hello. Very nice presentation. Yes. Can you show me the pre-op side once again, please? Sagittal and axial. Pre-op MRI.
Pre-op MRI.
Yeah.
Are you seeing this? Are you seeing my?
No.
Are you seeing the screen?
No.
Are you seeing the screen?
Screen we are seeing, yes, but no picture on that. Just dark screen. Yeah.
Okay. Just.
Pre-op. Yes.
Yeah.
This one and the axial. Next one. Okay. So, why did you decide to fix this in this case? Is there any instability in this?
Back pain. Yeah, back pain and leg pain. Manual laborer.
Yes, but I don't see any instability in this. So leg pain would be cured by a discectomy, and back pain is not always due to instability. So
Yeah.
I would have done a
my
microdiscectomy in this case.
Yeah, so I've got disasters in manual laborers in these patients with large central contained disc having long time back pain and leg pain. So I do a discectomy in this patient, they come back to me after 6 months, 1 year, because they are manual labor. My idea is not the kind of surgery I do for them.
No, come
My
back with
idea is
what?
to get them
Come back with recurrent
long-standing
disc?
pain relief.
No, come back with
Recurrent back pain.
Recurrent
Back pain, frequent back pain, because back pain, yeah. So I practice in coastal Kerala where I got a lot of fishermen, a lot of fishermen who are thick, like this, thick and muscular and heavy. So these people are the ones whom, even if they have only leg pain, I first try not to operate, because I do a discectomy for them, they come back. I mean, today I do endoscopy for them, but they come back with residual back pain. So these patients, I try, if I offer a surgery, I try to make it the most sustaining surgery, which is a fusion for me in that subgroup. If you look at the NAS guidelines, one of the indications for primary fusion is manual labor. So these protracted, long-standing back pain with leg pain, I chose today not to just do a discectomy for them, especially with these kind of developmental stenosis. If you look at the X-ray, if you look at the X-ray to them, you can see that they've got short pedicles. You can see short pedicles. These are the ones which come back to me in my subset of patients with disastrous results in the long term. Immediately they are fine, absolutely fine for 6 months, 1 year, 2 years. Then they start coming back.
But even after 6 months, they can have an adjacent level disease, they can have an adjacent level disc problem. So
that's what. So when you respect your lordosis, when you respect your PMI imbalance, there is less chance of adjacent segment disease in these patients. So it will come if you go and if you go and jack up the space and give focal kyphosis.
So here we put a full stop. Don't open the Pandora box, because Ranjit want to say that he has addressed the degenerated bad disc disease by the fusion. Now whether it can be addressed without fusion only by decompression or not, that can be a big debate, but we stop this discussion for this question that this was indicated fusion for badly degenerated disc of a laborer who has to work throughout his life, and there are very high chances that he will come back and sit on your head in coming future in 2 or 3 years with a severe backache or the recurrence of the disease. So he decided to go for the fusion. That's all.
Okay. Ranjit, excellent
Next
talk.
question.
Yeah. Anytime you do put a screw first, distract, and then do a decompression, like this is an open disc. Anyway, what do you do for collapsed disc? Any change in plan?
So Rakesh, it's a very good question. I stopped doing it because my rationale for that is that when I put a screw on the opposite side and distract, I'm creating focal kyphosis, right? Any collapsed disc, I am confident of opening it up with serial dilatation. And I believe that when you try to do a distraction, you're creating non-physiologic focal kyphosis there. Whereas if I'm going to use a disc shaver and gradually distract and try to recreate the lordosis there. Number two, in porotic patients, I don't want to load the screws by giving distraction. Number three, when I put a distractor across, I try to distract across, I try to go and put huge cages which are non-physiologic at that level. Now I gives me a lot of space there. I keep on putting thicker cages, and I end up not being able to recreate lordosis. I cannot compress well when I put a very thick cage. So today I try and limit it by 9, 10, 11. I don't go more than 12 in Indian patients. So which I can safely do with my shavers gradually. So I used to do it initial part probably 8, 10 years ago. Today I stopped. I don't use any distraction against his space. Even in severely collapsed disc patients, I can very well happily use my serial shavers and use my dilator. It's like OLIF, where we use the shavers to open up the space. I apply the same logic here.
And any
The same logic here, I use,
yeah. Yeah, any chances of end plate fracture, especially in osteoporotic, like?
Yeah, so yes.
So rather I will put the question in this way that, what are the tricks to prevent the end plate fracture and injury to the exiting nerve root? Because putting these cages might lead both, that is the step where these two important complications are seen. One is exiting nerve root injury while putting the cage, and another one is forcible expansion of the disc space leading to the end plate fracture.
Number one, sir, the most important thing to prevent the exiting root injury to seat properly. I don't go ahead with my annulotomy unless I visualize the exiting root very well. And where I see the space is narrow, I try to remove more of bone, more of lamina and flavum, make sure I see it better than before I go inside. Next step, in cases where there is a acute and exiting root exit, I mean, it is not at 5S1, it's at higher level, 3, 4, 2, 3. I try and use a root retractor, not at the dura level, but at the exiting root level, especially at the stage of end plate preparation and cage insertion. So I know my sites of where I can cause damage based on my prior experience. So when I feel that my shavers are going inside, I make sure I see them well before I go inside. Next, I use a retractor to keep the root away when I try to shove in my shavers and my trials and my final implantation. Next, to prevent end plate fracture, in very porotic patients, say elderly, multi-level degens, I don't do TLIFs. I go for OLIFs because there's lesser chance of end plate fracture because you're putting a cage which sits on the periphery and not at the center. Number two, other point is to prevent aggressive discectomy using huge sharp shavers. Do very serially and have a feel of the end plate when do it. Number three is not to shove in large cages. Remember, even in large cage, Dexam 3.5 plus, you get end plate fractures and cage settling. So it's a feel. You get the feel. You go by the feel. That's again why I don't use the question which Dr. Rakesh answered. Why don't I use distractions? Because cases where I've distracted, I put in big cages. Over time, they settle and they fracture because of the poor end plate. Did it answer the question?
Yes.
Did it answer the question?
Yes, I got all the messages except that in this case you have shown a very high disc, large disc space where the Cambin strangle is also wide and the space you are getting put the work is a larger one. But when the disc space is significantly collapsed and you have to go for the fusion, then the exiting nerve root is almost sitting on the osteophyte or end plate of your superior vertebral body. How do you tackle that?
So there again, I visualize the root properly. Whatever is keeping me on the way, I decompress it. I do the microsurgical decompression there, make sure that my root is free, and then use a root retractor. I use a root retractor there and keep my root away. So typically, what I face is that whenever you do the exiting root decompression, well, you see the dorsal root ganglion. So if wherever I go and meddle with the dorsal root ganglion, then those are the patients who have got more of post-operative dysthesias. It's not about deficit, they get dysthesias. So typically I want to discharge all my TLIF patients second day home. So I do TLIF today, tomorrow they have to go home. That's my goal. They will not go home if I mess with the dorsal root ganglion. They will stay. No, sir, because anybody will not go because my pain is not gone, I will not go. So the way I measure my root handling is the way patient goes home on day one. Patient goes on day one means I have done my job safely. And also I use post-operative ropivacaine, I give parafacial block and all those things to keep the post-op pain less and let them go home.
Reverse way, I am asking the question that how frequently you fail to put the cage and accept that you just put the bone grafts and come out. Does it happen?
Oh, sir, that's a good question. That, yes, of course happens. That's a pre-op decision for me. It is not an intra-op decision. Pre-operative when my disc space is less than 6 millimeter. This typically happens to me when I do a long segment fusions, not essentially an MIS TLIF. when I do a long segment fusion for a degen scoli or something at L5S1, if the disc space is less than 6 millimeter, I don't attempt to put any cage inside because number one, the smallest cage I have is 8 millimeter. There is increased incidence of cage back out when the cage size is less than 9 millimeters. Number three, I cannot put a lordotic cage at L5S1 in those collapse spaces. So those spaces, I try and just, if I try not to open up the space if required. If I end up opening it, I put graft. I put graft, not a cage. So never it has happened at say 3-4 or 2-3 where I plan for a TLIF MIS bar open and I have not been able to put a cage. Then I try to think back at myself. What did it go wrong in my pre-op analysis as to why I could not place a cage? It doesn't happen.
So as a corollary, what you are saying is that you don't use expandable cages, right?
Never. I'm totally against expandable cages. Totally I'm against it. Because you cannot jack up something and try to re-kid low doses and let it sit on the end plate and let it heal there. No. You can create, why do you use expandable? To create space. You have to create space mechanically, directly. Use the larger cages. Next, you create lordosis by doing a fasciectomy and lordosing, shortening the posterior column, not by jacking up the anterior column. You jack up the anterior column, you are putting it against an end plate which might be soft, which might collapse. You're adding that extra cost to the patient for no reason. It's absolutely unphysiological and it's purely industry-driven bull. It's not at all rational. There's enough papers published. It is all bull. Now there are many people who put up the jack cages. It works. It does not.
Absolutely agree.
Hello.
Yeah, Ranjan.
Yes, sir.
Last question.
Yeah. Any incidents of pseudoarthrosis in TLIF in your practice, and how do we prevent?
Yeah.
And how do we manage?
Yeah. So two things. Number one, pseudoarthrosis which you found out. Number two, pseudoarthrosis which became symptomatic to you. So many a times I see patients whom I don't see a solid fusion on the X-ray over time. And remember, once you have a cage inside, you will not get the so-called mobility which we mentioned in conventional surgery in a dynamic X-rays. So any halo more than 2 millimeter in size on a CT after 1 year, up to 1 year, it is known that you have a halo around the cage in CT and then it stays stable. If it goes after 2 years, after 2 millimeters, after 1 year, it is a sign of pseudo. Now, is this pseudo symptomatic is the question. So what I do is that if I see this I see the halo on the X-ray and I see on the follow-up X-ray 1 year, I see more gap, I take a CT and document it. And I tell the patient that I see a pseudo here, but you have no symptoms right now. And if it happens to fail, then we will go for revision. That's one. Next, today, for want of something, if the patient becomes symptomatic, I use teriparatide. Off-label, I use teriparatide, and trust me, it works. Trust me, it works. It's off-label, it works. Third, if I have done a technical failure of doing poor end plate preparation, subtotal discectomy, inadequate graft, unstable fixation, whatever I do, any teriparatide, anything, it will fail. It will fail. It's a matter of time. It's a matter of time. So those cases, I take all the prerequisites, pre and intra. So for me, typically, I take around 20 minutes to prepare a single level disc space. Why? I don't use BMP. I don't have sharp and mechanical cutters. 3, I use the autograft with some G-bone or Chronos to expand. So I want to make sure I do everything possible to make my end plates healthy. So I use bone spikes. If it is sclerotic end plates, I do multiple picks. I put my endoscope. So today I try and do endofusion. So I put my endoscope, make sure I got real paprika sign, bleeding end plates before I start my cage insertion. So I do anything and everything possible in those cases to to make sure that I have bleeding end plates and keep it healthy and use as much bone as possible and make sure I got real stable fixation, and I try to make them walk day one or as early as load them so that it heals. Once it happens, this is my protocol. Document it. If it is symptomatic, use teriparatide. And of course, I have revisions also. I have had revisions in cases where I do long segment fusions and my L5S1 goes into pseudo. So when I revise, I go to double 4 rods and all those things.
If you allow me for a single question, I'm Dr. Hardik. Hello, Ranjit sir. So
yeah, Hardik, tell me.
So what do you do when you see a case of a grade 2 or 3 listhesis with a collapsed disc? Do you put the screws first, distract it, and then put the cage, or they with the same plan what you have shown in the video?
So if I see a grade 3 and 4, so grade 4 high dysplastic, I don't do any MIS. I don't do MIS. So my grade 1, grade 2 always MIS. Grade 3 is a borderline. I take a dynamic X-ray. And I see if there is mobility. If there is mobility, I'm fairly confident that I can get the reduction by positioning. I can get the reduction by positioning. So typically what I do is that I start the surgery with the hip flexed. Once I do bilateral total facetectomy. So it's a release surgery, it's a release. I release both facets completely by wherein I'll already start seeing some mobility, right? Then I put the contralateral screw guide wire, and if I feel it is not really reducing well, there I put the screw first. But remember, it's after bilateral total facetectomy because I don't want anything impinging on my exiting route when I do the reduction. Again, I try to extend the hip intraop. I get the reduction by intraop hip extension. So my OT techs are trained to put 6 pillows across the thigh after I do my decompression to get the reduction. Till it is residual, then I use the screw and the opposite side reduce. Why I don't try to do it first? Because if I do it, my cage, intraop cage expansion becomes limited because I've got some kind of hold on the other side. So first bilateral total facetectomy, then see if it is opening. If it is not opening, then put hip extension. If it is not opening, then put screws, then reduce or distract, and then end plate, and then cage.
Thank you, sir.
Thank you, Dr. Unikrishnan. Nice presentation. We would like to invite next speaker.
I'd like to invite next speaker, President of our MISSAB, Dr. Amit Jhala, sir, for MIS's Transkambin Lumbar Interbody Fusion.
Ranjit. And before I go for my talk on Transkambin, I would like to thank the team of Venus, the sitting on the right side of me, Rakesh and the whole his subordinates to organize such a wonderful event on behalf of MISSAB. And it's very well attended, and there is a lot of discussion which is there. So that is the first thing. The second point I want to make is that you have seen a classical conventional things which are going on, and there are so many things which are so rigid ideas which are there. So what I'm going to talk is something unconventional, which is something recent. So there can be some controversial points which can be there, much for a discussion in my cases rather than the other things which were already talked about. So with that caution, one more announcement that I want to make is that MISSAB is having 10th year of meeting in Ahmedabad, and I heartily invite all of you to our meeting of MISSAB, where all these things are going to be discussed in great details, along with not only the techniques that we are showing today, but also the technology which is helping us to do all these procedures. So I heartily invite you, And please register. The early bird registration is still open. So that's the second point. So after this, we all know that stabilization and interbody fusion is must when there is a instability. There is no doubt about it. Okay, I'm not going into the controversial part which was there in the previous talk. Okay, but when there is a obvious instability, it definitely requires fusion. And the fusion is like a clock. That's what I feel. And since 1945, 40s, that these fusions have come with the Clovert started it. And it has moved. It has moved. With time, it has come from posterior to anterior, anterior to posterior. So there is a clock which is already running for this thing. Plus, if you see in the dial clock, we are trying to see if the vertebra is in the center. We have tried to fuse this vertebra from all the ways except 1 o'clock, which is not there. So sometimes, I don't know, somebody will come with that procedure also, where you can fuse from that 1 o'clock position also. So this is what a conventional recent things which are coming up and which is already there is MIS TLIF and endoscopic TLIF. They are already being practiced as on today. And that's the recent fusion trends. And these are some of the downsides that you have to resect the bone, you get the epidural bleeding, and you have to be very careful about the dural tears and nerve root injuries, and that's what we were discussing in the previous talk. So they are the downsides of these procedures. So the other procedure which is already there is the indirect decompression, where you don't touch any of these things, and you get a decompression, you get a fixation, you get a fusion, and the patient is well. So it all depends on the school of thought, whether you are a direct decompression school or you are an indirect decompression school. So that's where, again, the difference comes. So what I'm coming and talking about is the indirect decompression. So the next two topics, myself and the next topic, is totally on the indirect decompression. We are not going to go into theory of indirect decompressions, but the lateral fusions and transkambin fusions, these are the two which are there for the indirect fusions. Now coming to the Cambin's triangle. What is a Cambin's fusion? That means you try to fuse and go through the natural corridor of the Cambin, which was already discovered in 1970. So it's not a newer thing. It's quite an older thing that you try to have explore this space, and the Cambin's triangle, where there is an exiting nerve root laterally, the superior end plate of the inferior vertebra at the base, and the superior articular process forms the third part or the third side of the triangle. So it's a right angle triangle, and this is the triangle which is avascular, and you can enter into the disc space directly, and that space is going to be explored in my talks. So we know very well that we are doing the nerve root injections and transforaminal blocks through this. The next came was the transforaminal endoscopy, which is already being practiced for a long time, 20 years now. And now the recent trend is try to explore. I may say recent, but the first endoscopic fusion was done in 1996. So it's recent, but it is quite old. Okay. So that's the Transkambin TLIF. So what are the advantages of this type of an approach? The approach goes through a natural anatomic safe entry zone. It's an avascular area. It is facet sparing. That means you don't need to do any bony work. Nothing has to be done. No dural neural retractions, no entry to the epidural space. The bleeding is less than 50 ml. The bleeding is too less because you are directly into the disc space and doing the fusion. It's quick in operative time because you don't have to drill and you don't have to go for the disc space. You are directly entering into the disc space. So it's quick in the operative time. Can be done in local anesthesia and can be percutaneous also. So these are the two things which needs to be explored. You can have a larger cage compared to TLIF, but smaller compared to OLIF. So it is in between stage between the OLIF and the TLIF. So that's the other advantage. You can add a decompression if there is a unilateral compression on the exiting route or the traversing route. So that also can be added if you are doing this procedure. And it's an extensile approach. That means if you are feeling that you require a more space, you can remove the SAP, you can remove the IAP and convert from
Transkambin to a TLIF procedure. So that is also the advantage. So these are the advantages of this approach where you can explore these things. I'm giving all these theoretical lectures because it's a newer procedure. Then I will go to the this thing. But there are issues of this procedure also. And we should very well know when we are coming to a newer procedure, I think we should much more focus on the issues rather than on what are the advantages. The issue is it's a very limited space. And that's what we know, that Transkambin has a very less space. Laterally, it is limited by the exiting nerve root. Height differs according to the disc height. So if you have a variable disc height of the patient, then if it is less than 50%, the Transkambin triangle further shrinks down. Then it becomes difficult to enter this. Medial, it is limited by SAP. So if you have an SAP osteophytes, then also the Transkambin triangle comes. And we are all doing our surgery for this type of patients. So you have to be very careful for this also. If there is a listhesis, further the Transkambin triangle decreases. So all these things needs to be considered. I'm not talking about the root anomalies and anatomical variations of the Transkambin triangle. So what are the complications of this procedure? The complications, the foremost and the most important complication anyone can face is exiting nerve root paresthesias. And around 20% of the cases, you can get an exiting nerve root paresthesias if you have this procedure. So you have to be very careful if you are doing this procedure. So these are the cautions that I am giving beforehand while I'm talking. Okay. So it is always better because the base of the Transkambin triangle, it is around 9 millimeters. So if you work within 9 millimeter, if your instruments are within 9 millimeter, then you will be able to do this procedure very safely. Okay? So it is better to use 9 millimeter cannula size whenever possible. You should have a specially designed cages which have this type of nozzle. So when you have this type of nozzle, it is self-expanding the space and it goes inside the disc without or with less damage to the exiting nerve root. And the best is an expandable cage, though you may like or may not like. If you want to have this procedure, I feel that the best is the expandable cage because you can put the cage through the 9 millimeter cannula. So these are the precautions. Some things that you should know that you cannot have if there are transitional anomalies, like if you have a large transverse processes, you cannot enter the Transkambin triangle, so you cannot do it. If you are doing it at L5S1, 75-80% of time, you will be able to do it, but 20-30% of time with the high iliac crest, you will not be able to reach the L5S1 Transkambin triangle, so it may not be possible. So reduced disc height, reduced foraminal height, listhesis, they are all, you have to be very, pre-operatively you have to think whether you will be able to do it or not. Okay, so this is what you need to think about. So one more thing that what you are looking at, anybody, which triangle is having more space, L23 or L5S1? L23, right? Everyone feels that L23 has a more Transkambin triangle. It is actually reverse. The L45, L5S1 Transkambin triangle has more space compared to L23 and L34. So you have more problems with L23 and L34 with the Transkambins compared to the L45 and L5S1. And this has been studied by so many that size of the Transkambin triangle increased in area, moving down vertebral levels with L5S1 being the largest. Okay? The other thing is there was also considerable increase in the size of the Transkambin triangle if SAP was removed. Third, 33% of decrease in the area of the Transkambin triangle in operated cases. That means these are degenerated ones, degenerated facets. So Transkambin triangle which is measured in normal, you have 33% less when there is a pathology in that particular segment. Okay? And cannulas between 7 and 8 millimeter are safest. You can use maximum up to 10. You should not go beyond the 10. And the cage size that you can implant inside, I would say it is 10, though they have written around 14. But 10 to 11 is the maximum size that may be safe for putting through this Transkambin triangle. So there are 3 techniques. Now coming to the technical part. There are 3 techniques. All the 3 I have used. One is full endoscopic technique, routinely employed for TLIF. Other is percutaneous technique, no scopes or tubes, only under IITV guidance. And third is the tubular technique. So whatever is comfortable, I'm going to present 2 techniques of these 3. So needle targeting, those who are doing transforaminal endoscopy, it's very easy for them to target the Transkambin triangle. But those who are doing, they also know that they have to go AP, lateral, okay, to check in both the AP and lateral planes. So this is what is conventionally, these are the points that you make. But in AP, you draw the line at the disc level. In lateral also, you draw the line at the disc level. Wherever they meet, that is the meeting point, and that is your target entry for this thing. So that's the classical that the transforaminal guys use it for the endoscopy. I don't use this. What I use is, because I don't like AP lateral. Every time you do AP and lateral, everything changes. So what my target is this, that these are the targeting points for that. So what my targeting point is, if this is the exiting nerve root, this is the Cambin's triangle, which is the farthest point if you want to stop exiting nerve root. This is the farthest point, okay? So this is the farthest point. So if this is the farthest point, that is the safest point, okay? And if you want to find out that safest point, this is the nerve root and this is that point. Okay, so I take a Scotty dog view or an oblique view, and in that one view, I can put in my needle inside. Okay, and that's what the needle goes. So that's the Scotty dog, and that's where the needle goes inside. So needle goes inside at the junction of the superior articular process and the facet and the pedicle. So that's where. No, I'll show in the video. You will see everything in the video. Right. So this is what the entry point I use. I don't know, it is not mentioned in literature anywhere, but this is what I use where it is. Because I feel it is very easy. There is no AP lateral, it is required only in oblique view. You can just enter and target into the disc base. So this is a video of tubular TLIF, female 66, bilateral neurogenic claudications and all that symptoms. And patient had an L5S1 degenerative listhesis, and there was a stenosis at L4-5 also. So this is L4-5 stenosis. There is a facet fullness at L5S1. So I had to fuse both the levels. I decided that I have to fuse both the levels, and in that, this also you can see that there is a stenosis at both the levels. But I am at present selecting the cases not more than grade B of a stenosis. Okay. So this is the video now, which is going to run. So I put all the wires first. So all the wires are already there inside. And then we measure, we mark the midline. Then we mark about 8 or 10 centimeter from the midline. Depending on whether the patient is fat, you give 10 centimeters or 8 centimeters is fine. That at the 8 centimeter mark, you can just enter inside. So these are 2 levels which I am doing in this case. So both the levels are marked first. These are unedited videos, so this is what was our intent was initially. So they are not edited ones. Yeah. So that's what the marking shows. So once that is marked, one thing I want to say is that I am doing at 2 levels. The first needle targeting I am showing at the upper level, and the cage I will show at the lower level because I got that type of videos managed. So the needle targeting you will see in this. So I use a Jamshedi needle, and you can see that that's very important that, oh, it started from before. Okay, so that's where I start. As I said, that my point of target is the pedicle and the SAP junction on X-ray. So that's where I target, and that's the farthest point from the exciting nerve root. Okay. So the needle is going through inside, and once it goes up to the medial pedicle line, I stop. I don't go. I take an AP view. So that's the point where it goes inside. So that's the AP view. AP view, it is up to the midline. So I still want to go to the opposite side. So I further advance my needle in AP so that it crosses the midline. So then I put the, then I check in the lateral where is my needle position in lateral. So in lateral, I can still go inside further. And I put a wire which goes through the Jamshedi needle and goes up to the anterior 1/2 or 1/3 of the disc space. So once this wire goes, then everything is cannulated instruments. What I use, you can use other things also, but what I have is these are the reamers which are there, which goes. You can use these reamers, or you can directly use even the even in tubular you can directly use your first dilator, which docks inside the disc. Okay, so there is no need, but if this will open up the space much more, if you have a reamer, that will open up the space much more. Or you can, so that's the gradulated increasing reamers which are there. So that's the second reamer. This is, you can do it in local, but I'm not doing it. It's in the GA. There is no monitoring here. Ideally, you can monitor. Yeah, he uses monitor. I don't use it. So these are the reamers. I am just skipping these reamers, are just reaming it, reaming the space. And then this is very important that these are the shavers. These are cannulated shavers, which once you have made a space about 8 millimeter, these reamers come from 6, 7, and 8. Then you can directly use these 9 millimeter shavers. So that's the 9 millimeter box shaver, which are cannulated. And these box shavers, you can just enter inside the disc, and you rotate it, and you will get a large amount of disc which is prepared. So once you see, you will be able to see how much of, that's the 9 millimeter shaver again going another one size higher. that shows the amount of disc with the shaver which has come out. So if you use a gradually increasing, you can get more disc which is coming out.
Sir, this is minimally invasive procedure. Why there is so much of blood?
I'll tell you, the most bleeding is coming from percutaneous screws. The percutaneous screws, if you put an incision there, they will bleed much more compared to the other things, because from there it oozes. So that is from the wire sites. That is from the wire site. Yeah, but that is from the wire side. You can see it is coming from the wire side. It's right from beginning it was from the wire side. But not from the fusion side. So once you have done the shaver, what I use is, this is the tubular retractor that I put it. So once I want to see exactly inside what has happened, how much I have cleared, so then you can put in the tubular retractor. The tubular retractor is of 16 millimeter, which may be varying from 70 millimeter to 100 millimeter, because you are going oblique. So you will require that long tubular retractors. And that goes, this is safer because it docks on the facet joint. It does not go up to the disc. It does not go up to the disc. So it docks on the facet joint, where it is like an extraforaminal disc herniation, what we were talking about. So it docks on the disc, and then under vision, you can do further preparation. I use a microscope also. In this, it is not there, but I use a microscope also here to check whether everything is okay or not. So that's the docking part. And then you can use your conventional instruments here. So your conventional disc forceps can go, your conventional long curettes can go inside. So that's clearance of the disc space. That's a curette, and you can see that you can curate it very nicely under image. Even you can have that grating sensation which is felt when you are curating. So all these things can be there. So once the curette and everything is done, then the next step would be to size it and then put the graft and then put the cage. Okay, so this is what the next step would be. You can wash the disc space, thoroughly wash the disc space, and then that's the sizer which goes inside. This video is of the lower space. So that goes in the disc space. You can see, and you can again check like in open whether it's fitting right or not to check the size of the cage. So then you over the wire you can put the so this goes right inside the disc space. So then it becomes and the graft, you can, whatever graft your choice, you can take the autologous or mix with the autologous and the hydroxyapatite, whatever. So then you put it inside and pack. You have to be very careful that it does, you have to hold it, otherwise the K-wire, all the instruments can go to the opposite side. So you have to be very careful about it. So you can see that a graft is being packed.
Where did you take the graft in this case?
I use bone substitutes. I use bone substitutes. So that's the cage, which is usually the cage size is around 35. 35 is in, while in TLIF we use around 25. So it's around 10 millimeters more. And then the cage is inserted. So that cage goes inside. And you check in AP and lateral the exact position of the cage. Okay. Fine, so I think it has moved a little. So that's the position of the cage which is there. And I'll just move forwards. This is the final picture. So if you see this final picture, the most important thing is that in this incision only, that 16 mm, you are able to do both the levels. 4, 5 and 5S1. Both the levels are from the same small incision. The incisions of percutaneous screws are much more compared to these things. So this is a tubular way that I did it. And this is another case which is again listhesis at L4, 5. And I'm showing with the help of the endoscope. And this is what whenever possible, patient affording, I think this is the best way to do it rather than what I showed it. So I'll move it fast because the needle targeting is already known to everyone now. So measure it. So that's the measure, that's 4, that's 5, that's 8 millimeter, that 8 centimeter, 10 centimeter. Then you do an oblique projection. So once in oblique projection, so that's the oblique projection you see. This is what I'm going to use is 8.5 millimeter cannula. So the incision would be around 9 millimeter. So this is where I try to go. I walk on the bone. I don't directly go to the soft tissue. I first walk on the bone, come to this point, which is there. So this is where it starts. And then put in the needle. Needle goes up to the medial pedicle line there. Check in AP. So it should cross the behind, and then you check the lateral, and that's the lateral projection. It goes to the anterior 1/3. This is just going ahead, that's fine. So that's the reaming over the needle. I'm skipping that part of reaming, but this is very important that after the reaming is done, I want to show you this cannula. So this cannula is around 8.5, which is a square cannula. And square cannula is important because that goes along the disc rectangle. So that's the square cannula. So the cannula goes inside, so inside the disc space. Now we are safe. Once this cannula goes inside, not like in tubular that all the instrument has to go and traverse through the extending nerve root. So this becomes once safer, that everything is now going to be there through the disc inside. So it's never going to damage the exciting nerve root. So this is the safest. So that's the oblique bevel cannula which protects the exciting nerve root. And then you have this special expandable shavers which expands from 7 to 14. Expands from 7 to 14, and that goes through that 8.5 mm cannula. So you don't have to you can see that it is just rotating, and you can measure according to that the cage size also. It goes to 10 or 11, and you can measure the cage size also according to that. So this is not moving. You see, this is not moving. So then I will do is I'll reduce it a little bit. Yeah. So from 12 I just reduced it to 11, and now it is shaving. Okay. So that's how you can also know how much size of the cage is required. So that's the size. Exactly you can check. Can use this disc forceps which are available to clear the disc space, but there is a curette which is also available there, which can go through the 8.5 mm cannula. And it also scrapes, it's a flexible one, so it scrapes the end plate. And then in these cases I use a scope also to check the end plate bleeding, whether it is there or not, because you can use this thing. I think I'll skip this part for want of time, but I'll show you that there are bleeding points which are there. So that confirms that whatever we have done. You see, whenever put in the scope, there are a lot of disc material which actually comes out, because there was no space of that material to come out. So once you put a scope, it washes out all the disc material which is there. I'll just go to the last part where I can see the end plate. So this is the end plate. This is where is the end plate. So whatever little bit of there was a large piece of disc which came out, so I had to remove the cannula and now so that's the bleeding end plate which is seen. I don't know, it's not seen there very much nicely, but that's the surface. You can see that bleeding points which are there on the end plate. So that's the whole upper and the lower end plate which can be seen. So then you come out, you can see a very nice hole there. You come out of it after checking it, then that's the expandable cage. It's from 7 to 14 with self-locking. Once it does not go more than certain torque. So you cannot overdo it. And just put in the graft there. Check that the graft is adequately packed. That's the cage going. So the last part, you will see exact position of the cage and then we are done. Is looking at the marking so that the whole cage has gone outside the cannula anteriorly. So there is a marking provided there. Okay, so now the cage is gone and now we are expanding the cage. So that's the cage expansion. We don't over expand it as Ranjit was telling. If it is snugly fitting, that's fine. So that's the final picture of the cage. AP, lateral. And then we remove it. So again we just put the scope to see exactly where the cage, how it is placed with the scope. Remove the cannula and then put the posterior percutaneous screws. So that's after putting the screws, AP, lateral, and that's the incision, which is quite small about this. I think I'll stop it here. Thank you. Any questions?
Hello, sir. Dr. Hardik here. I want to know how the indirect decompression you are able to achieve with this Transkambin approach. What I have seen the only post-op MR of your cases. So I want to know how this Transkambin is going to have indirect decompression.
This is one case. Start projection. It is the same mechanism. It is the same mechanism because you are gradually increasing the size. So you see there is no disc space here. There is a grade 1 listhesis. Of course, there is no much of a compression there, but again you can achieve the disc height and you can put this much amount of cage. So you can increase the disc height depending on, because you are putting gradually increasing sizers. When you gradually put increasing sizers, it expands.
I think there was not much of the disc space increase while putting the cage, particularly the non-expandable.
Because it is not required, no. Because as I said that it is not required. You don't want to expand it or you don't want to jack. Even in OF we don't want to jack it up. We want to keep it as minimum as possible, because more jacking up, you are having more end plate pressure and you have more subsidence. So we just keep it as upper and the lower disc, whatever is required. Like so here also you see there is no disc space, but if you see the end point, it is like up to the upper disc space.
So if I want to convert it into the tubular, if I do far lateral tubular TLIF, it would give me the same result what you are able to achieve.
So that's what I said. No, you can do a tubular also. But in tubular then you might have to remove and drill the SAP. Here you don't need to remove the SAP.
Thank you.
Is this a post-op MRI? Or pre-op?
No, that's a pre-op.
Sir, what if there is significant ligamentum flavum hypertrophy? Does this indirect decompression?
So I have done up to grade B at present. So up to grade B you can do it. So that's a 1 year follow-up of the same patient. This is what you are talking about, right? Slightly more than that. L23 slightly more than that, okay. And then you do multi-levels with that, okay. This is a revision case. That means it was already operated 20 years back at L5S1. And now it is L4-5 listhesis, adjacent segment. You can see CT, and you can see that you are able to put it there. You can see the increase in the disc height also. There. Okay.
What size of remotes do you use, and how do you ensure about it's not causing any injury to the exiting root?
So that's what I said, that as minimum, one is the entry point itself. Once my entry point is there.
As you increase the size of the reamer,
so that's the shape of the reamer is very important. I don't like that box reamers which I was putting there, because the box reamers are having a square shape in the front. So what I like is the reamers which I used, which are actually conical reamers. So once it goes inside, it will self-expand.
Okay.
So there is a difference in the instrument.
Which company is the
So this was Maxmore.
okay.
Reamers were of Maxmore. So there are multiple instruments. One expandable cage is of Globus. The others are from Geon. Other is a mix of Maxmore also. So it's a multiple company instruments that I have.
Okay. Thank you.
So you were using oblique view. So do you bring the facet to the middle of the disc and then use the end-on view of the needle? How do you?
I don't use an end-on. I don't use an end-on. So what I do is I don't want to go directly to the soft tissue. So I target on these, on the TP and this SAP junction. So I target the TP. Then I walk on the TP. Okay.
So
and then when I feel a give-way sensation,
tactile feedback.
At that time,
feedback you use as your mechanism.
Yes.
Thank you.
Elaborate a little more about that spotting out exactly where should it be, like as he was pointing out, whether you bring it to the middle of the middle in the oblique view or.
So this is what I said, no? So this is in lateral view, but if you see, this is the Scotty dog view.
Exactly, it looks in the
Last
middle.
question.
This is Scotty dog view. That means this is the ear, and this is
The
the
rest
end
of
plate.
the questions will be answered in
So
the
this is where
MISSAB
the eye target.
yearly
This is where I
conference. It's very near 2 months only.
Okay.
So the entry point, sir, is actually very good, because a lot of times my concern is whenever you are doing a percutaneous this thing, if there is a conjoint root, very difficult to pick it up on the MRI.
Yeah, so
I think that is why I think that is one very important thing of putting it, targeting the bone rather than trying to go to the.
So I don't use the targeting point of the endoscopy.
So Chandan, I'll reply to that. That is why I use neuromonitoring in all my KLIF cases. So I actually use the Transforaminal trocar. I mean the neurostimulator what we use, and I put it and we check that there is nothing coming in way. So I use neuromonitoring in all of my KLIF cases. Yes.
Next speaker.
Just last question, sir. So from kind of pioneer in MIS TLIF to OLIF and now KLIF. So what is your protocol? In which patients you choose which? Or just someday you do this?
Any direct decompression required TLIF.
Okay.
That means disc, facet cyst, bony stenosis, TLIF. Wherever there is no direct decompression required, like in the dynamic stenosis, maybe it is up to grade D also. Still, I am not telling, but if the patient has got a clinically no rest pain, whatever the amount of compression is there, and if there is no CT scan showing a facet osteophyte compressing the root, and the patient has no rest pain, whatever the compression, I go for indirect decompression. But because I am evolving on K-LIF, I am not using that like O-LIF at present.
Okay, thank you. Thank you, sir. So we have the last talk before lunch. This is by Dr. Neeraj Vasavda. He is going to talk on L2 to L5 O-LIF.
Okay, so this is another talk on indirect decompression, what we are going to do. This is O-LIF. Actually, O-LIFs introduced the concept of indirect decompression, and which has been further explored in this transforaminal Transkambin fusion approach. So there are various approaches to target your lumbar spine when you are doing a fusion. If we started with P-LIF, we started with open T-LIF, then came the lateral trans-psoas approaches. This O-LIF per se is an anti-psoas approach where you are targeting area anterior to the psoas muscle, and finally there is one which is called A-LIF. We also have now introduced the MIS TLIF approach, which is modification of open TLIF to the tubular retractor. And now, once Amit Bhai's excellent talk, we cannot forget that, K-LIF is also an approach to fuse. So there are so many approaches what you want to fuse. And what we are going to talk is mainly on indirect decompression. What we do is we try to jack open a disc space, whether it is O-LIF or whether it is K-LIF, and we trust more on straightening of ligamentum flavum as well as widening of the foramen and disc space, which leads to a decompression in phases. You can very clearly see that the collapsed disc from a collapsed disc to a very tall disc, which can happen with O-LIF, is good enough to do a good decompression. Advantage are almost as equal as any other minimal invasive approach. Here we don't even enter the epidural space. We remain completely outside of epidural space and can do the fusion procedure. The advantage of O-LIF is you can do a better anterior release, specifically in deformity cases where you want to reduce the deformity. There this releases really works wonder. You can even do anterior longitudinal ligament excision to get a better lordosis when you are doing an O-LIF procedure. Osteoporosis per se is one of the contraindication to use any of this procedure where you are targeting indirect decompression by jacking open a disc height, because sometimes end plates is so fragile that you try to open and it can collapse. So beware when you are doing O-LIF or this K-LIF procedure in DEXA less than -2.5. Better to optimize those patients first with teriparatide or whatever molecule you prefer, and then take it for your patient. Now, before you choose a case for O-LIF, it is very important to know the anatomical structures, because you will be dealing with lot of dangerous structures around. And you can see this on MRI. This is at 3-4. This is nice psoas on the left side. This is the aorta or the large vessel and vena cava. And you can see this is the bare area. This is the area where you have to target to do a fusion. So this anatomy is absolutely necessary to understand, because sometimes you have a different vascular structures and you may not get this area and you may end up in a soup if you are trying to do that. To avoid this, some surgeons started using the trans-psoas approach, but where the damage to neurological structure are much more. Now, if you look at this particular image, you can see psoas is there. The bifurcation is of major vessel is already happened, and you can see there is very less area to do O-LIF. In expert hand, you can still do O-LIF in this case, but generally this is not a good case to do your O-LIF cases, because once psoas is coming in way and you have a lot of vasculature to go into put the cage inside. Now there is a general scare regarding O-LIF. Why there is scare? Because when you are operating around so many of vital structures. You have a major vessel at L4-5 or L5-S1 generally is contraindicated for O-LIF, and you will have to do a modified version of O-LIF. That is what we call as a lateral A-LIF, wherein you will have to go in between this bifurcation, not where the anti-psoas traditional O-LIF approach what we use. So these are the areas which makes OLIF much more dangerous. We'll take you through one of the cases. This is 4-5 disc herniation along with a grade 1 listhesis patient. Position is standard hip approach what we use. In a lateral position, surgeon will be standing at the belly, around the belly and in front of the patient. You have to be aware where your incision would be. Incision would be around 2 fingers anterior to your disc space. Beware that you are using iliac crest as your marker, because sometimes iliac crest will be overhanging at the L4-5 and you may not able to do OLIF properly. Now here we are relying more on an orthogonal maneuver where we enter the disc space obliquely and then we rotate our cage to go in a perpendicular position in a lateral view. So for that matter, your iliac crest should not come in your way, because if it comes, the bone will not allow to do an orthogonal maneuver to position your cage in a correct position. Now after skin incision, when you have dissected subcutaneous tissue, first layer which you encounter is external oblique muscle. The fibers will be running like hand in glove position from lateral to medial in a supra-inferior direction. You dissect your external oblique, then the perpendicular fibers of internal oblique is dissected. So this is all a blunt dissection you are doing. Nowhere now onwards you will be using a sharp dissection. Once your internal oblique is dissected properly, you will dissect the transversalis muscle or the third layer of the muscle. Then comes the transversalis fascia. The moment you open a transversalis fascia, you will see retroperitoneal fat. You use your finger to dissect through your retroperitoneal fat and identify psoas muscle. This is the psoas muscle. You use a cottonoid or a peanut kind of a thing to dissect all the soft tissues from the psoas and identify the anterior border of the psoas, so that you start working. The major scare is sometimes, ureter, this is a ureter, you can see, which get reflected along with the peritoneum, and you are working here. So make sure that you have retracted your peritoneum properly, and this is the anterior border of psoas. You further dissect your anterior border of psoas to create your space. You have already dissected peritoneum. Now another important structure is this is a genitofemoral nerve which is into the belly of psoas muscle, and you don't want to retract much, you don't want to damage much, and then you have identified more or less all the structure. Now this is almost doing like an ACDF, where on one side you have a pulsatile major vessel which could be aorta or a common iliac, and lateral side you have this psoas muscle, and between these two you are operating. So more or less as if you are operating between an esophagus and a carotid when you are doing an ACDF. This is more or less exactly similar procedure you are doing. So once you have identified the anterior border of psoas, you dissect through. You can use a dissector, or you can just do a peanut or a blunt dissection, and you can identify a disc space just anterior to psoas. Sometimes you may have to burn some of the muscle fiber of a psoas minor to get exposure. This is psoas minor. You may want to cut, or you may want to just dissect through it to create your disc space. You dock your first dilator. Initially I used to use neuromonitoring also for these cases. Nowadays we have almost stopped using neuromonitoring for OLIF cases. So this is from one of my original videos where we used to use neuromonitoring. So this is the trocar what we used to use. We stimulate and then we dock the needle inside. Then the guide wire, first K wire goes, first dilator goes. You can see the obliquity of this dilator. So we are not perpendicular to the disc space in lateral, but we are quite oblique, around 30 to 40 degree oblique. Once dilator goes in, you can see this, you can stimulate the nerve just to check that you have not encountered any nerves. You gradually prepare your end plates with using sequential larger sizes of shavers, and you can curate the end plate just standard fashion what we do in preparing end plate. So you can do a complete release. Now this is the orthogonal maneuver which we would want to do to identify perfect cage placement. You would have noticed that from an oblique to lateral position is absolutely necessary for this. And this is first trial which identifies how what is the size of cage and everything you want to put. And then finally you can put the cage inside. This is how it happens. We dock a canal. This is IIT view. You can gradually clear the disc space, and you can see how nicely the disc height is jacking open. So you can do it for same incision, around 1.5 to 2 inch incision. You can do 3 level in one go very easily. You can see how nicely this deformity is getting corrected. A total collapse disc also gets jacked open. The beauty is it is a 360 almost anteriorly complete release you can achieve, and you can achieve a nice disc height, nice foraminal height in our patient. So there are approach related complications which can happen while doing this procedure. Subcutaneous neurovascular damage can lead to a pseudohernia. You can damage genitofemoral nerves. There could be segmental injury, vascular injury, ureter injury, or a bowel injury. Generally more common, if you are not careful, you may have a vascular or a ureter injury. Another flip side of OLIF over KLIF is you will have to turn your position into prone position. Now with image guidance, with O-arms and all, you can do single position OLIFs also, but it requires some amount of experience before you start doing it. So this is the pseudohernia, and this is not my patient, this is from a literature. This is lumbar plexus, which is into the psoas muscle, generally. So even if you are doing anti-psoas, if you keep retracting psoas too much, this nerve structures can get damaged, and your patient may have a praxia or a palsy post-operatively, which more often than not recovers within 3 months' time. So this is our data so far. We have used around 125 cases. We started doing around 2017. We have documented a very good fusion rate. We had one stable pseudoarthrosis. We had 1% patient which required revision, one patient had a fracture, and another had a subsidence of cases. So far, fortunately, we have no major vascular injuries. I had one segmental injury which led to a retroperitoneum large hematoma, but patient did not need it to be revised. No tubular organ injury so far, and no hernia we have so far. So in conclusion, before doing OLIF, understand the regional anatomy. Pre-op proper planning is absolutely mandatory. You should know what amount of cage you are going to put. Position the patient. True AP and true lateral is most important, because if your patient is not aligned properly, you may feel that your cage is going in a right direction perpendicularly. In fact, your cage may be oblique and may hit anywhere. It may hit on the opposite side nerve, and we have reported cases where opposite side nerve post-operatively starts firing and patient wakes up with opposite side, the right side pain. Muscle fiber, I prefer to do everything under vision, even up to reach up to psoas. I think Amit Bhai has more or less, relied on his finger, and he has stopped going under vision. I still feel, what happened? Okay. I still feel that, everything has to be under vision, and I see all the structure before I go ahead. Gentle dissection of retroperitoneum with finger is very important. EMG, if you are doing transpsoas, if you are not doing transpsoas, there is no need of neuromonitoring. Proper positioning of retractor is very necessary, because sometimes the retractor may come in way of inserting your cage. So make sure that your retractors are in proper position. Carefully prepare disc space so that you don't damage end plate, because if you damage end plate and cage is of not proper size, this approach leads to more subsidence than even our TLIF. Do not use oversized implant, it may fracture. And before closure, make sure that there are no major bleeders, and if so, please manage those bleeders. Thank you so much. So no questions.
I would like to comment that, or ask a question. Is there now a competition in the TLIF, OLIF, and now the...
well, you can say that. That is why. So that is why I had put that first.
But the audience who are still has to decide are those who are just now doing the tubular decompression and now thinking that they want to fuse, or they want to go towards the fusion, which is a major procedure which has got a big learning curve, which needs minimum data of your own 20, 30 cases with its own complications plus minus. Now you are opening up the 3 corridors for them and enter one of them. How they will decide that where they want to go?
Well, I guess the answer is pretty simple to it. Whatever works in your hand for your patient is the best technique. So actually there is no technique which has shown a significant superiority over another technique. Every technique has its own advantages and disadvantages. So I guess there is no significantly, you can never say that only.
I will have a comment on this. Sorry to interrupt you.
No problem.
For the juniors or those who are in the shoes where they want to enter that. Now these things, indications are little bit lesser compared to the TLIF. TLIF has got wider indications in your practice. As you move towards the OLIF, the indications will reduce in the form that being advantages that you can do 2-3 levels through a same incision, plus you have address by reducing taking out the lesser bone, lesser corridor work. Still, the indications are very less compared to the European or the American society with the Indian society. Because we cater maximum patients when they are almost, their claudication distance has reduced too much and their backache is at the extreme that they are sitting on the chair and need people to make them stand, at least in the early phase of your practice. So the TLIF should be the beginning, and then there should be concentration on these two bosses, not in the early. That is what I want to correct.
So as far as OLIF goes, I think those who are doing OLIF since very long, everybody more or less has stopped doing OLIF for single level, because it doesn't make sense, to keep on. My MIS TLIF time is around 1.5 hours. So if I'm using this, unless I'm doing a single position OLIF, this will take 2.5 to quarter to 3 hours. In changing position itself will take half an hour. So in my books today, if I am doing OLIF, it is generally for 2 level, 3 level, mainly deformity cases where there is adult scoliosis. On those cases I use OLIF. Single level, more or less I have stopped using OLIF. As you rightly said that, probably TLIF is still a, now with advent of KLIF, I think those single levels have gone to KLIF rather than OLIF for me.
So so for single level OLIF, do you always back it up with pedicle screws or?
Oh yeah, always. Well, there are two school of thoughts, about that. Some actually started, putting screws in front, and that mainly nowadays we do it an adjacent level. Whenever there is an adjacent level issue in a previously operated spine, we just put a OLIF cage interiorly and we fix 2 screws there and then, and it has proven result. Now, if you are doing in a lytic listhesis, say for example, you cannot get away by just putting 2 screws in front. You will have to use 4 screws in the back. One school of thought says that when you are doing an OLIF, only 2 screws is sufficient on the left side from where you have put the screws. So I mean, at least I put all 4 screws even in a single level OLIF.
Neeraj, on pre-operative MRI, many times there is very little window. So with experience, do you take more liberty or expanded your indications, or you still very strict about choosing your patient for OLIF?
Well, not as strict as I used to be, but I still I think I would want to have adequate psoas, which I feel I should be able to retract not too much, and create a space. So basically, I think about it in a way that, if I mobilize psoas and if psoas can expose a disc, then I think, you can do it. So I think initially I used to look for a very wide corridor when I started. Now I am not much concerned about those very wide corridors. But vein, sometimes some anatomy you see that, vein is coming almost laterally. Those are cases I don't touch. He touches even, very dangerous cases, but I don't touch those cases.
Okay, thanks. Oh, one last thing. Do you have any number between the window?
Well, I guess, there is.
Or you just eyeball it?
No, I think there are numbers where, people say that, 2 millimeter to 3 millimeter, but, it's very difficult to measure. So I just eyeball it, I should be comfortable enough that I see over a period of time, you know that, this psoas you will be able to retract.
What would you tell beginners? Okay.
No, beginners, they have to have at least, I would say 6 to 7 millimeter of corridor before they start. Thank you.
Thank you, Neeraj sir, for excellent presentation.
Any more questions for this combined session? From the residents or the junior consultants?
To any of the speakers. We have
any of the
time.
speakers.
Yep.
Yes,
Thank you.
thanking
Thank
all
you
the speakers and all the moderators for a nice session on fixation and a heated discussion. I would just like to request Dr. Chandan Mohanty sir to hand over memento to Amit Jhala sir as the end of the session, sir. Thank you everyone. We are breaking for a lunch break and then we will return with the third session. Thank you. इधर इधर चाहिए था मुझे पढ़ने के लिए, थोड़ा बड़ा नहीं हो गया? देखो जरा। हाँ चलेगा चलेगा। ये स्लाइड से और इससे ये नीचे बड़ा होगा कैसे? पढ़ने लगे अभी बराबर है ना? ये करके देना मुझे। वीडियो चल रहा है क्या? देखता हूँ इसको यहाँ से प्ले नहीं कर सकते क्या? प्ले हो गया हो गया अच्छा एक बार क्लिक करना पड़ेगा। इसको मैं क्लोज कर दूँ, इसको भी क्लोज कर देता हूँ। ठीक है डिस्कनेक्ट। Yes. So that will be purely a tubular MISS approach. So 2 day MISS. Rahul, I want to laptop. So 1 day we will have this lectures and videos and concepts. Next day full day you will be on Canal. So next day whatever you want, cervical, lumbar, per cadaver, so that will दिखने रहा। Program will send it is still the venue is still not decided whether KEM or SIAN. Either one of them will be the venue, and the first day will be in a hotel. So that is what tentative date is. Faculty will be mostly me, Arvind, Vishal Kundani, Arvind Kulkarni. Then there will be one from KEM. I think Dr. Sonode will be there. Sandeep Sonode. He will be there from KEM, and we'll get one new हेलो चालू है बंद कर दो
Hello, hello.
Hook. Hello everyone. After a nice heavy lunch, we are starting our sessions early, but in the morning, two speakers were remaining to be felicitated. So first of all, I would invite Dr. Prakash Moda sir to welcome Dr. Janil Gurnani. अरे अरे कोई है अरे पढ़वाना चाहिए साहब अरे लाइट लाइट्स अंकित सर आ जाओ and just a note for all the faculties, there is a special bag available at this counter for those goodies and the mementos, sir. There is a bag available, sir. એટલે ઘરે લઈ જાઓ વાંધો નહીં આવે. Yes, sir. And requesting Dr. Bhaumit Thakur, sir, to welcome and felicitate Dr. Vikrant Pujari. सर थोड़ा साइन Thank you, sir. Now I would like to invite the chairpersons for the third session. They are Dr. Prakash Muda, sir, Dr. Yashish Dalal, sir, and Dr. Nimesh Patel, sir. Kindly join us on the stage, sir.
Good afternoon, everybody. And let's hope that everyone had a very nice lunch. And now we are inviting Dr. Vikrant Pujari to talk on Miss Odontoid screw fixation. Dr. Vikrant Pujari is a senior neurosurgeon in Gokul Hospital, Rajkot.
Good afternoon, senior dear friends and colleagues. I think we have gone for lumbar, and previous speakers have quite impressive lectures I heard today since morning for the lumbar spine and fixations and all latest technology wise. And so today here I am to present for the MIS odontoid screw fixation. As you know, incident of odontoid fracture is 10 to 15% of total cervical spine injuries. Young motor vehicular accident, hyperextension injuries, old age, travel injuries, pediatrics. But in pediatric, they are less devastating, can fuse within 16 weeks, usually needs no surgery. Anatomy-wise, as we know, all ligaments, apical, alar, and transverse, especially integrity of transverse ligament is very important for us, especially coming ahead in the anterior screw technique. Types of odontoid fracture, as you know, Anderson D'Alonso classification, type 1 oblique fracture through the odontoid tip, type 2 fracture through the base of the dens, type 3 fracture through the body of C2. These are the CT images of type 1, 2, and 3. Further subtypes of type 2 odontoid fractures are Grover classification as type 2A, which are undisplaced, type 2B, displaced transverse fractures or anterior superior to posterior inferior fracture, type 2C commuted or anterior inferior to posterior superior. Now comes to the management of type 2 fractures. Type 2 odontoid fractures represent approximately 2/3 of all odontoid fractures. A lateral bending force has been proposed as the mechanism causing the development of these fractures. Reduction and hollow waist immobilization, reduction and anterior screw fixation, which is the only modality which can provide immediate stabilization. If not able to reduce the fracture, then odontoid excision and posterior C1, C2 fixation or anterior fixation by particles technique can be done. Now coming to the comparison, anterior posterior surgery. Advantages of anterior surgery is that immediate direct fixation of the fracture is done, preserves normal mobility of C1, C2, high rate of fusion is that, and pain relief is immediate. Disadvantage of the posterior surgery is significant reduction is the head rotation, extensive muscle dissection, and need of bone graft harvest. Lenerson and et al. Quoted the risk of failure of helioembolization is 21 times higher than the surgery in patient greater than 50 years of age. 1 screw or 2 screws, which one is the better? Jenkins and Alfieri, single screw provides much stability and fusion rate as compared to 2 screws and technically is more easier. Single screw technique is more easier than the 2. Indications of odontoid screw placement. Type 2 odontoid fractures, type 2A displaced fracture of odontoid, if undisplaced then can be conservatively treated. Type 2B, anterior superior to posterior inferior fractures must be treated with anterior single screw fixation. Type 2C, anterior inferior to posterior superior fracture can be treated with single screw provided you can apply pressure with a sponge or with the gauze from the mouth. If you apply the pressure from the posterior pharyngeal wall, the displaced fracture get aligned. Anterior lateral mass fixation or posterior C1, C2 fixation also can be done. Fracture must be less than 3 months of old. Contraindication SCC, torn transverse ligament, fracture greater than 3 months of old, which are non-reducible, anterior oblique fractures, short neck, and so on. Radiology-wise, X-ray, flexion extension, CT with 3D construction, MRI. Especially MRI is important to see any cord edema or cervicomedullary junction edema is there or not. Type of displacement, anterior and posterior are there. Here we are reviewing one case which presented to us 50 years male with history of fall from bike, severe neck pain, giddiness, quadriparesis, +4 power. Sensations were normal. As you can see, the images anterior superior to posterior inferior fractures on the CT images. Now we'll go for the technique wise and instrument what will be required in anterior single screw fixations. Skin knife, right angle retractor, microdrill system, Kerrison rongers, all long mark K-wire, cannula with serration, cannulated tap of 4 mm diameter, cannulated lag screw of 4.5 mm diameter, cannulated screwdriver and automated drill. Surgical procedure, induce the patient with Taskov. We have a specialized developer Taskov for these types of cervical injuries. Without extension or flexion of the neck, we can induce the patient. Supine position with bolster under shoulder with minimal extension. Apply Kirschfield strong retractor, start with 2 kg, increase gradually to reduce the fracture. Reduction of fracture is very important in this procedure before going ahead. Mark the skin incision, transverse or oblique. So how to mark the incision? From where to enter this area, where to enter the C2 body. So put a K-wire directly from the base of the C2 body towards the tip of odontoid. The wire where it touches the skin is usually the level of skin incision, usually lies at 4.5 or 5.60 space. You can see in this image that position, minimal extension, and lower one lateral image showing in the skin level incision. Take 1.5 mm skin incision, dissect platysma, identify sternocleidomastoid, dissecting, separating trachea and esophagus medially, carotid bundle laterally to reach prevertebral fascia in the midline. Identification of longus colli is very important. With this minimal incision like 1.5 centimeter. Why it is important? Because you should understand all basics lies in the midline of the spine, cervical area. So if you are not in the midline, all the procedure will go wrong. So marking of the midline is very important. So how to mark the midline? So you identify the longus colli muscle on either side. Center of this is the midline. Okay. So you have to identify this first. And even you have to just make it sure on AP and lateral images. Drill the upper part of C3 vertebral body in the midline. Why to drill the upper part of C3 vertebra? Because the angulation what is needed to put the K-wire or screw is what is required, that notch is required. If you don't do that, that angle cannot be, you cannot get that angle. So drilling of upper part of the C3 vertebral body is very important. You drill the C3 upper part little bit, make a notch, remove some part of the disc from that disc space, and that will make things very easier. Now in this case, you can see after drilling the notch over there, place a serrated cannula at the base of C2, confirm with the C-arm. Drill a K-wire through the serrated cannula so that it crosses the fracture line of odontoid. So we use the automated hand drill for the K-wire as well. So slowly drill the K-wire through the C2 body till it crosses the fracture line. Sometimes the fracture fragment or odontoid get displaced. At that time, either you have to put a sponge holder in the mouth, you can just put a pressure on posterior, it will get reduced and you can able to do it most of the time. But important is in midline. Then pass a cannulated tap of 4 mm over the K-wire and tap till it crosses the fracture line. Hold the K-wire with the artery forceps so should not come out of and remove the tap gradually. Confirm the K-wire position with the C-arm. So what is important when you drill it with the tap actually, when you are putting a tap, 4 mm tap over the K-wire, if you are drilling it, sometimes while coming out, the K-wire gets come out along with the tap. So you have to make sure proximally and distally, especially first in the distally, that the K-wire should not come out while you are removing the tap. Measure the length of the K-wire, how much is required for this. An appropriate size of lag screw can be used. Pass 4.5 mm of lag screw over the K-wire and tighten till the lag part of the screw crosses the fracture line, and head of the screw must sit in the disc space under the C2 vertebral body. Why it is important to sit the head of the screw in the disc space? Because if it is quite out, then it may have, it is of a trachea, as you know, anteriorly, so it may touch it and gives the pain for the pain. Then confirm the position of the patient with the screw with the C-arm. Sometimes if screw causes distraction of the fragment, even the screw also, while putting the screw also, there will be the distraction of the fragment. So it's the same thing you can do, you can put a sponge holder and reduce it. This is the 3D CT image of the anterior screw fixation. You can see as you have put the screw, the distracted fragment has came down, and that's a peculiarity of this lag screw. I will come to ahead what is this lag screw, how it looks like. So this is how the position of the patient and skin incision is there. We'll go through a short video of this actually. Marking of the skin incision directing toward the tip of odontoid from the C2, but it is like C3, C4, C5 or C5, C6 level. So after dissecting platysma, just identify sternocleidomastoid, trachea, esophagus, medially, carotid bundle laterally. Just go by finger dissection. That is the best way of doing it because it will not injure any vascular structure that is very medial, and it's with this small port you have to go it. Now this image, if you see, this is the drilling of upper part of this vertebra, C3 vertebra. After drilling the upper part of C3 vertebra, introduce a serrated cannula, and the tip of serrated cannula should exactly sit between in the notch below C2. How it looks like. So once it sits, confirm its midline. So after you put a K-wire, drill it till it crosses the fracture area, crosses the fracture line in AP and lateral, you just confirm it whether it is distracting or not. Pass through it till it crosses the tip. If it is not, reduced by the sponge holder from the mouth. Now this, you can see the K-wire is almost crossed up to the tip of the odontoid in AP and lateral images. So how is this serrated cannula? What we are measuring the length of the K-wire, and after measuring the length of the K-wire, you can select the appropriate side of lag screw. Here we can see distally the K-wire is actually holded. You can see it here. And we use the hand automated drill. Important is like to hold by both hands. 1 millimeter of difference at the proximal will divert the screw by 3 to 4 millimeters. You are in the wrong direction then. So just positioning in a static position is very important. You should nobody should touch you while doing this procedure. You should not get any sort of distraction during this procedure. So that's important. So holding of the K-wire, also while removing the tap actually, you have to remove the tap slowly, that the K-wire should also not come out. Sometimes K-wire gets broken into the odontoid. That's very dangerous. You cannot do anything. So just once you have entered, you should not make multiple entry points. Only one entry has to be followed. So before that, you make sure that you are in a correct position to do that. So once the tap is removed slowly, hold the K-wire proximally now. Upper one is a normal screw, lower one is a lag screw, where the shaft is actually holds the C2 body, and the distal ones is the threaded one which holds the fracture fragment of odontoid in the place. That's a lag screw. So serrated lag screw over the K-wire and just tightened it till it crosses the fracture line slowly. You can see the position of that serrated cannula hand has to be very static. These are the post-operative images. Post-operative LFA mobilize the patient on the same day. Advantages: preserves the rotative motion of the cervical spine with stabilization of spine, causing immediate relief of neck pain. Fusion rate is usually 93% and patient can go to his routine work. Complications: if you are not in a midline, then K-wire can injure neurovascular structure. Avulsion of cortical edge of C2 vertebral body if screw goes superficially. Sometimes screw gets superficial and cortical surface of C2 get avulsed. So loosening of the screw if there is any infection, dysphagia, hoarseness of voice, injury to esophagus. In the images which in the boxes are there, the broken screw is also, sometimes the screw can get break there. This is a patient after surgery, immediate after surgery. His quadriceps paralysis actually almost resolved. His neck pain is not there and he's doing well on the immediate very first day of surgery. Conclusion: anterior screw fixation is the treatment of choice for acute type 2 odontoid fractures with no morbidity, immediate mobility and relief from cervical pain. Single screw is sufficient to provide good fixation and fusion. Thank you very much. Here is one more announcement from our society. I here welcome all of you for the upcoming conference NISICON, which will be organized in Rajkot 2025 on 28th February, 1st and 2nd March of 2025. Behalf of RNA, Rajkot Neurosurgeon Association, NSSI, we welcome all of you for this great academic feast. Thank you.
Now I invite questions from the audience. Yes, Bhomik.
Can you elaborate upon the importance of lag in the screw and why keeping the head between C2 and 3 is important for the sake of general audience?
Yeah. So coming to that very important point, as you mentioned, lag screw, if you see, the proximal part of that screw is very plain. It is not threaded. The distal part is threaded. So when the screw enters the C2 body, it holds the C2 body as a force over there. And when the distal fragment of the odontoid, when the lag part of that screw enters that with the threaded, it holds the odontoid in position. So it can become like a concrete hold of that odontoid fracture is there. So in our video as well as images, you can see that fracture, and it gets like telescopic of action is there, and it retracts actually. Odontoid get retracted toward the C2, and it sits in the position. And why head? Head should be inside this notch, because if you are not drilling a notch at the upper border of C3, it may injure the vas or esophagus trachea. So that is very important. That screw should be in the notch at the level of the surface of the body. Yeah.
Space or the upper body of C3 to provide counter traction to the lag effect at the fracture side. I think that is more important than the neurovascular complications.
Yes. And important these things, like I told you, like entry point is very important. Once you made an entry point in the all, you should not change it. Before doing that, midline is very important, and midline has to be confirmed anatomically as well as radiologically. More anatomically, if you are under vision, if you are doing that, you may not be in a wrong position. Anybody else?
Can you please elaborate all the instruments, specialized instruments which you use here?
Okay, we use actually serrated cannula, K-wire.
The instruments also, not the instrumentation, but the instruments to reach. You used a certain long cannula type thing.
No. That's a serrated cannula what we use. Okay. And once you are exposed with a small incision, you expose in the neck, okay, at the concerned level. With Langhand, you just retract muscles, you just retract esophagus trachea. Go to the midline in the prevertebral.
That is done with open vision, or it is with
open
microscope?
Vision under microscope. under microscope. We use microscope, high magnifying microscope, whatever which
So
is
you
available.
use any retractor to keep the...
Yes, Langhans retractor. Just minimal retraction is done. Very minimal retraction has to be done. And with that is a very small port, 1.5 centimeter. And through that you go to the midline in the prevertebral fascia. Identifying midline is very important. So longus cola, you have to identify longus cola on either side. So because it's that small, you won't be able to identify the if you're not able to identify longus cola, you cannot be in the midline. So even the X-ray
So till
image
that time you are just, it is like conventional micro discectomy, same dissection you are doing through a small incision with Langenbach. No self-retaining retractors or anything.
No, why? Because they actually obstruct our views for imaging. So we don't use any other retractor system, anything. Just serrated cannula. Once you have got dissection over, just put a serrated cannula. That's it. Nothing else.
Hello, sir. Hello, sir.
Yes, Rakesh.
You.
In which cases of type 2 fracture you would not use odontoid screw and you would prefer posterior fixation, or in all odontoid fractures you would use this only?
See, type C fractures usually which are anterior-inferior to posterior-superior, they can be done but with great difficulty. Okay, you have to put a pressure on and it becomes very taskful actually. More easier and straightway fractures are type 2B, which can be done very easily and straightforward. Okay. But type 2C fractures, where the fracture line is actually crossing from anterior-inferior to posterior-superior. So that time, your direction of the screw is just parallel to the fracture line. So that is one of the things.
Hello, sir.
Nice talk, Dr.
Hello, sir.
Vikram.
One question. Two questions. Any special type of OT table you are using for C2?
No, not really.
For AP view, what changes you are doing in OT table?
See, coming to the C-arm, actually, if you are having just before, during lunch hour, we were talking about C-arm and O-arm. If people are having O-arm, that's the best thing. In my initial institute, we used to use O-arm, but wherever the possibility of one arm, two C-arms will be more beneficial at the time of procedure. If you are doing only with one C-arm, that becomes a little difficult. If you are having two C-arms, you don't need to position all the time C-arm. So two C-arms will be helpful while doing this procedure.
Okay, especially the osteoporotic patient, very difficult to confirm in the AP view, the midline.
Yeah.
So in conventional versus MIS, if we are going for this MIS.
That's what, it should be like, age is also very important factor, and osteoporotic quality of the bone. You have to be very selective in this procedure. The fracture has to be less than 3 months of old, and age should be around 50 years less than that.
And if we are going for MIS and patient having osteoporosis,
yeah.
So if it is difficult to confirm in radiologically, how to confirm anatomically that we are in midline?
In osteoporotic cases, you
Yes,
said.
sir.
That's what I said. You just identify the longus coli. Okay, that won't change. Anatomy of longus coli won't change with osteoporosis. They never changes their position. So laterally, if you see laterally, the longus coli are very same. So that's why initially I was enumerating longus coli muscle. See the longus coli muscle, be in the midline of that. Mark the midline of that. Because sometimes your C-arm images also maybe just, you may not be in the wrong place then.
Yes, sir.
Yeah.
Thank you.
Nice talk, Dr. Vikrant. One comment from my side, as you mentioned, in the leg screw is always good because once it goes into the distal fragment, it doesn't displace it further. It actually pulls. And a quick question, any literature review between MIS, odontoid fixation anterior, and a standard open where you have difference in the vascular injury? I mean, one has a higher or anything, like particularly for the MS because you are not using retractor once you are there. So any comparative study, anything?
No, not still like, not quite studies are such.
No such.
Yeah. Anybody else?
Answer to your question is, C-arm, you were saying that you are not able to visualize AP properly. The reason is, don't use horseshoe, or you will have to buy a radiolucent horseshoe. So don't use horseshoe means head position should be on the radiolucent table. Then only AP is possible. What we try to do is we put the patient's head on horseshoe, which is a metal and which gives the artifact. So we are not able to see the proper AP. That's the problem. So for this procedure, if you want to see the AP, then you are not supposed to use this horseshoe. Put the head standard on the radiolucent table with head ring, simple head.
Thanks, Dr. Vikrant. I think we'll go with the next talk.
Thank you very much.
Would like to invite Dr. Ranjit Unnikrishnan. I think he's going to join us on Zoom meeting. Is he ready? Dr. Ranjit is an orthospine surgeon who is practicing in Kerala. One of my old colleague in Amrita, actually. Dr. Ranjit.
Are you seeing my screen?
Yeah, hi Ranjit. Dr. Nimesh
Hi.
here. Can you hear
Thank
me?
you, thank you, sir. Thank you very much. Glad to meet you again. So here we go. So it will be a recap of two techniques. One is the percutaneous vertebroplasty and another is using the cement screws. So we'll, again, couple of prerequisites. Number one is to get good AP and lateral CM images. Any of these techniques, like we've been seeing since morning, we have to have good CM images. If not, we will be not able to do it very safely. Number three is localization and guideway placement. Number four is being familiar with the instrumentation and cement handling. So you should not be doing cement screws if you're not very familiar with using vertebroplasty and have a hang of the way the cement setting works in your theater. You know, it's in your theater, and always have a backup plan. As in to do, if your cement leaks, what would you do? If your cement does not go into the screw, what would you do, etc. So have a backup plan. And out of this, this is the most important thing, good AP and lateral CM images. And be very familiar with the system which you use. So in this, we've used a locally made percutaneous system for the screws. So this is how a typical OT setup is. In this, remember, when you are doing vertebroplasty along with cement screws, you have to be swift with respect to cementing technique. So it's very useful to have an assistant or your associate who's familiar with the steps, and he should be able to see the monitor the same way you should be able to see the monitor. So there is a hitch as to if you have those monitors in the C-arm which is mounted on the C-arm, it becomes a bit of a headache. I face it occasionally. Or if you have a separate monitor, it's very useful so that both of you can see the same thing, because you can both work at the same time, thus reducing the cement setting time and trying to finish the whole thing in one pack of cement rather than two. So this is a representative case. She was a 69 or 70-year-old female who has sustained a projectile fall, had a fracture of the D12, which was typically worked up in my practice. We work up all initially for all sorts of secondary pathologies, and we always start them first on teriparatide, irrespective of the surgical indication. So she was on it for almost 2 months, had still persistent pain, was having difficulty in daily activities, and at which point we advise surgery. So when you look at the MRI, apart from these retropulse fragment, etc., it's very difficult to make out the integrity of the posterior wall, etc., in CT MRI. So we all speak of all those things, cement leak, blah, blah, blah. But remember, expect it to leak and think accordingly. All these imaging might not give you a real picture as to what and exactly how the wall will be. And if second, you might have done the MRI at the start of treatment, say 2 months ago, you'll be advising surgery after 2 months. So you might not always repeat the MRI just before surgery. But when you see this whole white on a T2, that means complete marrow replacement with fat. This is a patient wherein if you do a focal vertebroplasty, in my book, there is no role for standalone vertebroplasty in junctional regions. I always instrument them because it has failed for me, including the so-called stenting procedures. They fail in the long term when you have these junctional locations like D12, L1, L5, S1, etc. So I always instrument them. And when I see these white out in the MRI, I always plan for cement screws. So today I moved over to exclusively into cement screws for all these fractures because I want to try and hold them as much as possible with treatment of osteoporosis with teriparatide if it is not contraindicated. So again, I always repeat this image. So you should, when you use a percutaneous screws or plasty, you should look at your index level. Forget the other level. You should not be seeing like this two end plates. You should always see a square in the box. So you should train your CM tech and your OT guy to make sure that he's able to show your index level. Index level is your level which you're going to do the procedure like a box. Now the question comes, sir, if there's a wedged vertebra, which level you choose? So always look at the upper end plate because we are going to target the pedicle. The end plate closest to the pedicle is the upper end plate. So in cases where you have a wedge vertebra, like in the lumbar spine, lower lumbar spine, forget the lower end plate, look at the upper end plate. In thoracic, you can, if the vertebra is squarish, you can get a right box shape end plate. Now, this again, if you look at this, you can see my end plate is, upper end plate is like a box, lower end plate is got double shadow line because I'm more interested in the upper end plate, so I look at that. And just forget the world, look at this box and remember these three lines. Remember the pedicle is like a clock. So when you are doing the right pedicle, you start at the lateral pedicular line at the 3 o'clock position. Point number 1. Once you start there, you in AP, if you look at my CM image and here, I come up to the 12 o'clock position. So the sequence I follow is I do all AP, then go to lateral because AP lateral, it becomes difficult at times for my whole team. So I do all AP, then go to lateral. So in this, I start in the AP at 3 o'clock, come to 12 o'clock, then I go to the opposite pedicle. I start at the 9 o'clock and come to the 12 o'clock. Right? So this is standard for all the vertebral levels. All the vertebral levels, I come there, and after I come there, then I go, this again I mentioned, after that I go to lateral. When I am at the mid pedicular line, I should be just at the posterior vertebral line. At that stage, I go further and cannulate and go into the body. So I'll show a small video. So this is a video with the particular steps taken for cementing. So when I cement, I pedicle both, I do both ones together, meaning I do both AP lateral, then go to the next level. So I'll start the video now. I'll pause in between. So this is it. So I'm trying to see I'm trying to feel my pedicle. So I start on the right of the patient. I'm a right-handed surgeon. The CM is always on my left. Just look at this point. So when I am in these porotic pedicles, don't try to do one-handed show. So I hold with my both hands. I sit on the lateral pedicle and my associate uses a very light-weighted mallet, not a heavy mallet, a very light-weighted mallet. With my both hands, I hold my bark needle and then he hits it. And then I look at this point again. Sorry. I have to, this is a very careful point. So when after I go this line, once I hit the pedicle, so I come to the mid pedicle line, go to lateral. Oops. So again, I'm holding it with one hand. Once I feel it, then I use my both hands. I hold with my both hands, then my assistant hits it. And then at this position, just see very carefully. This is how you have to, the most common error is when you try to remove the outer cannula, outer part of the bark needle, your wire comes out. So if you see very carefully, then a shortcut to pause it. So my one hand is sitting on the patient. I rest my elbow on the patient's body. Can you see? And while I hold the wire with my left hand, slightly pushing it into the bone, and then with the other hand, I remove the wire. And then I twist it and clip it away from my site of interest. The same thing is, so again, I use a nitinol wire and I use the blunt end. I'm just showing that, not the sharp end, because porotic bone, it might just walk in like king. So hold it again, I'm resting my hand on the body and resting it. Then I gradually rotate and there's no fast movement, it will come out. And then you again clip it away from your field. Now this is one pedicle. So this is repeated at all the 3 levels. Now the second level is where I take my index level or my vertebroplasty level. So at this level, I cannulate Again, like skin, I skin and fascia at one cut. And roughly, I know that the back of my knife is the size of the screw. So I just put it. And again, now I'm putting my needle. Again, with both hands, I hold it very carefully. Now I'll take my first C-arm shoot. I make sure I'm at the 3 o'clock because this is the right pedicle. Repeat the same thing on the left side. Cut skin, fascia. And again, I hold the handle with the Jamshidi needle with both my hands, and then my associate heals in. Now, this is it. Remember this point. Since if you are doing both pedicles same time, there is a chance that when you're hitting the right pedicle, the left screw comes, the left needle, left Jamshidi comes out. So when I'm hitting the right one, my associate is holding the other one with his left hand. So when I hit it, it does not accidentally come out. And when I repeat it to the other side, he holds this side. So once I cross the posterior, now I'm coming to the level of place where there is the compression fracture. Here now when I hit it, he will hold the other height. Now here I am preparing for the cement for the vertebroplasty. So here what I do is that I don't put the guide wire. I keep the Jamshidi inside. Then this is a cement cannula going inside. On both sides we have the cement cannula going inside. So I always try and use an index screw. So I try to always cement the index screw also, so that I want a short segment fixation. Same principle which you use in percutaneous fixation fractures and burst fractures. So I make sure my cannula goes inside. Now here I put both my cement cannulas, and then customary, we always try to take a biopsy, try to aspirate that level to see if something comes out, because we have seen some strange pathologies coming out in so-called osteoporotic fractures. So I again see and aspirate. In this case, I got nothing because she has 2.5 months of post fracture, and she was on teriparatide. Now I always use a bipedicular approach because this is known to decrease the chance of cement leakage. So I inject the so-called saline test. I inject and make sure the saline comes out of the other cannula, and I repeat it so that my space is continuous on both sides. Again, I inject here, so it's a continuous space. This might decrease my chance of cement extravasation into the canal. Again, see, I am using the back of my knife, making sure that my space is my size of my inches is intact. Then again, I repeat the same procedure at the lower pedicular level. Use the same thing. Now again, just notice that I rotated the cement cannula so that it does not hit my vertebroplasty. Another small tip which will prevent you from crowding off your J needles. Go again, cannulate the lower level and repeat it on both sides. Again, put the guide wire. So I repeat the same procedure. Now the guide wire going inside, lower level. At this stage, we have not started cementing. We have made sure we have all the wires inside. We have the vertebroplasty needles inside. We have the cement cannulas inside, and then you wire it up. And I dilate and dilate. This is just don't forget this step. Don't forget to use the screw dilator into your dial system, because if not, that simple fascia tightness will prevent your screw from going inside. And remember, this is not osteoporotic bone. You try to push in your screw, your guide wire will migrate. One single dangerous instrument in these procedures is the guide wire, and it is not navigated if you have navigation also. So make sure that you use the cement dilator, the dilator, so that your screw goes in very well. Now, and again, another point here is that when you try to pull out your dilator, your wire might come out. So the tip is that out of the 3 dilators, remove the inner one first, the center one first. I'll remove the center one first, then remove the other ones. Again, always keep holding the guide wire. If you can see the left side, my associate is keeping on wiping the guide wire. A guide wire with a clotted blood is a recipe for your guide wire migration when you put in your instrument. So each step he keeps on wiping the guide wire with a wet gauze so that no blood is dried up on that. And so we're working at both at the same time. Now we insert the cement screws. We keep all the screws inside ready so that I can save my time on cement insertion and using a single pack of cement whenever possible. So typically we can do vertebroplasty at the index level with 6 screws with 1 20-gram pack of cement. So we can save on cost there. in those situations. Now I have inserted, and just look at this. This is a very important thing. When you put in your rod system inside, please remember to incise the upper wound by a centimeter at the skin and fascia, because you will see that if I have done it inadequately, my rod will not go in smoothly. So I keep that incision ready, and like you know, Amit, by packing in gauze pieces into the, because the most common site of bleeding is a pedicle screw site. So I keep it packed with the roller gauzes, and now I have all the 4 screws, 2 upper level, 2 lower level inside. It is inside and all done. Again, I'm making the upper incision slightly more longer. See him wiping the guide wire so that it doesn't dry up. It's a standard procedure for me in my OR. Again, we have all the screws inside. The index level, or the D12 in this case, I've just kept the cement cannula because I'll do a vertebroplasty there and then do the further procedure. If you see, I use Felicitation screws at the upper 2 levels and the regular screw at the middle level, just to decrease cost some few thousands more for me. At the index level, anyway, I'm going to use cement, so I don't need a Felicitation screw at that level. So at the index level, I use 2 regular MIS screws, and at the upper and lower level, I use the Felicitation screws. Next and most important is to for the cement handling. So in this, so once we have the cement in the bowl, then we start the timing, and again remember not to beat it like the way you make an omelette. Just lightly, mix it. So you mix it. My timer is on. You can say timer on. So I mix for a minute, keep for a minute, and use the next minute. So this is the consistency of the cement which I need. And we typically use these lever lock syringes of 3 cc's to put screw into the cement into the screw. But to load them, I take first 2 10 cc syringes, load them like this. This is the consistency. So we both of us have take 10 cc's, and then you can see I use 6 syringes because I got 6 screws. Remember, never more than 1.5 cc per screw. So one level will take not more than 3 to 4 cc's at the max. So this is one. I have loaded my lever lock syringes. So my scrub nurse and my associate, they all load the screw together, and now the cement is ready. Next, we go to the vertebroplasty. So this is it. No, I am. Sorry. So going to the level of vertebroplasty, we both work at the same time. We screw it in and gradually keep looking in the image. We gradually inject the cement, and as we inject the cement, we gradually withdraw the cannula. This will be a very gentle movement because it will come off in one go. You gradually withdraw the inner cannula so that your cement gets more. You start from the far end and come to the close to the near end, and gradually you keep on injecting the cement under imaging on both sides at the same time. And at this level, you inject more than 3 to 4 cc because you're doing a vertebroplasty, not just cement screws. And once, so you can see all my other screws are loaded. You can see all the 4 syringes onto the adapter into the screw, and then I use a plunger, and with the plunger, I gradually drive in the cement. Please keep looking here. It's but not uncommon to see the cement leak into the end plates, into the disc space. Don't worry. I'll show you another level when the cement goes out also. Don't worry all that. So it is not unusual. So again, both sides, we gradually use the plunger and push the cement inside. So this is the index level. Always hold. So the meantime, my associate and my scrub nurse, they inject the cement into the cement screws. You can see the cement filling into the lower screws, how it's filling in very well inside. And they are told that not to use more than 2 cc at each level for each screw. You look at the upper image. You can see cement going into some segmental artery. So initially, earlier I get scared. Now nothing happens. Just go ahead and keep injecting. As long as nothing comes into the canal, don't bother. So that is where I keep. I don't look at the front of the body or the side of the body. I look at the back of the body. So my entire focus is the back of the body, and gradually keep injecting. And once injected, I remove the adapters from the upper screws because I want them to be mobile heads. Then I put guide wire into the the site of the index level where I already injected cement more, or where at the vertebroplasty, and look at my hand is resting on the body, and both of us at the same time withdraw the cannula. Then I tap that level, and then my hole was small, so I just, it's not like strict editing, I just kept part of it to show the have a feel of it. And then I put in the regular screws into that both of those guide wires where we did first vertebroplasty, right? And once we have again the same step, I don't forget to dilate each level because I don't want the guide wire coming out. Remember, in this level, guide wire comes out, you'll be able to put it back, but the cement is setting. You don't want the cement to set, and you don't want to get caught not being able to. So this is another very important step. After you have all your cement inside, you should make sure that all your heads are freely mobile. If they're not freely mobile, you will not be able to negotiate your rod in very well. And at this time, my CM comes to AP. Till then, I'm on lateral. My CM comes to AP just to make sure that, look at this shot, you can see my index level vertebroplasty. And if you look very carefully, you can see the cement going up some segmental artery at the upper level. Because naturally the upper screws, the body is not as empty as the lower body. That's why it did not take much cement. That's why the cement went out somewhere. The lower body took all the cement very well, and the index level took a good amount of cement. At this, again, after this AP shot, again my CM comes out to lateral. I break off the tabs of these particular design which we use. And then look at this. This is the thing which I was telling you. I had taken a slightly longer skin incision at the upper level, but it was inadequate. See, I'm struggling to negotiate my rod inside very well, right? So, and then the machine holds it, and then I use the sound to make sure that my rod is inside at every level. And then I use my, I'm slightly extending the skin because I was inadequate in my first cut. I cut the fascia more, right? And then that lets me, this single step will avoid lot of hazards of trying to seat your rod very well. So at this, I seat the rod into the montage. Remember this step, the first screw I put is the middle screw, because I've seen that makes it more easier to seat the other ones. I don't put the edges first in these kind of cases. I seat my the center one, in this case D12, very well. Then I repeat the same steps, so it is seating very well. All the montage should be at the same line. Then I repeat it at the lower level and also at the upper level. So my assistant holds the rod put, because especially if you're using a lordotic rod, if you keep moving your hand, you will lose whatever correction or lordos you are creating. At this level, it is dorsalumbar junction, so I want it straight. And now I do the final torquing. Remember, I don't use that counter torque because my assistant is holding the rod very well. So I use this. If you are if you're not confident of this thing, then you can use a counter torque. But I've seen that the counter torque takes a longer incision to go inside. So I use it. My assistant holds it, then remove the rod, and after that I break off the tabs at this level, and that finishes that side cementing vertebroplasty. And again, look at the slightly longer incision. Just be very careful. A simple tip which you should follow, which will prevent your struggle when you negotiate your rod inside. Now the next rod goes inside. Again, getting it inside. So if you're using a much longer segment, you can use an aligner. I seldom use it. I use the feel and the hand. Again, using my sound to make sure that all my rod is inside, putting the middle screw first. I tighten it completely. My assistant holds it with the right amount of angulation, and then the lowest screw, and then the most proximal screw, and then there's the most proximal screw. So I get them to keep at least 2 or 3 screwdrivers, etc. Because it's cement working. I want to save on the time. So now I have my screws inside. It is seated very well, and final torquing is done at all the 3 levels, and he's holding it. So there's no, and I break off the tab. I break off the tabs in this particular design. So just get conversant to whichever one company you're using, and be familiar so that you can get out of your problems when you have them. Right, and that is it, and that completes the lateral view, and this is the AP view. Right, now this is the final picture. Look, you can see that the cement going up one of these vessels. Thankfully, she has no problem. I have had them couple of times, but touch wood not yet to have a deficit or where I had to open up again. And this is the final skin suturing. And just tips: ensure adequate visualization and orientation. Have smooth guide wires and light mallets. If you can use the nitinol wires, they are more resistant and they don't bend as much. You set up a sequence of imaging, all AP, then lateral, because you can decrease the lead time in the OR. Stabilize and hold the guide wire and wipe the guide wire at every step. Every step you should keep on wiping with a gauze piece so that blood does not dry on the guide wire. Remember that it is a very small cannulation. So if it dries up it's okay for a young patient, but in an osteoporotic bone, you will not know when the thing migrates anteriorly. And once the tip of the screw is across the pedicle, I remove the guide wire. I don't keep the guide wire till it goes inside. So remove the guide wire and then advance the screw. So again, choose an ideal indication. Ensure that your OR team and you're ready for it, especially when you're doing a cementing screws. So make sure you're conversant, the whole team knows the sequence and they're familiar with cement. So I typically get around 16 to 18 minutes for my cement handling. So I should be able to complete my vertebroplasty and my cement screws within 18 minutes, which is quite satisfactory because I use the same cement in the same OR temperature for every case. So the entire team knows that. You should make sure you get adequate C-arm visualization. And whenever you fail, always have backup plan, because we are doing MIS screws, but you tell the patient that you might have to open up if you have a cement leak or your cement sets in. You cannot advance further. Thank you, and any questions?
Thank you, Dr. Unnikrishnan. I invite questions from the audience.
Hi, Dr. Ranjit. Excellent presentation again. So, few questions. Monopedicular versus bipedicular entry. Like in my practice, initially I was using bipedicular, now switched to monopedicular. I have not found any difference. What is your take on that?
So I was initially monopedicular, went to bipedicular now, because when I found that, see, if you are using an index procedure or you start something after giving teriparatide, I have found that after giving teriparatide, there's some amount of healing happening. So my cement leakage or my pressure is more when I use a monopedicular approach. So when I went to bipedicular, that has decreased. I get a more easy flow. And anyway, I'm going to put a screw in that particular pedicle. So why not have two pedicle axes? That's my logic for that.
Okay.
I seldom do any standalone vertebroplasties now. I hardly have any case where I do only vertebroplasty. All need screws, whichever my indications are.
Yeah, that was my next question. If there is no kyphosis and there is a classical Camel sign where you see the defect, even in those cases, would you instrument?
Yeah, so the patients where the so-called classicals, where you have only no PLC injury, are the patients who will heal very well with teriparatide. You don't need a vertebroplasty for them. So the ones which really, so my workflow is that any patient I see of osteoporotic fracture, I have a CT, MRI, X-ray, day one. I don't take a DEXA because DEXA is, you have already osteoporosis. Why do you want a DEXA, right? Then I see for electrophoresis and all secondary causes. And if I see a PLC injury, if it is a junctional region, I tell that there's a high chance you might need surgery. You might have to take an earlier call. So nobody, generally they don't accept first day. So I start on teriparatide. If I don't see it's at the L3 level or at D8 level, I tell them, well, very poor chance, very less chance you will get surgery. We'll just treat the medicines and they heal. The ones where I see a PLC injury, the ones are junctional, are on my radar. So they are the ones which go in for surgery. And those are the ones when I did standalone vertebroplasty, including the so-called stenting, they fail. They fail meaning the patient doesn't complain, but my X-ray showing still kyphosis. I think, what did I achieve? Spending so much money and did that thing and it is still bending. So whereas if I yet to have a case where I did vertebroplasty along with cement screws which failed because of the junctional location. It has failed because of the disease, not because of my fixation.
And the philosophy of cement in an index case and the screw above below versus cemented screws, making it more rigid, would it cause more chances of adjacent segment fractures?
Very good question. Very good question. So the rigidity is at the segment, at the upper to the lower vertebra. I use a index screw or nose screw, the rigidity does not change. Does not change. But I was exploring the same thing. So our classical teaching or our understanding was that osteoporosis instrument long, correct less.
Yeah.
Right? When you do short segment, it fails. Right? So extrapolate the fracture philosophy where we started using index screw fractures in traumatic burst fractures, and that decreased our fixation level. I applied same thing in osteoporotic fractures also. I am using index level screw and cementing it and putting screw there, so I don't have to go as long as I should go where I should go earlier. So I have used those. I have come to this concept right now that I use the same levels which I would use in short segment in a normal trauma, but I put cement and screw same level.
Yeah, that sentiment is fine. My question is above and below cemented screw, like in all three.
I have not seen at least in my nearly. I mean, I'm using this almost in 6 years now. I have not seen any of them fail because of this screw at the level. They failed where there are to start with multiple level fractures. That I started treated medically, and D2 L1 was one of the component. So in those cases, what I do is that I go long, but I don't put screw. Say I'm going from D10 to L3. So I put 2 screws at D10, 1 in D11, 1 in D12, 1 in L1, 1 in. Now I stagger them, but cement them all. It's my index decision to start with that I'm going to go long, not a decision which happened because of my extension after surgery.
Just last question: a maximum amount of cement in a fracture level. What is your average amount of cement in the fracture level?
So a screw never more than 1.5 per screw. At the plasty level, does not go more than 5 to 6. It takes 3. Okay. So typically what I use is I have this syringe which is 3 cc, right? So when I try to inject in first, 0.5 cc goes into the track. So they stop at 2. Vertebroplasty, I use 2 full 3 cc on both sides. Okay. So it comes to 5 to 6, not more, never more.
Thank you so much.
If I try to go more, it leaks out.
Thank you, Dr. Ranjit. Thank you for joining from distance and enlightening us.
Thank you, sir.
I will now invite Dr. Janil Gurnani for the last lecture of this session. He's a neurosurgeon with special interest in minimally invasive spine surgery and endoscopic surgery. He's going to talk on posterior cervical foraminotomy in minimally invasive technique, a very interesting alternative to anterior cervical microdiscectomy.
Good afternoon, friends and seniors. A big thank you to Rakesh sir and Venus Hospital team for inviting me to this platform and to this beautiful program. My video presentation is on posterior cervical foraminotomy, whether it is a gimmick or a solution to all our problems. As we see, the routine cervical disc prolapse, ACDF has been a gold standard for cervical disc prolapse since a very long time, but the disadvantage with it is that it fuses, has ASD and approach related complications. But the advantages of it is it removes disc, there is no recurrence, and it is gold standard time tested. Can be done with or without instrumentation. Disc replacement is a slightly newer phenomena where the entire disc is removed. The advantage is that it is motion preserving in selective cases, but the disadvantage is the cost. As we see in ACDF, removes disc and removes the motion. Disc replacement removes the disc but preserves the motion. So the solution to this in selected cases is posterior laminoforaminotomy. It is a posterior approach. It is motion preserving, no instrumentation, can be done either by an endoscope or a tube. I am using a tube currently. The disadvantages is that there is limited case selection, theoretical risk of recurrence, venous bleeding, and some patients do present with an axial back pain, neck pain. I take the patient on either a 4-pin or I prefer Mayfield or a 4-pin for a short neck patient and a gel headrest or a horseshoe for other patients. The disadvantage of using a gel headrest in a short neck patient is that inadequate flexion is achieved. can be used in cervical disc herniations, which is lateral to the thecal sac, cannot be used for central herniations or myelopathy. Selected cases with predominant radiculopathy, this is a good procedure. No need of implants, a shorter hospital stay, and minimal post-op pain and wound complications. It has no anterior approach related complications like dysphagia, voice problems. This is a 39-year male with a right-sided radiculopathy for 3 months, had tried multiple therapies, right-sided shoulder weakness of 3/5 and a deltoid wasting. There was no signs of myelopathy. We did a posterior cervical microdiscectomy with this. As we see, I'm using METRX dilators, an 18 mm port, microscope, and a Midas Rex angulated drill AA14. There is a disc herniation you can see here. As we see, there is a right-sided foraminal disc and a small fragment that is impinging the right side nerve root. This is the most important slide. You see, I'm standing on the right side. This is the cranial part. This is the caudal part. This is medial and this is lateral. The aim is to drill the lower part of the C4 lamina, the upper part of the C5 lamina, and some amount of the facetal complex. And the aim is to make this V into a U. This is the anatomy as viewed at the same level from the tubular retractor. A small incision that is almost 2 cm long for an 18 mm tube is used. The incision is almost 1 cm, 1.5 cm parallel to the midline. One point to remember is that the cervical muscle is multi-layered, so don't just plunge in with your dilator. Use a blunt finger dissection, then dog the tube. Then use the dilators and then dog the tube. Don't plunge in directly with a first dilator. I don't use a K-wire currently. The position as we see is parallel to the disc space. A small sliver of muscle, which there is always a small sliver, you can either use it with a sponge holder and or you can use it with a Bowie cautery. We have exposed the lower part of the C4 and the upper part of the C5. This is the C4, C5 facet joint. I'm using an angulated Midas Rex 14 mm drill with a cutting burr. You can either use a diamond burr. There is one important point to note that irrigation should be done, and secondly, the flaval anatomy is different as compared to the lumbar spine. The flavum is thin overall, it thins off very quickly, and there is a very limited foraminal extension. So when you drill the lateral part, there is a high chance that you can injure the nerve root. As the nerve root in the foramen is uncovered, the flavum is not present as present with the lumbar spine, so even be careful with your kerrison. I always use a 1 mm upcut in cervical, no other size I use. One important point to note that the disc in the cervical disease like this is always either in the axilla or it is just under the nerve root. There is no concept of a shoulder in a cervical foraminotomy. You can see that this is the lateral border of the thecal sac. This is the nerve root which is under pressure. Generally, venous ooze is present in such cases, so you can use a bipolar at a lower setting. One more important point to note that this is the caudal pedicle here. You can feel the caudal pedicle. This is the cranial pedicle here, which is not under vision. The nerve root is actually hugging the caudal pedicle. So in certain cases where the disc is huge and the root is under tension, you can drill some amount of caudal pedicle to free the nerve root and cause less manipulation of the root. I put in a small roton dissector under the axilla and try to remove a fragment of it. You can see the fragment coming out. A small fragment has come out and a large fragment will now be delivered. You can even use a blunt hook to pass under the nerve root or the lateral part of the thecal sac to remove the fragment. Pass a hook or a dissector circumferentially to release all the adhesions so the fragment comes out en toto. You can palpate the nerve root all along and see if it is free. There is always epidural bleeding, so it is wise to either use a Surgicel or a small Abgel. Initially I used to instill some steroid, but I have stopped currently. The working port is removed and you can see all the muscle layers beautifully coming up. Complications. K-wire induced complications, but I do not use a K-wire currently. You can put a dilator lateral to the, and cause injury to the vertebral artery lateral to the facetal complex. Wrong level, when your neck is flexed, make sure you take multiple CM, else you will migrate either cranially or caudally. The other general complications include 2 lateral or 2 medial drilling causing instability, venous bleeding, root injuries, and if no fragment is found, please check the date of the side and check CM. It is a safe and effective strategy in selective cases. Ideal cases, soft lateral disc herniations with only radiculopathy, disc osteophyte complexes. In certain degenerate cases, you see there is a lateral osteophyte that is causing radiculopathy. You can confirm it with a nerve root block and then cause a foraminal deroofing. Hence, it is a great procedure with motion sparing, lesser hospital stay and minimal blood loss, early return to work and a smaller incision. Thank you.
Thank you, Dr. Janil. I invite questions from the audience.
So my question is, do you do a CT scan routinely?
Yes.
Because a lot of times the disc is calcified.
Not in soft disc herniations, but in slightly middle-aged patients with disc osteophyte complex, I do get a CT scan, especially at the foraminal cuts.
Given a choice for any particular case, you will prefer this or ACMD?
Sir, depending on the patient, if it is a young patient, 25-year male with just a radiculopathy and acute onset disc herniation, I will do this. Because the question with ACDF, it always fuses, and a disc replacement, it is a recent procedure, costing is very high of the artificial disc, and there is a question on it if it actually moves in a longer run.
No, why I ask is that I could see that you have removed only a small fragment of the disc and then you close the procedure. So this is a very sure chance that there is going to be recurrence because the annulus is still open behind that.
But sir, the amount of disc in a cervical spine is very less. So there is a chances of recurrence, but literature says that the chance is almost close to 5 to 7%, which is actually the same for a adjacent segment disease in an ACDF. The reherniation rate is not as high as lumbar spine in cervical spine because the volume of the disc in the disc space is less as compared to the volume of disc in the lumbar spine.
Have you encountered hard disk during surgery with a lot of epidural bleed? What is your strategy at that?
We just did de-roofing of that case and instilled some local steroid. That was that. We haven't, if the patient is still in follow-up, there's one case like this, the patient is still in follow-up. If he has problem again, I'll go for an ACDF.
We have usually seen a lot of epidural venous oozing during this procedure. What is your experience for that?
Yes, sir. There is a lot of venous oozing, especially when you de-roof the foramen. The solution to it is patience using a small cottonoid and bipolar at a lower setting.
Okay, thank you, Dr. Jainil.
Now we'll invite Dr. Chandan Mohanty to talk on IDEM, Intradural Extramedullary Tumour, Excision. Welcome, Dr. Mohanty.
Thank you, chairpersons. Thank you, Rakesh Bhai and the entire Venus team for this kind invitation. So, slides. कुछ मिररिंग करना है क्या? Sorry. So, my mandate today is to show a case demonstration of an intradural extramedullary tumor excision through a tubular retractor system. So, I'll straight away go to the case and not spend too much time on theory, rather have time in the end for discussion. So, this one was an 18-year-old girl who had presented to me with 1.5 month history of heaviness of a leg, and basically had presented with a picture of spastic quadriparesis, asymmetric, left side affected more than the right side. She also had a right median nerve neurofibroma, which was excised about 10 months back by me. So she is a known case of NF1. You can see that this is a large dumbbell tumor at C5, C6, which is encroaching into the canal with a very big extraspinal component as well. In addition to that, you can also see that she also has multiple neurofibromas elsewhere in the body. So she had one near the occipital condyle, one in the T6, T8, T10 region. The other one is presacral, another one is at the lung apex, and multiple over the peripheral cutaneous nerves. So the intention of so once you see a patient with neurofibromatosis 1, the usual counseling which I do to these patients is that I always tell them that you are dealing with a disease which creates tumors. They might be benign. In 1 or 2% cases, there is chance that it might become malignant and become a malignant peripheral nerve sheath tumor. So I always tell these patients, considering the age, you have to prepare yourself that you are going to have some kind of surgery every 2 years to 3 years. You're going to have a tumor which is going to grow, and as and when it becomes symptomatic, we are going to treat that. There is no point being excessively radical in these cases, because preserving the function is the primary aim. Because she is going to have more tumors. She already has a lot of tumors in her spine and the paraspinal regions, and they have to be counseled correctly so that the expectations can be managed. So this patient, we basically did a C5 and C6 MIS laminectomy. This was, we did it under intraop neuromonitoring with SSCPs, MEPs, and free running EMGs. The incision was standard, about 0.5 to 1 centimeter from the midline. I did a slight cranial direction for this to access the C6 better, and then just to wand it inferiorly and get access to my C7 lamina also. So I'll just show the video. So that I can run it faster at places. Okay. So after standard docking, doing a muscular dissection with the finger and then using the smallest size dilator, not using the K-wire as shown by Janil and previous speakers as well, we basically expose at least so before I'll just orient everybody. So you can see here, okay, fine. So this is the cranial, this is the caudal, up is the medial and the low is the lateral. So I'm standing on the left side of the patient. This is a left-sided approach. So this is the cranial, this is caudal, medial, and this is lateral. So it's the same steps you have to do. So in fact, you have to think it of as a three-part surgery which consists of a hemilaminotomy, then a contralateral decompression, and then the third part is the tumor excision after opening the dura. So I use the standard 3 mm Anspark drill cutting. So you have to be careful that the ligamentum flavum, as was pointed out, is thin in the cervical spine. And once you reach the inner cortical margin, you can switch over to using a small size kerrison. So once you see the ligamentum flavum, you can start using your punch. So you use the smallest number 1 kerrison punch because already you are dealing with a cord which is sick and you don't want a bigger instrument with a bigger footprint indenting into the cord. So once you start doing your ipsilateral hemilaminotomy, take it cranially, complete this level. Sorry. So once the ipsilateral hemilaminectomy is completed, as you can see here, the same way was described by Dr. Ranjit in the morning, that you have to tilt the table, tilt the microscope to go to the base of the spinous process so as to access the opposite side lamina and to drill the undersurface of the lamina. We know that the tumor is on the left side, but the intention of doing this laminectomy on the contralateral side, so we are turning the table now. So the intention of doing the contralateral decompression is to create the space for the cord, because remember the cord is pushed to the opposite side even though the tumor is towards me on the left side. So we need to create space for the cord. So during a dissection or any maneuvering, there should not be any cord injury. So it's important to create enough adequate space before you go ahead and start doing your decompression. So this is now me drilling the base of the spinous process, going to the contralateral side. So that is now the lower part of C6 there. So I basically drilled a small part of the facet joint, but not too much, not so much to create an instability. So this is the next level, cranial level. So essentially the aim was to do a 2-level laminectomy from the ipsilateral side. So we expect a lot of oozing. Once you drain some of the CSF, the epidural veins will start oozing. Once the tumor is removed, after the dura is closed, you expect oozing because suddenly all the epidural spaces open up. So you have to be prepared for that. I think once you are prepared to what are you going to expect intra-op, half of the battle is won there. So you can already see the bulge of the tumor. This is the part of the tumor which is going into the foramen, into the brachial plexus in the front. So again, I'm wanding. So basically, I put the largest dilator which I have used and just change the direction. So this is not a Medtronic. This is an Indian company which I had used for a demo case. Advantage of this is that it's a expandable tube here, and it's expandable in all the 4 directions. And obviously it is economical as well. So again, I'm completing the laminectomy of the cranial level. So I'll just run through all this. So once this is done, I think, just take it back. So this is my exposure. I can see the root, the cord is pulsating. I'm ready to, my 2 levels are complete. The scope is tilted to that side. So as I told you, anticipating the bleeding is important. We put a pledget of gel foam all around the dura. This is standard practice, but it has to be followed whether you do it open or whether you do it through the tube. As you can see, I have not expanded the tube too much because I believe that expanding the tube too much is actually sometimes counterproductive. And if you read the recent papers by Roger Hartle and et al., they actually say that opening up the tube too much converts an MIS surgery into a mini open surgery and not exactly an MIS surgery. So I make an incision on the dura along the fibers of the dura. So that's the normal horizontal, that's the normal vertical cut. And then you will see that I make another cut which is perpendicular to it. So I make a T cut in the dura. It's a shape like a letter T. So this T cut is basically along the axis of the growth of the tumor. So it allows us to follow the root along which the tumor is growing. So this is all expected. As soon as there will be release of CSF, there will be oozing. You have to be patient, but you have to have a clean, dry field before you go inside and start doing your surgery. Otherwise, continuous oozing from outside can just make it a very frustrating procedure. So this is the T cut, which I was talking about. So this cut is basically along the direction of the root there. So once that is done, now important part is that we are predominantly going to see the tumor and the root, which is going to be mostly underneath or either moved up or down. The reason I do not put sutures and pull the dura on the other side is that I keep the cord protected from the instruments that are going to come in and out. Another important fact that you will now see, which is different, is the fact that this entire surgery is a bimanual surgery. You have to use your 2 hands. So I think an MIS, intradural extramedullary tumors, is still one of the last true indications where actually a tubular system scores over an endoscopic system because it allows you to use your 2 hands to do a tumor excision, especially in tumors like neurofibromas, which arise from the connective tissue of the nerve fascicles rather than a schwannoma, which arises from the Schwann cells and makes it easier to remove it without damaging the nerve. So that's a tumor there. We're coagulating the surface, trying to shrink it. Shrinking always helps the tumor. We have monitoring, so I am confident what I'm doing there. Shrinking also helps to create some planes which you can later exploit. So we always go ahead and do this intratumoral debulking. So tumor is sometimes vascular, so again that is along the expected lines. You also expect bleeding once you take a fragment from the foramen because of the veins, which would again open up after being under compression for such a long time. These are all expected times where you expect bleeding in the surgery. So we dissect, and then again, one more advantage of this is that I'll be using one instrument. So I start using my CUSA. So the CUSA basically is a cavitron ultrasonic suction aspirator. It basically breaks down the tumor with ultrasonic energy, irrigates the field as well as applies suction as well. So you can excise the tumor. You can see I'm making a cavity inside the tumor so that it allows me to pull the periphery into the center and make a good plane around it. So the CUSA helps in removing the tumor without putting any traction on the tumor. So again, this is not possible with any of the endoscopic systems. It's again a blessing of the tubular systems. So once the tumor is satisfactorily debulked from the center, we do a piecemeal excision without being too hasty, without trying to pull and try to get a big chunk out, even though it feels that it's almost ready to pop out. It is not, because it's still attached to the root. So there is a proximal part and the distal part of the root to which it is still attached. And those two rootlets will have to be cut before you take this tumor out. With the monitoring in our hand, that will allow us to know whether it's a sensory root or a motor root with the free running EMGs. So if it's a motor root, it will get stimulated. If it's a sensory root, it will not get stimulated. So you do this step-by-step piecemeal excision. So here I'm buzzing the distal end to which the nerve is attached. You can see the nerve root is exiting from that part. So you notice one thing, you haven't seen the cord yet. The cord will be seen at the end. So again, this CSF, this flow of CSF again tells us that we have got the pole of the tumor. We have been able to mobilize the pole of the tumor. Again, no pulling. I like to use the CUSA to debulk it completely. Once that is done, you see that root which I'm cutting now, which a rootlet from which the tumor is arising. So this is the distal end of the root from which, so I'll cut this and detach it from the distal rootlet. You can see the other normal roots here, all coming into the field one by one as you start debulking the tumor. Once that is done, it's still attached cranially to the proximal part of the root. That has to be separated. You can see that the entire root appears swollen. This is in sharp contrast to a schwannoma, where the root will, or the nerve, affected nerve will not be swollen. It will be pushed and thinned out. So that there I'm cutting it, yes. So that's the fragment out. You can see the blood, which I was telling you from the foramen. As soon as I remove the tumor from the foramen, there is going to be some oozing. You have to be careful that you do not coagulate the root there. So here you can see the affected root that's being taken out. So after you remove the tumor, it's important just to inspect everything. Now you can see the cord in view. You can see that how I'm changing the orientation of a microscope to look up and down. Need to make sure that there is no fragment or a nodule of the tumor which is left behind. I'm not going to plan and remove the foraminal and the extraforaminal part from this surgery. If at all the patient becomes symptomatic for that, she will require an anterior cervical posterior triangle approach to remove that. So this tumor is mainly to treat her quadriparesis. So the target is and was the intraspinal component of the tumor. So once that is done, there's an important part which many of us are always concerned about. Hemostasis should be perfect. Always a nice sign to see that there is no smoke in the water. It's all clear. So a signal to start closing once the tumor is out. You can see this entire cavity here. So I'll start suturing the dura. For dural closure, I use a 5-0 PDS. It's about a 9 millimeter needle. You can see it's quite easy to suture the dura. You do not need any specialized equipment. So the suturing is in real time. So that gives you an idea how much time it really takes to suture the dura. So this is just a long bayoneted needle holder and forceps. You can do multiple things. You can do an extracorporeal knot, just if it makes it easier. There have been description of laparoscopic knot pusher to do suturing. All that can be done, but usually it's not necessary. It's quite easy, so you can see it's just very easy to take this thing. You always have the option to expand the tube in case you feel that you're not able to maneuver the needle properly. So that is one advantage of using an expandable tube. But yes, suturing is definitely much more easier in a tubular system. And I think that is one of the major advantage of a tube over an endoscope. So same, I'll be closing the T on both the ends. I don't aim for watertight closure. I just put sutures to approximate the dura. So once that is done, I'll just show you. So again, this side also sutured. So what we use is a hemo patch. So hemo patch works both as a hemostat as well as a dural substitute, forming additional barriers. So once a hemo patch is placed, I would do a kind of a double glue technique where we put glue now on top of this. Then we put a sandwich of Surgicel and gel foam on top of that. You make sure that you're not squeezing or pushing it down, it's just placed over it. So once that is done, so there are two layers of glue. So one is first hemo patch, glue, Surgicel gel foam, and then glue again. And then again, rest of it is standard, but again, cannot emphasize the importance of closing the fascia properly. I think importance of fascial closure is critical. It's a 2.5–3 centimeter incision for a cervical laminectomy. So let me just go back to my slides. So this is the post-op. You see the whole tumor is out. There is no pseudomegingocele or any CSF pocket which is formed. This is about a 2-month-old scan. You can see that some tumor is there in the foramen, but as I told you, we are not going to chase that because she's going to have more tumors in the future, and we need to be sure that we protect her function. So this is a CT which we had done. I was just a bit concerned as to how much of the facet I had drilled because the facet and the foramen was quite thinned out by the tumor. So you can see that large part of the facet is preserved here. So we have done the C6-7 and a little bit of C5 partial laminectomy, as you can see from the CT. So it comprises of, actually if you think about it, this surgery is a revision of all that you have, all the lectures that you have heard in the morning. about the quadrant and importance of doing decompression in quadrants and completing the decompression ipsilateral, contralateral, removal of the flavum. The only additional steps is obviously the dural opening, removal of the tumor, and then doing a dual closure. So I think this is the main advantage of MIS tubular systems in intradural extramedullary tumors. I think for intradural extramedullary tumors, I think endoscope still has some distance to cross, because bimanual dissection is possible only with a tubular system in a dry field or an air medium, not under fluid medium. You can use your CUSA, you can expand the tube in case you are not able to suture the dura, but dural suturing is also quite easy, as I showed you in the scans. Thank you.
Thank you, Dr. Mohanty. I invite questions from the audience.
How many meningiomas you have removed this? Is there any strategical difference in the operative planning when you are doing this meningioma?
So
by MIS?
Yeah. So meningioma is kind of a bit of a challenge. If I do a meningioma, I make sure that I don't do a meningioma which is more than 2 levels, and for the meningioma to do it MIS, I have done meningiomas only which were located posteriorly or posterolaterally. I have not done an anteriorly located meningioma, obviously, with the tube, because you need to go around. You have to have a margin bigger than the tumor as far as your decompression is concerned, and it just becomes so. Even if it's like a 3-level meningioma, it just becomes cumbersome to do 3 levels with a tube. I just prefer to do it open. I can do it in half the time.
Dr. Mohanty, for this particular case, an injured tiger is more dangerous. Similarly, a half-removed tumor is more dangerous.
That is why I spent some time on the concept of neurofibromatosis. This is a very well-known concept of neurofibromas, that you do not go chase and remove each and every bit of the tumor. The problem is in the neurofibrin gene, which is going to produce tumors. So there are many tumors. You would have seen this large presacral tumor that she has. She has a tumor in the occipital condyle, which has just started eroding her spine.
No,
so all of them will require excision.
That's right, but see, you don't chase all tumors, but the one which you chase, you have to kill it.
No.
You don't just injure it and come out.
No, so the main...
That's what, otherwise it's 100% going to recur there, and it's going to be a bad second surgery.
Yeah. So typically it will not recur because I have excised the root. That's why I showed you that I cut it proximally and distally. So it is not going to recur there, but it can grow further along the course of the plexus. That I agree.
No,
it can grow along that.
I don't agree. The root is not the source. There is also blood supply which is going to allow the tumor to grow. So you have not taken care of the blood supply.
So sir, the whole issue is that if it is extraplexal, how are you going to remove the extraplexal tumor?
That's why this approach for this tumor.
So you have to do an anterior and posterior approach.
No, for this particular, I'm just talking of this case. The technique is very good, and it is very good for certain tumors which are just pure single neurofibromas or schwannomas. But for a patient with NF1, when you are removing half of tumor by this technique, it's not the...
Sir, I would actually differ.
It is not the accepted norm.
I would actually differ because there are many protocols which have showed that NF1 should not be treated aggressively. The aim should be reversal of deficit and not tumor excision. If it is a solitary NF, if it is solitary NF, the patient does not have NF1, then absolutely I'll go ahead and do it anteriorly also.
Even by MIS also, in this case, you would have taken out all the tumor through the same incision.
No, sir, this was going in the front. This was basically going into the lower plexus. So it was affecting the lower quad also. So it was basically sitting on the apex of the lung. So it was gone into C8 and T1 roots also. So it would not have come. So I have to take the rib out and then do basically what we do for lower cord injuries.
Nice talk, Dr. Mohanty. just one question. You always suture the dura, especially for the IDM, or you use clips also for the closure of dura?
Yeah, so we can use clips or we can suture. Both I have done both. This case, because it was a T cut, it was a bit difficult. And the problem is that when you put the clips, you basically obliterate that part of the, so there is some dural loss, and that I did not want to do that, especially because the cord was already compressed. So, but you can do both. You are absolutely right.
Anyone from audience? And I think.
Thank you very much, Dr. Mohanty.
Thank you, sir.
And with this, we conclude the session. And I think any more questions we can have a later on. Thank you.
Yes, sir. Sir, but before that, I would request you to hand over mementos, sir. So first, Nimesh Patel, sir, would present a memento to Vikrant Pujari, sir. I request Yashish Dalal, sir, to present a memento to Janil Gurnani, sir. हाँ सच बोलूँ છું આના પછી Thank you, sir. Requesting Dr. Prakash Moda, sir, to present a memento to Dr. Chandan Mohanty, sir. And thanking all the speakers and chairpersons to keeping us awake in this post-lunch session. Thank you, sir. We are breaking for a tea break, small tea break for 10 minutes. welcoming back everyone after a brief tea break. I hope all of us are now awake for the next session. This is a short one. I would request the chairpersons for the next session, Dr. Deepak Patel sir, Dr. Sandeep Shah sir, and Dr. Bhawmit Thakur sir. Kindly join us on the stage, sir.
Now we invite Dr. Amit Jhala to talk on MISS unusual indications.
Okay. So from morning we are talking about a lot of cases on MIS. So whatever is left behind I will try to cover. So nothing is unusual. I think everyone is doing everything. So I'll just put 4 or 5 cases which I have done. So it will just for completion of whatever is left and which can be taken care of by an MIS way. And after I think a good coffee, everyone will have be alert. Okay. So they are just collection of some cases that I'm going to present. So the first is unusual indication, something about lumbar disc prolapse. So we have talked about the extraforaminal approach, we have talked about the paracentral approaches, the up migrated, and I think you showed one axillary disc also, right? So one of the indication that we have, he's a 40-year male, had a low back pain, right lower limb claudication. Of course, all the things which are positive for the disc prolapse. And this is the disc prolapse which is there. So this is an inferiorly migrated disc. It's at the level of the pedicle, inferiorly migrated. And that's what you showed, that you have to go to the axilla to remove this disc. So there can be some approaches for this. So the disc is actually, if you come from the shoulder, you cannot reach that place. You have to go into the axilla if you want to reach that place. And this is either it can go up migrated from the lower disc or it can be down migrated from there. But the level is at the pedicle level. The fragment is at the pedicle level. So if you see, this is known as a hidden zone. This is known as the hidden zone because it is hidden by the lamina. It is covered by the lamina. Usually what we have is you go to the shoulder, you retract the nerve root and then you get it. So this disc is usually in the hidden zone. And as you said, either you have to go from below up by doing a complete laminectomy and remove this fragment, or come from up, remove this part of the lamina and come down. So this is how you have to approach this fragment. Okay. So what we did again was a tubular. But tubular directly, it was a translaminar discectomy, so where you don't need to come from up or down, or just targeted discectomy, come at the pedicle level. You dock the retractor there at the lamina. So, and then you burr and make a small hole directly in the lamina at the pedicle level. So our normal usual docking of this is somewhere here. We don't dock it at this place. Then if you want to come down, it becomes very difficult. So if this was a migrated fragment, so you just burr it down and make a very small hole around 5 millimeter and go directly translaminar. So that's what, it's a burr hole like what you do in brain. So it's a burr hole and directly there'll be no ligament. There'll be directly epidural space. And once you reach the epidural space, you will see there'll be no nerve root or nothing will there. except the epidural veins you will be able to see. And you retract it, and that's the retraction, and directly you will find out the fragment. So this is one of the easiest way that you can remove this disc fragment, where you don't need to go, it's a large fragment which is coming out. So this was one of the things which was remaining in our talks. So this is what the fragment is, and which comes out. And there are so many 2 or 3 fragments which were there, which was a large one again. And you check whether there is no other fragment which is remaining or not. And then that's the root, and you can see a gel form which I have packed there. So that is one of the approaches that you can have. And if you see, then it's a very small hole directly, and it is known as a translaminar discectomy, which can be done. So this is another, that's a post-op MRI of the same patient with complete clearance, which is shown there. Another case, a similar case, but at a higher level. This was at L4-5, this is at L2-3. And again, the fragment is at the pedicle level, and that's where the fragment lies, which is again an inferiorly migrated fragment. And what you do is a similar type of a docking at the pedicle level, and then you just make a small hole there. You might have to extend it a little bit. And that's where the root is. You can see very nicely the axilla here. You can see the dural sac also, the axilla, the exiting root also there. And the fragment is lying in between the two. And you can excise that fragment. So this is just for a completion that you can have such a disc prolapse, and that's one way of directly doing it without doing a complete type of laminectomy. And you can see very nicely, this is the exiting root. You can see that it is very well cleared off, and that's the dural sac. So that was the fragment. And just to show the post-op, the amount is around 4.9 millimeter of drilling that we had to do, and this is the hole which was done. So this is the level. Coming to similarly from lumbar region L4-5 to L2-3, now coming to the thoracic disc also. So thoracic disc also is slightly unusual not to get, and it's also difficult sometimes to do it. The only thing is that again this patient had got a large thoracic disc at the level of D11-12 from the L1 to L2-3 last time. Then this is D11-12, which is a central disc. And now if you want to approach this disc, either you can go from back and laminectomy, and it's very difficult, you know that it's dangerous to do and retract the cord at this level. Or you can do a facetectomy, and then you will have to fix and fuse it. The other approach is either a thoracotomy approach, which we were doing way back to approach this central type of this there. And the third is a LECA approach. LECA is something like a Transkambin that I showed in the morning. So it's a LECA approach. So this will give you more angulation, and you can have more clearance there. So we tried to do this with the LECA approach, where the docking is quite lateral, like an extraforaminal docking which is there of the tube. And then with you do have a 15 degrees of obliquity of the image intensifier, and then dock at this foramen, and then from there you directly enter into the disc. So this is what we did. Of course, we had to fix this patient. We have not damaged the facet, but still we felt that we should fix the patients, and then we fixed it. And you can see that's the D11-12, and you can see a very good clearance of the D11-12 disc there. So that's the pre-op and the post-op showing the clearance. And you can see that this central part is totally normal, and we went from there. Coming to spinal tuberculosis from disc, post cervical was already taken, so I have not taken nothing more in cervical to show. So it was there. Coming to spinal tuberculosis, again, what the approach is the same. 40 years male, had a D10, 11 tuberculosis. So this is where the patient had a tuberculosis, severe pain. The patient did not have a deficit, but there was an abscess there. So you can see that there is a posterior, the prevertebral and right, left-sided abscess which was there, which is seen here. You can. So we also thought about similar LECA approach there. We did a posterior percutaneous fixation, and then the dock in the foramen directly, extraforaminal directly with the tube. And this is from the extraforaminal approach. We went into the disc and got a pus there, which was removed. And then this enters into the disc space and complete clearance done. Removed all the muck which was there. You can see a lot of granulation tissue, and then that's the complete clearance, and then you put in the graft as usual for this from the tube, and that's the graft which is completely packed there, nicely packed anterior grafting, and that's the clinical picture. Similar tuberculosis now coming at the lower level, but then there is a kyphosis there, and then at 54321 L12 probably the level. Again a similar type of thing, but then we had to create, because there was a kyphosis, there was a kyphosis there, so we actually recreated the lordosis there. We opened up the disc space, and then with the help of the tube we did. So that was a laminectomy which was done there, facet was removed. So it was like a TLIF approach that we did. And that's the all tuberculous material which came out. And we cleared the vertebra, the debris from there. The point is that tube can do so many things. Wherever you have a lesion, you can just have a targeted approach, and that's a grafting again there, done. That's a graft which is there. So that's the pre-op, that's the 6 months post-op, a very nice correction of the kyphosis which was there, all by percutaneous way. Sometimes we have a lot of issues of cage. Once there is an infection in the cage, then how to remove the cage. And it's a big problem sometimes to revise from the same area and to remove the cage. It's a very big problem. So this was an infected TLIF. This was an infected TLIF where there was a cage which was loosened. The CT scan shows that there is a halo around the cage. It was sunk inside. So when it is sunk inside the upper or the lower body, it's quite difficult to remove that cage out. So we did posterior fixation as usual because this patient required a revision. So we did a posterior fixation, but then we went with a lateral approach. So it was a lateral approach, and with the lateral approach, this is the tube which is going, this is the actually docking that shows the first dilator, which directly goes through the K-wire inside the cage. You dock at that level, and then you remove the cage. It's very easy to remove the cage by MIS way without entering into the spinal canal, without damaging the dura, and you can just remove it. And the reconstruction also is very easy from there. Okay, so that's the cage which was removed, and then we put in a mesh cage, reconstructed with the mesh cage, and then because it was infected, we had used stimulant in this case. So a stimulant was put along with the graft. So, and that's the follow-up of this patient. And that's the CT scan, which is 1 year CT scan, which shows a very nice fusion which has been fused in all the three planes, axial and all the three planes. So that is one of the indication where you can use the tube from lateral approach to do this procedure. Benign spine tumors, they also, of course, intradural was shown, so this has no value now. But still, you can use this benign spinal tumors. So this is a patient of an osteochondroma. So it was a C7 osteochondroma in a 35-year-old female which had a right-sided involvement. You can see that was the osteochondroma, which is there. And in the CT also, you can see the osteochondroma coming from the facet joint. So we used expandable ones, the tubular retractor expandable ones in this case. So we did a laminectomy as was shown. So we did a laminectomy. We thinned out the lamina, and then, so that's the thinning of the lamina, that's the central midline, that's medial, that's inferior, that's superior. And then we started doing a laminectomy from the medial side, because the whole facet, the osteochondroma is arising from C6-7 facet joint. It was going anteriorly. So from medially, we tried to remove the lamina and tried to come laterally. So this is the midline laminectomy, which is there, hemilaminectomy, which is there. So we burred it, made it thin. So that was part of the bone which was over the osteochondroma, which was removed. And once that was removed, you will see the tumor. So that is what is the tumor. This is the whole osteochondroma, which is in front of the facet joint. So that was the osteochondroma which was removed as a one piece, and that's the dura and the nerve root, which is quite free after that tumor removal. Okay, that shows the probing by the hook, that all the spaces are free. That's the post-op CT. This is where we went. That was the pre-op. That is the post-op, showing complete removal. And you can see that's the pre-op, and that is the post-op. And that was the 3D CT, which shows this is amount of laminectomy that we did to remove that tumor. And that was a biopsy report. So you can do this tumor removal also. So that's another patient, a 14-year-old boy, had a history of fall before 8 months, got a neck pain and right arm pain, was treated like a trauma for 8 months. That patient had a trauma, and the patient had a night pain, daily requirement of analgesics at night. Neurologically normal, except that there was a pain. And this was the X-ray. Now if you see, this is a CT, and that you can see it's an osteoid which is arising from C3. So that's an osteoid from C3. And we did, this was with a 16 millimeter. So that is the facet joint line. This is the V, what was shown in the by the previous speaker. That's the inferior lamina, that's the superior lamina, and that's where the midline is. So we started burying and removing that part. We did a laminectomy there. And we exposed, this is the part of the tumor which is there. the osteoid we had to free the right sided C3 nerve root. So we are opening up the foramen, and that's the foramen, that's the root which is seen there. Patient had that pain in the right. So that's the root, which is seen very clearly. And that's the pedicle. So the whole root is cleared from the foramen to the pedicle. And this is where, as I showed, this is where was the osteoid and that is what was removed. So that was the bone which was of the tumor. So we completely removed it. So that was free. So the root was totally free from all the angles. So that's it. Coming to some metastatic lesions. You can have metastatic lesions which are there. These are for palliative surgeries. That means the patient has a metastasis, has been given chemotherapy, has been given radiotherapy, but still they have a severe radicular pains and they want a focal removal. So this is a patient, you can see that was a lesion there which was pathological lesion L3. Biopsy was already proven, mucinous adenocarcinoma there, and RT was taken, no improvement, CT was taken, no improvement. And then you can see that there was a tumor which was localized to right side. So it was a localized tumor to the right side. So it was a palliative surgery which was undertaken. I'll just skip it forward because we can just do a decompression there and removal of complete tumor. So we just removed the tumor and then filled it with again the docking was at the pedicle level because the pedicle was involved. So the docking here was at the pedicle level, we burred the pedicle and went into the body and then curated the whole body from there. You can see that's the root, and this is where the dural sac would be. We measured the gap which was there. We did not put anything, but then we put in the graft there. There was nothing like this. We just put the graft there and came out. So, and that's the post-op, 6 months post-op. The patient was doing well. There was no pain. Of course, the patient is in the follow-up of the oncophysician, so it does not come to me regularly. And this is one of the last case which I'm going to show. It's a foreign body removal. This is a patient was operated for TKR. And then while 48 hours after, they had to remove the epidural catheter. And the catheter they inserted, and after 2 days while removing the catheter broke inside the epidural space. And there was no complaint of the patient, but then it was discussed with the patient whether to keep it inside or whether to remove it. And the patient opted, because there are reports also that you can keep this catheter unless there is any issue. But then we thought that we should remove anything which is there should be removed. So this is the X-ray. MRI did not show anything. So if you get an MRI of this epidural catheter broken, you will not see anything. It was just seen because of the radiopaque line, a very small radiopaque line which is seen there. So that is where it is seen. This is a very small catheter, which is anterior actually, lateral and anterior there. So whether to do a complete laminectomy or what, so we just did a tubular one. And we removed this catheter with the disc. I think this video should, this is a video. And you can see that with the help of the tube, we did a foraminotomy and removed the catheter. And the catheter was around 10 centimeter. Thank you.
Thank you, Dr. Amit, for having excellent presentation of unusual cases. The house is open for any question answers.
Sir, do you do any open cases?
I do.
Maybe since we have some time left, you can say, I mean, some few indications of open cases.
I do definitely open cases. There's no doubt about it. But whenever possible, my 80 to 90% practice is MIS.
Any specific indications to straight away go for an open surgical access?
For an open surgical access.
You see a case and you say this cannot be done with MIS.
Everything, I think most of the things can be tackled by an MIS. The big problem is the cost factor that we have. So if there is a adult deformity, then you require multiple levels. We can do multiple levels with the MIS also, but then the cost factor is so high that sometimes we have to open these cases. Of course, all deformities I open. So anybody knows that I am I'm doing a lot of deformity every Wednesday. So all deformities I definitely open. There is no MIS role for the deformity corrections, pediatric deformities. So that's all.
Similar questions like, how many times you do surgery without implant?
Oh, so many times. I am one of the surgeons who would not like to put the implant.
The newer generation, like whenever we, since last 5 years, we see any conferences, even any disease, usually the implants are there.
Yes.
So if you can delineate, because we have learned from all,
So I would say that most of my discectomies, unless in the morning there was a controversy. So if it is a central disc, like it was a manual labor central disc with a large annular tear, then only I will put the implant and fuse the disc. Otherwise, all paracentral disc, anything which is there, I just do only a discectomy. I am not doing a TLIF for all the discs which are there.
Right.
All the stenosis, unless there is an evident, there can be hidden instability which is very difficult to find out. But if there is an evident instability, then definitely fusion. And that too, if it is a stable listhesis, then also I don't fuse. If it is grade 0 to 1, then only I just do an MIS fixation. MIS decompression over the top, and I don't fix it. So these are the indications that, as far as possible, my mentality is that when not to use implant.
Right. Because
that's it.
What about cervical lateral masses?
Yeah, okay. So open cervical laminectomies, I don't put lateral masses. I don't put fixation in all the cases. So I just do a laminectomy many times.
Dr. Rakesh.
Excellent talk, Amit bhai. So this kind of cases do require, apart from experience and skill, fearless nature, innovative thought process and patience. Anytime you have struggled a lot while doing MIS, or at some point of time you might have thought that I could have done it open. So any of that experience?
Initial, definitely for any initial procedure, when I started the MIS, when I was doing so many, my first discectomy took 3.5 hours. So, and that time I was doing in 20-30 minutes one open discectomy. And then I had to convert. So it took 3.5 hours for me. So there are frustrations. So then when I went to over the top decompression, so many times you feel that, you see, it is not easy. Everyone feels that over the top decompression, it's easy, but there is a lot of patience which is required to go to the opposite side, to go to the contralateral inferior root. So, but you have to have persistence and patience that no, I have to do with this only. So that is gradually cultivated rather than frustration is always there. When you start anything new, there is always going to be a frustration and there is always going to be an apprehension. But ultimately, if you have a conviction that I want to do it with this way, but then you have to invest a lot in time. You should not be in a hurry if you want to start any new procedure. If you don't have time, you cannot progress.
Thank you. Okay.
I'm also using MIS for the cox spine. Probably I have done 40 cases by MIS. The destruction of the body, which is above and below, is significant. It can be tackled. Half above body and half below body is taken care. I'm just putting the graft. But do you suggest a long segment fixation posteriorly, or you manage only one level above, one level
Always
below?
2 level above, 2 level below.
But does it
Because what happens, it's a paradiscal lesion. So if there is a paradiscal lesion, the upper vertebral body is half. If it is destroyed, that screws are not going to be good for a purchase. You can get a purchase, but you cannot rely for a long time. Right. So that is where always in tuberculosis, most of the time 2 levels above, 2 levels below.
You have never thought of putting the cage or expandable cage from the laterally?
In any type of infection, whether it is tuberculosis or whether it is pyogenic, I just put a graft. Unless the gap is such, like I showed one case, the gap was that much that I cannot rely on a long graft. So if it is a one vertebral body with 2 discs involved, the graft cannot work. But if it is just a paradiscal lesion with half vertebral body, the graft is going to work. So it depends how much the anterior reconstruction that you have to do.
Thank you, Amit bhai. Now we call Dr. Anil Patil for MIS lumbar discectomy complication.
Thank you, Rakesh, for allowing me to present at 11th hour. Actually, 2 days back only I decided that I will attend this conference. The reason behind this, because I'm presenting the same topic before Rakesh, because he is going to talk on the complications. I am the 12th man in before the 11th man with the water. Now, complications in MISs. I tell you that in last month I did 7 of the TLIFs, and out of these 3 got complicated very badly. So I thought that I will come in the community so that my morale, which has gone down so much, will come up. So are the complications of the MIS are same as conventional surgery? Almost same. It is the discitis, recurrence, battered nerve syndrome, nerve root syndrome, cage dislodgement, malposition, screw malposition with or without nerve root injury, and the dural tear. Fortunately, in the MIS, the dural tear is not a big deal. In last 12 years, I have experienced a dural tear almost more than 40-50 times. In the early phase, it was too much common. Now the incidence is very low. But as the muscles are prolapsing very nicely, you just put the gel foam on that dural tear and it will be taken care of. About the discitis, the incidence has reduced significantly, and untoward MIS complication. I think in last 12 years I have faced only 4 discitis cases, whereas I reviewed my own cases from 2005 to 12, that is in 8 years. For the open surgery, it was almost more than 10% or 5 to 7%, 5 to 10% was the incidence. In the early phase, it was more. Now, this is one of the discitis case which I am presenting. 40-year-old diabetic housewife with left-sided L5 radiculopathy not responding to any conservative treatment with MRI, as below. There is a central disc. Now, this disc can be an indication for TLIF, but I decided to go for the simple discectomy and decompression of the nerve root with lateral recess decompression. In the beginning, patient was doing good for 1 week, and then she started symptoms in the form of severe backache, spasm, and increasing bilateral lower limb pain. Early conservative treatment considering the possibility of recurrence of the disc. So I continued the conservative treatment, but it was not responding, and the repeat image was suggestive of such a big lesion here, which was obviously suggestive of infection, and this patient was not having any fever or malaise or other parameters which are suggestive of infective etiology, except severe pain, increasing radiculopathy, and the spasm. I went for the contrast MRI, and contrast MRI is showing so much enhancement. She was tossing in the bed. Now what to do? You can conserve with the antibiotics. You can explore and debride. You can explore, debride, and fix. You can explore, debride, fix, and fuse. So I decided to explore. This is the video. As I opened it, I got a pus over there. It was 27th day from the surgery. I could take out that pus and infected disc. So this was a combined picture where first decision going for a discectomy by incising a annulus in a degenerated central disc. Considering that, I will take out the maximum disc and decompress the nerve root, which is symptomatic. But that disc was prolapsed the moment she was given the sitting position, and on the top of it, it got infected. I have decompressed it adequately, taken out all the infected disc material which was lying behind that nerve root and behind the thecal sac. It is tedious job. You have to be very patient, polite, and not to catch the dura or the nerve root while taking out this material, because as the time passes, it is very adherent to the nearby structures. I could do it. We have debrided the disc space. We have given a thorough wash with the betadine, and then obviously with such an infection there was no question of fusion. We have to consider not to put any additional things over there. So we have just fixed it. This was the percutaneous fixation, and on the 7th day, patient's pain was gone. She was able to sit, and on the 10th day she was discharged, and I could sleep comfortably. Now judge complication, next complication happened in this video. This also happened unfortunately last month only. So putting the cage is not easy, and taking out the cage is not at all easy, because taking out the cage is always associated with some injury. So what are the options available, or what tricks you can do to remove this cage? or this patty rather, because it is behind that cage and you cannot take it out. Pull patty forcibly, never, because only the hanging part and the thread will come out, patty will remain with the cage. Try to distract, you have already distracted maximum. So you cannot distract anymore. Do the osteotomy, there is no space remaining to do the additional osteotomy without retracting the nerve roots. Reverse hammering is very difficult because there is no space to impact your, but you have to do same thing, or you have to convert it into the conventional, and still it is a difficult business. I could reverse hammer it and take it out, but obviously while coming back that has injured the exiting nerve root and patient had deficit. Fortunately they have not complained, and now it is almost more than 50% of the added deficit has recovered in last 2 weeks. So MIS is not easy. Since morning, those who are sitting behind, they are having lot of dreams that I will become a MIS surgeon and it will be a very easy ball game. But at the end of 12 years, I think that you have to be very cautious and spend a lot of time to learn with your good bosses. Otherwise, it can create a lot of messes. Thank you. I have reversed the hammer. I could do it.
Now we call Dr. Rakesh Luhana for the closing lecture, the MISS complication and management.
Good evening, everyone. Thank you so much for attending it and showing a lot of enthusiasm in discussion. So we'll present last talk of the day, minimally invasive spine surgery, complications and management. Every time I present this talk, I have to pass through bad memories, difficult times, but it is essential to learn how to avoid and how to manage. So just basics about MISS. Since morning we are hearing about it. So I use tubular system and microscope in all cases. X-tube, quadrant and matrix, these are all tubes I have. Usually my majority of cases I do it with 18 millimeter matrix tube, and quadrant I use. Oh, it's not advancing there. Okay, so yeah. Okay, and I use 14 millimeter tube for a classical discectomy. We do multi-level canal stenosis. This is a patient with a 3-level canal stenosis with a small tiny incisions, and next day patient can go home. MIS TLIF, we routinely do it. Facet synovial, this is contralateral approach, approaching from opposite side. This is T12 intradural tumor done in MIS way, primary dural closure excision, and this is post-operative. This is beautiful post-operative MRI and with little footprint behind. But along this journey, I faced few complications. At times I have failed in planning. Majority of times the failure is during execution, which may be while docking, while decompression, while fixation or putting a cage, and there are some unfortunate post-operative complications as well. Very important is complication avoidance. So plan your cases properly. The diagnosis has to be right. There has to be a good clinico-radiological correlation, and there has to be robust indication. Getting complication in a gray zone or a doubtful indication is the worst thing you can face. And the surgical option has to be right based on your competence. Whether you would do tubular MIS, interlaminar endo, transforaminal open, which is varying with your own experience and expertise. This is a case where one had failed in planning, like severe canal stenosis with a congenital narrow canal at 3 levels, and young enthusiastic surgeon beginning of MIS practice and doing it MIS, ending up with a bilateral foot drop and very poorly done surgery. So this has to be avoided at all costs. Grow gradually in your learning curve. Sharing my cases, this 65-year-old lady with a back pain following a trivial trauma, tenderness over mid-dorsal spine, neurology was intact. The patient came to me with this MRI, it was in contrast MRI, which showed a lot of enhancement and prevertebral enhancement. Thought maybe malignancy. We got a PET CT also lighten up that area, and that said that early fracture cannot be differentiated from malignancy. So we are not sure whether we are dealing with osteoporotic fracture or a malignancy. I decided to do a biopsy with a 2 above, 2 below fixation. The biopsy came negative, treated as osteoporotic fracture. Immediate post-op picture looks good. 2 months patient was fine. And then 2 months later, she came back with a severe back pain and difficulty in walking and had an implant failure. So we had to revise it. So we placed the vertebroplasty cement, extended 1 level above and 1 below. So eventual result is good, but looking back, probably maybe only vertebroplasty would have been enough, or just an anterior reconstruction with a short segment would have been a proper choice. So your planning has to be right. Next case, 38-year-old gentleman with a neck pain and right upper limb radicular pain for almost 45 days, severe excruciating, not responding to conservative management, and MRI shows classical right paracentral foraminal disc herniation with a significant compression. We took him for surgery with a plan to do MIS, posterior cervical laminoforaminotomy. And then when you put a first dilator, it should have been stopping here, but it went straight here. And that scared me, took it back and repositioned it. When I went in, I realized that the usual interlaminar window is very narrow, but unfortunately this patient had a congenital anomaly and there was wide interlaminar window, and probably my dilator went through this. Revised it, did a discectomy, post-op, right arm pain relieved, but unfortunately patient developed grip weakness, which improved in next 48 hours, but patient had hypoesthesia in perineal region and left thigh. He had sexual dysfunction, which lasted for almost 6 months. And there you can see post-op MRI showing good decompression, but there is a signal change. So the lesson is beware of wide interlaminar window. First dilator tube must be under CM guidance or use your finger as a guide, and you have to be vigilant at every step. Third case, 62-year-old gentleman with a leg pain, severe claudication, dynamic X-ray, no instability. MRI showed severe L3-4, 4-5 stenosis, with a disc herniation, very tight stenosis with added disc here. So my plan was to do a MIS 2-level decompression. I started first case, serial dilators, 18mm tube under the microscope. I started a decompression. It was a very tight canal with a thin dura. At one point, while taking a ligamentum fleum, the dural tear occurred, and there you can see the noodles nerve root came out. I tried to put the nerve root back in, head low. I told anesthetist to put apnea, but because of tight canal, it's not easy to put the nerve roots back in. Realized I could not put the nerve root back in. So I tilted the tube away from the dural tear area and tried decompression. So ipsilateral decompression has been started, ipsilateral lateralysis, and then ipsilateral foraminotomy was done, ipsilateral decompression was confirmed, and then ipsilateral discectomy was also done. Then we went over the top, and the dural tear area was covered with a abgel and patty. And then once we achieved complete decompression, it was easy to put the nerve roots back in. Then I used DuraGen. And the TCL glue was done. So whenever this kind of large dural tear, try to put the nerve root back in. You can use head-low transient apnea or low volume ventilation, cover with abgel and patty, continue surgery away from the site of the tumor, site of the tear. Make sure you don't pull out any nerve roots. Primary suture, you can do it as and when possible. You should do primary suture, or you can use DuraGen or glue. If it's struggle, you can change to larger or expandable retractor, or maybe convert to open. Minor dural tear like this, it's more forgiving. What we use is a muscle patch. Like this is the device that used by ENT for a tympanoplasty, and that converts muscle patch into a beautiful patch like this, and then I put it over the tear area and use a glue. And next case, 75-year-old lady with a long-standing back pain and claudication, and L4-5 severe stenosis with arthropathic facets, dynamic X-ray showing instability. She has an osteoporosis, which we put her on teriparatide, and later we took her for surgery. Plan was to do L4-5 MIS TLIF. Everything was going well. We placed opposite-sided screws, ipsilateral K-wire, disc prepared, and while putting a cage, I was trying to push it more, and then the cage suddenly became vertical like this. So there was no way I could retrieve it, and that scared me. So patient was hemodynamically stable. We completed posterior fixation, consulted a vascular surgeon, arranged 3 PCV, because at times in prone position patient may be stable, but as soon as you do supine, they decompensate. So we arranged all this and turned her supine. Fortunately, vitals remained stable. We kept her in ICU under observation. Next day we got a CT angiogram. Fortunately, the cage was sitting between aorta and IVC. And we consulted senior and mentor and colleagues, and then decided to retrieve it with a retroperitoneal approach. We retrieved it and placed it back, and this is post-operatively. And it went uneventful later on. 3 months follow-up, it healed well, and the cage placement must be under CM, and we have to be careful while disc preparation and cage placement, especially in osteoporosis. Next case, 36-year-old lady with acute lumbar radiculopathy, not responding to medical management, and she has severe big disc herniation with significant root compression. We did MIS right L5S1 discectomy, Surgery was uneventful, but she woke up with a complete loss of vision in her right eye. Urgent ophthalmology reference was done, and he noticed retinal opacity, cherry red spots, retinal arterial attenuation, and optic disc pallor, and concluded that it's a central retinal artery occlusion. Ocular massage was given, oral Trental, mannitol, methylprednisolone started. Fortunately, her vision started recovering in 6 hours, and at 6 months, 90% recovery noted. So the lesson learned, its prone position is at risk for CRAO. Avoid extraocular pressure, avoid hypotension. Early detection and treatment could be the only salvage option. If you lose that 6 hours window, vision loss may be permanent, and the risk of vision loss should be included in a consent. Next case, a 66-year-old lady with a significant claudication, and we did MIS 4-5 decompression and L5S1 decompression. Post-operative patient was fine for 48 hours. 48 hours later, she developed urinary retention with a left foot drop. And when we got an MRI, we realized that there was a hematoma at L4-5 level. We re-evacuated, and she recovered well over 3 weeks. So hemostasis is, you should always take care, and because there is very little window, the hematoma of small amount also can become symptomatic. Next case, 43-year-old lady with a right lumbar radiculopathy underwent L4-5 discectomy somewhere else, and then she had a recurrent disc 1 year later. We tried conservative management and didn't help. So option of right redo discectomy versus TLIF was explained. Patient didn't want recurrence, so we went ahead and did a MIS TLIF. Post-op, she woke up with a right foot drop. And then we got a CT. We realized that both my screws were going medially, L4 and L5 both. So we had to revise both, and fortunately her foot drop recovered at 6 weeks. The lesson we learned, you have to make sure that you should be little medial, as Dr. Ranjit mentioned, that you should not be crossing midpoint when you reach to the base of vertebral body. Next case, 63-year-old gentleman with a severe canal stenosis and claudication, MRI showing severe canal stenosis. We did MIS decompression. At a small dural tear, till this time I was thinking that in MIS one can get away with a small dural tear, but unfortunately this patient developed a meningitis, and later in this post-operative MRI showed good decompression, but CSF confirmed meningitis, and that required 3 weeks of IV antibiotics. So try to prevent dural tear, and if it happens, if possible, repair primary, or else use muscle patch, glue, or Duragen, as I explained. Every time you cannot get away with a CSF leak like this. Next case, a 68-year-old gentleman with a acute lumbar radiculopathy, and MI showed L4-5 far lateral disc herniation. We did MIS far lateral discectomy. It was uneventful surgery, but post-op patient developed left lower limb monoparesis. I could not explain why from far lateral patient to develop monoparesis. Was confused. We waited till evening, but that deficit did not recover. So we got MRI local. That suggested that it's well decompressed. We did whole spine MRI, did not find any cause. So thought, let's get MRI brain. MRI angio brain showed normal MRI angio brain with a small hit, but this should not explain the monoparesis. So we get a local CT, and that showed that there is a small hematoma. That it was not too bad, but then we got a CT angio. We realized that the patient had an unfortunately diseased vessel, and there was acute abrupt cut off there. And then we relook at it MRI, and that showed that my track of disc forceps went right there, and probably that hit it. So at L4-5 level especially, the root vessel is very near, especially when you do far lateral. If your tube is docked little medially, then your direction of instrument may be going laterally. So that's why shift your incision disc tubular lateral laterally, and the direction should be like this. And then that required a laparotomy with a vascular surgeon. We did, and there was huge embolus, and that required distal thromboembolectomy. By this time, patient developed compartment syndrome, so iliofemoral bypass with bilateral fasciotomy. So minimally invasive turned into maximally invasive surgery, but unfortunately that also could not save the patient. We lost that patient. Patient had acute renal failure and we lost him. So keep in mind vascular complication, they are rare, but it can happen. Early detection and early intervention could have saved him. And the last and recently we are going through this patient, very interesting case, a 38-year-old lady, overweight, acute left leg pain for 3 months, unable to stand or walk without pain, limping while walking, SLR positive, left THL EDL grade 3, dynamic X-ray negative. MRI showed left paracentral 4-5 disc, was not too bad, so we decided to conservative management failed. So we did a MRI pelvis with lumbar plexus, could not find any cause except that L4-5 disc. So given a left L5 root block, patient had a transient relief for some time, and then she came back with a left foot drop. So there was no choice, but we had to intervene. We did left 4-5 discectomy on table. The nerve root was turgid, inflamed, and compressed by granular disc tissue. Post-surgery, remarkable improvement. On foot drop movement, recovered on day 1, independent walking day 1. 2 months later, came back again with excruciating left leg pain, unable to stand or walk without support, again foot drop. And we got an MRI. Plain MRI showed excellent decompression, but on a contrast MRI you could see significant enhancement around the root, perineural fibrosis causing a neurological deficit. Options: should we conserve, pain procedure, surgery, should we fuse or just do a redo discectomy? So we did left L5 root block, that again failed, no improvement, so we had to do a redo surgery. We did redo MIS left L5 foraminotomy, and on table the disc was intact this time. The nerve root was adhered with significant fibrous tissue around, so we did nerve root decompression, extensive irrigation, perineural steroid, and placed the drain. Post surgery again, complete relief of pain, foot drop recovered immediately, went home next day. And this time she underwent obesity surgery, lost 25 kg of weight over the next 6 months, did well for 6 months, and again same symptoms. And this MRI also showed plain MRI showing no compression there. So we did left L5 root block that gave relief for 3 months. 3 months later again severe left leg pain, left foot drop. MRI with contrast showing significant perineural fibrosis and enhancement. No end plate changes, no infection, dynamic X-ray, no instability. We did redo foraminotomy. This time we searched the literature, discussed with senior colleagues, but could not find adequate answers. So we decided to use this silicone patch. So after doing a proper foraminotomy, placed this silicone patch around the root. And remarkable recovery, leg pain completely relieved, foot drop complete recovery, very happy. And I thought that's an end of story. This time we continued anti-inflammatory for almost 3 months, and we thought before she becomes symptomatic we will get one MRI. We got MRI at 3 months. You can see no any compression on plain MRI, but again contrast did show enhancement, but patient was fine, so we were waiting. And 5 months later again severe left leg pain with a left foot drop. An MRI with again severe significant enhancement. We did a root block, tried hyaluronidase injections, research literature, very few cases we could find, so, and it's failed. So what to do next? Anyone? That would not give answer, sir. So we researched literature, found couple of cases where they said that do a fusion and probably local movement may be inducer for fibrosis. So we did MIS TLIF, post-op again leg pain 0, foot drop near complete recovery, numbness in left L5 dermatome, and now hope and pray that the story ends here. I'm not sure, this just 2 weeks ago we operated. And with this we would end the talk as well with take-home message. MIS has a long learning curve and one will have to progress gradually. Try to prevent complications by all means. better patient selection, detailed planning, perfect execution, proper post-op evaluation and follow-up protocol. If any complication, don't hide, identify early and tackle as soon as best as possible and try to learn from others' mistake. That was the basic purpose of presenting this talk. Thank you. This is MISSAB. Do join us.
Thank you.
Vascular injury. Vascular injury was the toughest case. This was one of the radiologist's childhood friend's father. And for that far lateral disc, I did not explain much complication and majority of the work was done by radiologist. He said कि थई जैसे कोई problem नहीं होगा ऐसा then. But then with this event happened, so you have to take it. I explained that, see, because of probably atherosclerosis vessel, there was no on-site bleeding. We could not identify it. So that was the toughest, very difficult to counsel. If this kind of complication happen, then I think rather than you, it all depends on patient's family and relatives. How would they take it? Like loss of vision, loss of function, loss of life. This all depends on patient's relatives. Somebody would take it, pretty mature relatives, and at times they would, make your life quite miserable. So it all depends.
Is there anything special that you do to prevent discitis after discectomy?
That is a good question. To prevent discitis, one thing is perioperative, preoperative sterility. And see, multi-specialty hospital would have higher rate of discitis because probably your same theatre is being used by a gynec, general surgery. In my theatre, apart from no infected surgery is being done in my theatre. So touch wood, for last 10, 11 years, no discitis, zero infection rate. So just a sterility, copious irrigation, everything like disposable drapes, no reuse of materials.
And by chance, suppose if you come across a case with maybe post-discharging after fusion surgery, at what point would you decide to remove the implants?
So with titanium implants, one can leave behind implant. In fact, there are, even in pyogenic cases, I have done fixation. So now with stainless steel implant, yes, it was a protocol that you have to remove implant. Nowadays, with infection, in fact, stability would add to the fusion and stability would help in relieving infection. So nowadays, fixation has become indicated for a discitis. So early intervention, early fixation would make him heal better.
Okay, thank you.
Thank you.
Just a minute, sir. Thank you, speakers. I know everyone has to leave, but before that, I would just request Dr. Bhumit Thakur, sir, to felicitate Dr. Anil Patil, sir. He has to leave, sir. Thank you, sir. And I would request Dr. Deepak Patel, sir, to felicitate Dr. Rakesh Luhana, sir. I would request Luhana, sir, for the vote of thanks.
Thank you so much, everyone, to attend. Formally, I would begin with thanks Dr. Amit Jhala, sir, President MISSAB and MISSAB for giving an opportunity to organize. Along with that, SAG, Dr. Subir Zaveri and Dr. Hitesh Modi to help us organize this event. With that, SON, Society of Neurosurgeons, Dr. Sandeep Shah and team, and NSSA chapter, Dr. Prakash Modha sir, and NSSA to help us to give an association in this meet. And I would thank our sponsors, Paras and the Trion Pharma, and Vishal and Globus Medical. I would thank our Utkarsh and audiovisual team for an excellent job. 3 rounds of applause for excellent audiovisual. And Anubhuti Event Management and Anjali Madam for excellent event. I would thank Venus Hospital, my hospital, for supporting us, and my spine team, Jinil, Ankit and Vinod for a good show. And also thank Surya Palace. And with that, thanking all the faculties and delegates to make this event successful. Thank you so much. And Ortho TV as well for live streaming this conference. Thank you.
Just a note that all the delegates and faculty kindly collect their certificates from the registration desk. They are ready at the desk. Faculties come here. Yes, okay. That will be.
Hello. Yeah. Faculty and delegates, please join us for a group photo. बोला है ना भारती को?